Sir, another last minute, which then we all will be live. We are live now. Over to Dr. Sanjiv.
Hello. Good evening, everybody, and welcome to this second day's proceedings of the course. Yesterday, we had a very eventful and fruitful academic discussion with some excellent talks. And I think we will continue with the same spirit, and we look forward to some very exciting sessions. We have actually 4 sessions today, and all of them are, packed with high quality lectures with invited speakers, both national and international. And I think we look forward to a very exciting day today. I'll request Dr. Shekhar to take hold of the proceedings and start the session for the day.
Good afternoon, everybody. Now I invite our esteemed chairperson to start the session, Professor Subrat Kumar Acharya. He is the Executive Director, Gastroenterology, Hepatology, Fortis Escort Hospital, Okla, and Pro-Chancellor, KIT Bhubaneswar. Dr. Avan Agrawal, Senior Consultant, Apollo Hospital, Mumbai. Dr. Sanjay Goja, Director, Lead Liver Transplant HPG Surgeon, Narayana Specialty Hospital, Gurgaon, India. And Dr. Ramdeep Ray, Chief Liver Transplant Surgeon, Consultant, HPG Surgery at Apollo Hospital, Kolkata. So I'll request our chairpersons to invite the speaker and start session.
Well, good afternoon, friends, ladies, gentlemen, and all my co-chairperson, Dr. Nagral, Dr. Goja, Dr. Ray, and all the eminent speakers. Indeed, it's a privilege and great opportunity to listen to such eminent people who has done so much of work with so much of knowledge and immunosuppression, which is the in thing and which is the most important thing following any solid organ or any transplant. I must convey my deep appreciation also to the organizer, Dr. Sanjiv Saigal, and he always does exciting work and exciting singing, exciting album, and exciting academy. Thank you, Sanjiv. So kind of you. And I see Shekhar as a budding, brilliant hepatologist under his guidance. And nice to meet you all. Without wasting time, we know how immunosuppression is important, or is a major determinant in long-term outcome of all organ transplant. I will first invite Dr. James Fung, who is also very well known. He's a young man, but he is the first transplant physician trained in Hong Kong. And he is a consultant hepatologist as well as gastroenterologist in Queen Mary at Hong Kong, which is the most famous hospital in the region. And he has sentinel work in this area in the transplant hepatology. And we are all eager to listen to him. Dr. Fung, please. Thank you very much. And it will be a great privilege to learn from you. Dr. Fung.
So thank you to the organizing committee of the Transplant Hepatology course for inviting me to participate and speak on the topic of long-term impact of immunosuppression. I have no relevant disclosures. So when we talk about the long-term impact of immunosuppression, this is really a testament to the efficacy of immunosuppressive therapy in preventing rejection and preserving graft function so that patients are surviving longer and therefore are susceptible to the long-term effect of immunosuppression. And when we refer to the long-term impact of suppression, we are usually referring to its detrimental effects, which can be divided into class effects which is the overall effect that can lead to the development of opportunistic infections and also de novo malignancies. Then there are these specific drug effects which are inherent to each class of drugs, which includes the calcineurin inhibitors, which may cause renal impairment, metabolic syndrome, lead to osteoporosis. The M2 inhibitors can lead to renal dysfunction with proteinuria, metabolic syndrome, of course, and also interstitial lung disease. Steroids, well-known adverse effects, including osteoporosis and also a metabolic syndrome. Now, I have put operational tolerance as a query here, but the achievement of operation tolerance is probably not directly related to the use of long-term immunosuppression. So I will go through each of the components in the next 15 to 20 minutes or so. Now, this table shows you the common infections in solid organ transplant recipients and stratified by the different time periods after transplant. The types of infections in the early post-operative period are largely related to complications from procedures, such as catheter infections and also wound infections and so forth. When you go beyond the initial perioperative period and into the long term, the immunosuppression that is usually reduced to much lower levels, and the risk of infections become less, although likely still higher than the general population. So the risk of infection decreases with increasing time from transplant, and other complications such as malignancies will become more common. Now, with long-term immunosuppression, the infections most commonly observed are the typical community-acquired pneumonias, which can occur in a significant proportion of patients after transplant. And the common bacterial pathogens include Streptococcus, Haemophilus, and also some of the atypical pathogens such as Mycoplasma. Now, liver transplant recipients are also at risk of influenza, which occurs at a higher frequency in all solid organ transplant recipients when you compare them to the general population. And if in fact they're more likely to get complications, and therefore yearly vaccination is still recommended and is effective. However, the seroconversion rates, of course, are lower than the non-transplant individuals, and breakthrough infections can still occur. For late viral complications, herpes zoster is probably the most commonly reported infection. And we talk about reactivation of hepatitic viruses such as hepatitis B and hepatitis C. This is rare nowadays with the use of highly effective antiviral therapies. Now, another commonly observed phenomenon after transplantation, of course, is renal impairment. And from this earlier study of almost 70,000 non-renal organ transplant recipients from the US, you can see that chronic kidney injury is very common after liver transplant, with 50 to 60% having stage 2 to 3 after 5 years, and a cumulative incidence of up to 25% for stage 4. And when you look at the incidence of chronic kidney failure in liver transplant recipients, you can see that it's higher than heart or lung transplant patients, despite probably needing lower doses of immunosuppression. Now, this may be multifactorial, and the post-liver transplant renal function is affected by pre-transplant factors, including pre-existing chronic kidney disease, and also the occurrence of hepatorenal syndrome, and also acute kidney injury, and also in the perioperative period where there's a risk of developing acute tubular necrosis. And finally, post-operatively, of course, with the use of long-term immunosuppression, and also the onset of diabetes and hypertension. And all of this cumulatively will result in what the final kidney function will end up to be. Now, on the left side of this slide is a diagram shows you the pathophysiology of CNI-induced renal impairment in both the acute and also the chronic setting, and the effects on the different compartments, including the glomeruli, the arterioles, and also the tubulointerstitium, ultimately leading to a reduction in renal blood flow and also the reduced GFR. Now, the chronic changes with long-term immunosuppression includes interstitial fibrosis, tubular atrophy, hyaline thickening in the arterioles, and also glomerulosclerosis. And on the right side is a summary of randomized controlled trials and also meta-analysis looking at the effects of different immunosuppression usage on renal function. And essentially, non-CNI or delayed CNI use is associated with an improvement in renal function in these studies. Now, rather than these immunosuppressive agents having any direct favorable effects on the kidneys, it is likely that the improvements observed is a result of lower CNI dose or CNI minimization. And as liver transplant recipients are living longer, perhaps one of the most notable consequences is that more and more will have underlying metabolic syndrome, including obesity, diabetes, dyslipidemia and hypertension, and also post-transplant metabolic syndrome arises in roughly about 40 to 60% of liver transplant recipients, which is roughly double that of the general population. And on the left side, you can see the incidence of metabolic disease prior to transplant, the risk factors with these diseases, and the post-transplant incidence, which is generally higher than the pre-transplant levels, especially for diabetes and also for hypertension. The risks for the development of metabolic diseases are multifactorial, and these include genetic susceptibility in patients with pre-existing metabolic diseases, the presence of sarcopenic obesity, and of course the effects of immunosuppression, of which steroids, CNI, and mTOR inhibitors are really the main culprits. Now, this slide shows you the proposed mechanisms as to how these three agents can promote the development of metabolic diseases acting on the various different organs. For instance, hypertension can occur as a result of increased vasoconstriction, reduced vasodilatation, and also reduced sodium excretion. Diabetes can occur as a consequence of reduction in glucose uptake by the adipocytes and also the myocytes, increased glucose production within the liver, and also a net reduction in beta cells in the pancreas. Now, not all agents have equivocal effects on the metabolic diseases, and this table will show you that some agents will have more detrimental effects than others. For instance, for hypertension, CNIs have more effect than steroids or mTOR inhibitors, whereas mTOR inhibitors will have more effect on dyslipidemia than other agents. For diabetes, steroid is the most diabetogenic, which is then followed by CNI. And so from this, the clinician can decide on the type of immunosuppression based on the risk profile of the patient. Now, even within classes of drugs, the risk of metabolic diseases and adverse effects may not be equal. With CNIs, for example, cyclosporine is associated more with hypertension, dyslipidemia, and also hyperuricemia, whereas tacrolimus was more associated with new onset diabetes after transplant. And in a recent meta-analysis of post-transplant diabetes after liver transplant published this year, the proportion of patients who developed post-transplant diabetes by 2 to 3 years was 0.15 for cyclosporine, 0.23 for tacrolimus, and 0.27 for sirolimus. So again, one can tailor the immunosuppressive regimen according to the risk profile of each patient rather than adhering to a fixed protocol-based regimen. And one of the more important outcomes which severely affects long-term survival in transplant recipients is the development of de novo malignancies, which is related to immunosuppression exposure and also to the intensity of immunosuppression. Now, once malignancy occurs, immunosuppression may also contribute to its progression. And there may be multiple mechanistic pathways, which falls broadly into a few categories, and these include impaired immune surveillance and also infection or reactivation of some of the oncogenic viruses. In the table here are a list of factors which increases the risk of certain malignancies after liver transplant. For instance, alcohol and smoking will increase your risk of lung, head and neck, and also upper GI cancers. If you have underlying PSC and inflammatory bowel disease, your risk of colorectal cancer is increased. High age and male gender, etc., will increase your chance of developing skin cancer in the long term. And of course, Epstein-Barr virus status is directly associated with the development of post-transplant lymphoproliferative disorder. So the incidence of de novo malignancies in transplant recipients is roughly about 2 to 4 times higher than in the healthy population. And the malignancy-related mortality is becoming the most prevalent cause of death amongst transplant recipients. And the most common malignancies include PTLD and also skin cancer. For other types of malignancies, there's often a high variability reported, and that is due to the different population that is studied and also the heterogeneity of the data source. For instance, head and neck and upper GI malignancies after liver transplant have a much more high prevalence or incidence in patients transplanted for alcohol related liver diseases. Now, this is in a large study, a recent study from France of over 11,000 adult liver transplant recipients. It shows that the probability of developing a de novo malignancy was 2% in 1 year, increasing to 13% at 5 years and 28% at 10 years. Significant risk factors includes recipient age, male gender, the type of initial liver disease such as alcohol-related liver disease, and also PSC. And of note, the initial immunosuppressive regimen used had no significant impact. The most common malignancies were hematological malignancies, 22%, followed by non-melanoma skin cancer, 90%, and lung cancer, 12%. And looking at several large registries reporting on de novo malignancies, one can see that PTLD appears to be by far the most common malignancy development after transplantation across these different registries. For PTLD, you can see that the risk after transplant is lower in lung and pancreas transplant, but higher than heart and kidney transplant for liver transplant recipients. And as you know, PTLD commonly results from de novo infection or reactivation of latent EBV. The risk of developing PTLD from EBV is highest with a primary infection. And other well-established risk factors include the intensity of induction immunosuppression, and also the duration of maintenance therapy, and also the number of rejection episodes. There's also strong evidence that specific immunosuppressive agents may be at a higher risk of developing PTLD, and these include ATG, OKT3, tacrolimus, and some of the not so established perhaps is mTOR inhibitors and cyclosporin, and whereas mycophenolate basiliximab induction shows no increase in risk with PTLD development. And on the right side, and you can see that that this is another recent study looking at PTLD. The onset of PTLD is much more earlier for pediatric patient age group than in adults. And in fact, most of the PTLD occurs in the first 5 or so years. And this is likely due to the fact that this is the period where the immunosuppression is going to be the highest. Overall, though, it is likely that the overall immunosuppressive state is the strongest promoter for driving the development of PTLD. Now, for patients who are transplanted for alcoholic liver disease, the risk of de novo malignancies is much higher, and in large part responsible for the reduction in long-term survival. And this is particularly true for smokers, whereby the risk of malignancies is markedly increased. And in fact, some transplant programs will require patients to quit smoking prior to consideration for liver transplant. And in the study of over 350 patients transplanted for alcoholic liver disease, the cumulative incidence of solid organ malignancies after transplant was about 8.7% at 5 years, increasing up to 33% in 20 years. You can see that tobacco use was associated with a markedly increase. If you look at the types of immunosuppression, it appears that the use of mTOR inhibitors was associated with somewhat decreased risk. Now, in another single-center study of, this is over 1,600 patients, the most common types of malignancies were solid organ tumors, followed then by skin cancer, and then hematological malignancies. Those mainly treated with tacrolimus had a significantly low risk of developing a solid organ tumor compared to cyclosporin. After multivariate analysis, history of smoking, predominant use of cyclosporin, and the recipient age were independent significant factors for developing solid organ tumors after transplant in this particular study. And this is a study of over 89,000 liver transplant recipients using the SRTR database, and just over 3,800 developed de novo malignancies. In this study, all the major immunosuppressive agents were associated with increased risk of developing malignancies. After multivariate analysis, immunosuppression containing CellCept, cyclosporin, sirolimus, steroid, and also tacrolimus were independent predictors for the development of solid malignancies. So rather than some agents being protective of developing malignancies, it is probably more likely that some agents, such as CellCept and steroids, have relatively less risk in comparison with the other agents. So does getting off immunosuppression reduce the risk of malignancy then? When they compared patients on standard immunosuppressive regimen to those who were weaned off immunosuppression and then achieved operational tolerance, and those that didn't achieve tolerance, they found no de novo malignancies in the tolerant group versus 4.6% in the non-tolerant group and 13% that were maintained on standard immunosuppression. So it would appear that getting off all immunosuppression will significantly reduce the risk of malignancy. But again, this will only be applicable to those that achieve operational tolerance. Now, this slide just shows you an example of screening protocols for de novo malignancies in liver transplant recipients. I won't go through each of these components individually, but as our liver transplant patients are surviving for longer and many are reaching into the older age group, screening for de novo malignancies becomes a vital part of the long-term management, especially as the majority will still be on some form of long-term maintenance immunosuppression. The chances of them dying from rejection or recurrence of primary liver disease becomes minimal, whereas the risk of dying from de novo malignancies will be increased significantly in the longer term. And moving away from de novo malignancies, one of the other long-term effects of immunosuppression, and perhaps not as much talked about, is its effect on our bone health. And of course, there are multiple factors which may contribute to the reduced bone mineral density before liver transplants, such as cholestatic liver disease, alcohol, steroid, and so on. Now, risk factors for developing fractures after transplant includes a history of vertebral fractures, older age, type of liver disease, and also retransplantation. And immunosuppression also contributes to the development of bone loss and fractures. Of course, steroids have the highest rates of fractures, especially with high doses. And in addition to steroids, other immunosuppression, such as calcineurin inhibitors, are associated also with the loss of bone density. And with a reduced GFR, increase in phosphorus, this may lead to increase in parathyroid hormone and also contribute to an increase in bone turnover. So it is important to monitor for bone mineral density using DEXA scan. Currently, I don't think there's a consensus on the frequency of surveillance for bone mineral density, but for patients with risk factors and a normal initial bone DEXA scan result, I think repeating a test after 2 to 3 years to exclude significant bone loss would be a reasonable approach. I will finish off talking briefly about COVID and immunosuppression because we are still in the middle of a pandemic and it can affect liver transplant recipients receiving long-term immunosuppression. The mortality appears to be higher for those transplanted for more than greater than 2 years. So it raises the question of whether longer immunosuppression exposure may be a factor. Now, in a recent study published in the Journal of Hepatology on COVID and liver transplantation, the study identified several independent risk factors for severe COVID-19 hospitalized patients. These includes the Charlson Comorbidity Index, male gender, shortness of breath of diagnosis, and also baseline immunosuppression containing mycophenolate. And the Kaplan-Meier curve illustrates the negative prognostic impact of mycophenolate, especially at a dose of more than 1 gram per day. Whereas in contrast, calcineurin inhibitors, mTOR inhibitors, and maintenance corticosteroids were not associated with an increase in risk of severe COVID-19. And in fact, in the study using the European registry, the use of tacrolimus was associated with a better survival. And this may not be too surprising, as studies have shown that CNIs can block the replication of human and animals SARS-CoV virus in vitro. There's not a lot of data on the use of steroid, although there has been a lot of interest in the use of dexamethasone, showing a lower 28-day mortality in persons with severe COVID. So steroids may have some benefit in subgroups of patients. Overall, the management of immunosuppression for transplant patients infected with COVID has been quite variable, although the overall tendency is to reduce immunosuppression, especially those on an anti-metabolite drugs such as mycophenolate. So to summarize, the overwhelming majority of liver transplant recipients will be maintained on immunosuppression, with only a handful achieving operational tolerance. So therefore, clinicians should be well aware of the long-term impact of immunosuppression, especially as patients are now surviving longer. The impact can be broadly divided into class effects, such as opportunistic infections and also the development of malignancies, whereas the more common individual drug effects includes renal toxicity, metabolic diseases such as diabetes, hypertension, dyslipidemia, and obesity, and also bone disorders such as osteopenia and also osteoporosis. Protocol-driven immunosuppression regimens are outdated and they should be individualized, taking into account the patient's risk profile so that the long-term detrimental effect of immunosuppression can be minimized, but at the same time without compromising on the long-term graft viability. One should aim to use the lowest dose possible to prevent rejection, thereby avoiding the development of associated adverse effects that we have just discussed. And last but certainly not least, all liver transplant patients should be regularly screened for the long-term effects and impact of immunosuppression. These include disorders such as diabetes, dyslipidemia, osteoporosis, malignancies, and also have a high index of suspicion for opportunistic infections, cardiovascular, and cerebrovascular complications. So I will finish here and thank you very much for listening. And also I would like to take this opportunity to extend a warm welcome to you all to the next CAST meeting, which will be held in 2023 in Hong Kong. And hopefully we can all travel by then and you will be able to come and visit us. So thank you very much.
Thank you, Dr. Fang, for giving us a nice talk. And is the questions answer is allowed or it is not allowed?
Yes, sir. Yes, sir. We can ask the questions.
So
After each talk, we can.
yeah, Dr. Fang, can I ask you as a moderator, first question, start the ball rolling, that we know that long-term immunosuppression has various high propensity to develop malignancy in a recipient. And there are various forms of malignancy. What I am interested to know is the number of immunosuppressants as well as the doses of immunosuppression has a direct correlation with the onset of malignancy. For example, maintenance only with TAC. Many patients you can maintain with TAC on long term. Simple, and steroid withdrawal is usually done at 3 to 4 months. And in contrast, some people may need both CNIs, maybe mTOR inhibitor, or maybe other inhibitors like EJA or CellCept. And is there a difference between various combination and the doses of immunosuppression as far as long-term malignancy is concerned, as well as long-term metabolic syndrome and renal disease? These are the three major Achilles heel on long-term immunosuppressants.
Thank you for your very good question. In fact, it is the Achilles heel, those metabolic syndrome and also the de novo malignancies. Certainly the types of immunosuppression, the intensity and the duration of immunosuppression is related to the development of de novo malignancies, especially with hematological ones. In fact, the majority of patients in these studies, long-term studies, they will by, especially if they're protocol driven, they'll be actually on minimal immunosuppression after 3 to 4 years. And most of our patients will actually be on perhaps low dose maintenance, tacrolimus. And these patients will, down the track, will still develop de novo malignancy. So as a class effect, it is probably just the overall decrease in immune surveillance, which is attributed to the increased risk of developing the solid organ tumors. Of course, there are some intrinsic diseases which may be associated with heightened malignancies, such as those that are transplanted for alcoholic liver disease. I mean, they certainly, especially if they continue to smoke, and if they relapse and drink, then their risk of head and neck cancers and also upper GI cancers are much more increased. In terms of the different types of immunosuppression, I've showed you that lovely meta-analysis. In fact, that all of them actually had an increased risk of developing long-term malignancies, which is, just a whole overall class effect, but some certainly more than the others. And agents such as CNIs were shown to be a bit more than perhaps steroids and mycophenolate, which is actually in essence an anti-metabolite or agent, or maybe anti-neoplastic. It's used previously in its early days. So there are some differences. In terms of metabolic syndrome, again, some of these factors, the degree of immunosuppression is going to matter. And the types of immunosuppression some of them will be associated more with certain agents. In terms of things like renal impairment and trying to get off, and will it improve? That little study I showed where they were able to achieve operational tolerance, none of that particular group developed de novo malignancies that were successfully weaned off immunosuppression. So that may be just a hint of, that if you are able to get off immunosuppression completely, then you're able to reduce. Of course, it's not going to be zero for life. It's going to come up, at one stage or another, but it's going to be much lower. In terms of renal impairment, I think that's probably been overstated in the past, perhaps, because by the time you can get off immunosuppressant and achieve operational tolerance, these are patients who are 5-6 years down the track. And by that time, the renal impairment's already well established, and there's not much degree of reversibility, even if you get off those. I mean, you and I know that, you know, our patients who have creatinines of 150, 200, even if we've minimized them and get them off immunosuppression, we can see that their renal function continues to deteriorate. So that's kind of, for that, it's probably, that's probably not going to be too much effects from trying to get off immunosuppression in terms of the renal function. But, you know, we still tend to do that.
Thank you. Is there any, I don't see any questions in the chat box. Is there any questions from moderator, because I don't want to waste time?
Yes. Dr. Acharya, can I ask a question? Hi, good evening. Thank you, Dr. Fang, for that nice talk. I had a very specific question that we use mTOR inhibitors as for their renal sparing effect. Now, if you have a patient with early diabetic nephropathy who's been transplanted, has a borderline creatinine, would it be, and he obviously has some proteinuria because of the diabetes, would it be safe to use an mTOR inhibitor in a patient like this, or would you rather go with TAC? Because this is we see a lot of diabetes. India, as you know, is a diabetes capital of the world, and we have this kind of scenario pretty often. So what would you do?
And there's an excellent question, actually, and it's all, with immunosuppression is always about, I think, balancing the risk and benefits. For those patients with significant proteinuria, I think it'll be very tough to use mTOR inhibitors as a renal sparing agent. And you would probably look towards other agents, such as mycophenolate in those cases as a renal sparing agent, because if they have significant proteinuria, then, you know, a lot of them will end up having peripheral edema, significant peripheral edema, and they tend not to tolerate even the lower doses of mTOR inhibitors. So the renal sparing benefit may not be so definite in this particular group of patients. In those with mild, you know, microscopic, you know, microalbuminuria, I mean, you can monitor the patient and see whether they'll end up with having significant proteinuria or have increased proteinuria while they're on the mTOR inhibitors. That's one way of individualizing the approach. But if they have significant proteinuria and renal impairment to start off with, then I'll be very cautious about putting those patients on mTOR inhibitors.
Thank you.
Thank you. If there are no other questions, I will request Dr. Nagral to take over the moderator job and invite the next speaker and moderate the talk. Dr. Nagral, please. And then the next moderator can invite.
May I invite Dr. Fauzi Salibi, I hope I'm pronouncing the name right, for a talk on once-a-day immunosuppression, the pros and cons. And I think it's extremely relevant for us. Patient compliance will improve tremendously, and we look forward to listening from this. Dr. Fauzi, please.
Mr. Chairman, dear colleagues, I would like first to thank the organizers for this invitation to the hepatology courses in India. These are my disclosures. So, for the once daily prolonged release tacrolimus in comparison to the BID or twice daily use of tacrolimus, and this is where I will only highlight my topic. There have been a huge number of trials during the last decade on such a topic, but we'll try to summarize the important points. Two main points to highlight: the PK data comparing once daily versus BID. We know well that tacrolimus had a narrow therapeutic index. That means between efficacy and toxicity, the grade is very low. TAC-PK also, in addition, had a large intra and inter-individually variation, and this is related to the metabolism mainly by P450 cytochrome. Therefore, for all transplant patients, there is a high need for therapeutic drug monitoring of drug levels daily in the first early period of liver transplantation, and then at each time of visit or consultation. And always dose adjustment are mandatory. The first message we can say, if we can do a little bit summary of all what have been published, that PK differences between once daily and BID mostly carry on absorption and do not carry on the metabolism and the excretion of the drug. And several studies reported now very strong and similar correlation between the trough levels and the 24 hours area under the curve. That way we can continue doing trough levels either with BID formula or once daily formula. The magnitude of certitude is similar. And the second major topic that highlights the need of once daily is compliance and adhesion treatment. Just to know that the prevalence of non-adherence to immunosuppressive medication may range from 8 to 10% till 20%. It's mainly high in pediatric and adolescent patients. The time at adolescence is very critical. In young adult patients transplanted mainly for acute liver failure or other liver disease, this is also critical. And you have many other factors that could lead also to non-compliance and non-adhesion to treatment related to social factors, psychological factors, addiction, and adverse event. Compliance to medication also might decline over time when we go 3, 5, 10, and 15 years. This probably contributes what we know now to either late acute rejection or probably antibody-mediated chronic rejection, which now the definition is not quite sure, but we have now many data, mainly in the young patients on chronic rejection, may probably related to less compliance. We will not follow all studies on these issues, but we know that several studies reported improvement in compliance and adhesion to treatment for TAC once daily. I will go on only the main few studies important on this issue. The most important one was, this was a prospective randomized multi-center double-blind study. 471 patients randomized either to the TAC BID group plus corticosteroids, 234 patients, or to the TAC once daily. And you can see for the tacrolimus BID here and the tacrolimus once daily on the upper curve, these are the mean trough total daily dosage in the upper curve, and we can see that you need more dosing, mainly in the first period to adjust, and the large variation to adjust your trough levels as compared to the latest period. But overall, if you look at the mean trough levels, also there are more variations in the mean trough levels during the first months when you compare later on in the treatment. And this is an important point when you want to use both formulation. When you look at the data on efficacy on renal, this is GFR, creatinine clearance was comparable among the two groups. Risk of biopsy-proven acute rejection was comparable. This study was in 2010. Maybe the rate of rejection at that time was slightly higher than today. And there is no MMF. This is dual therapy, not triple therapy. This is why we can expect a higher risk of rejection and renal impairment too. This is the main large pivotal study, the DIAMOND study, that compared the ADVAGRAF, which is the once daily dose, in three situations, three settings, in order to see can we use the once daily formulation early in the immediate period post-transplant. And you can see that the first arm was to use tacrolimus once daily at the dose of 0.2 milligram per kilo per day plus MMF. Arm 2 and Arm 3, they included induction therapy with basiliximab and less dose, reduced dose of TAC between 0.15 milligram per kilo per day, and the Arm 3 similar, but delaying introduction of CNI. And the data, we know these were around 900 patients, around 300 patients in each group. When we look at the tacrolimus, the trough levels of tacrolimus, all are the three groups are once daily formulation. You can see in the Arm 1, the highest dose, 0.2, it was high, the trough levels was really high here compared to the induction therapy where we used lower levels. And this is variation in the levels always during the first months. Similar here, we can see the trough levels of C0 from day 0 till day 35. You can see more variations during the early period, especially the first 2 weeks. And here also most unfavorable to use the induction therapy and lowering dose of attack. If you look at the data on GEGFR at week 24, on the MDRD, with the Arm 1 without induction therapy and higher dose of TAC, you have higher, the renal function was at, you can see the Arm 1, the renal function was the worst, around 67 milliliter per minute at week 24. And you compare the two arms here in orange and green with induction therapy and lower dose have better, significantly better eGFR. This is important when the extension data have been published later on in AGT and focusing on renal function, dividing group of patients with eGFR above 60 and below 60. If you look at between the randomization and week 24, as with always, we are using CNI, we were losing eGFR by 30 milliliter per minute. You see, we went from 100 milliliter normal eGFR at time of randomization to around 65. But the worst you lose eGFR was Arm 1, where you are not using induction and higher dose of TAC. It's similar. If you look at those patients with CKD, chronic kidney disease, as defined by eGFR below 60, you can have improvement in some degree of renal function from 36 to 48, but the best improvement were in induction therapy and lower dose of CNI compared to the Arm 1. If you look another, this is just to summarize all studies, 7 randomized controlled studies that try to compare once daily tacrolimus to twice daily tacrolimus, and you can see that all these data showed that comparing the two drugs, there was no difference on outcomes, neither on acute graft rejection, neither on the main safety issues like occurrence of infection, any adverse drug reactions, headache, back pain, and blood disorders. Most of these studies were only 1 year or 2 years period. But the most important data we have from the European Liver Transplant Registry that analyzed patients transplanted from 2008 till 2012, that nearly around 4,000 patients. And they divided those who were already started prolonged release TAC to tacrolimus BID. And at the end, they did a propensity score matching 1 to 2, and they compared 270 patients with once daily tacrolimus to 500 with BID. And they did show that finally on the long term, maybe not on the first year, but on 5 years, on 3 years here, patient survival and graft survival were significantly better when you use the once daily formula. I would show you better the study that continue. This was the extension study, also from the till 2016 this time, also from the European Liver Transplant Registry, 13,000 patients. And they divided those who prolonged release tacrolimus versus intermittent release, BID. And they did a propensity score matching using around 18 variables that we know that all could affect significantly outcome, like the MELD score, the Donner, Ishtar characteristics, the Immunosuppression score, ischemia time, graft preservation solutions, and also immunosuppression, whatever. And finally, they compared 3,000 patients with 1,000 patients once daily and 2,000 intermittent release BID. And you can see here that on the long term, and here we have the data on 4 years graft survival and 4 years patient survival, you have significant differences in favor of the once daily, around 5 to 6% differences in both graft and patient survival. And when you look also after, this is before, when after cross-matching calibration, the things remain, that you still have even better, more differences when you really calibrate according to confounding factors. You still have differences in favor of the once daily tacrolimus compared to the BID. And in the multivariate analysis that analyzed predictive risk factors of reducing graft survival or patient survival, you can see factors. We know that recipient age, the emergency status of the liver transplant, renal impairment could affect graft survival, but also the use of BID tacrolimus immunotherapy was affected also too with increased graft loss, but also with decreased patient survival. So what also I would like to say, if we want to calculate the need to treat, the number of patients need to treat to save one graft or patient survive, if you took other clinical examples, for example, you need to, if you do prevention with statins, you need to treat 35 patients to avoid a cardiac event. If you do flu vaccine, for example, you need to treat 23 patients to avoid a flu event. Also for osteoporosis, we know that we need to treat around 20 patients to avoid hip fracture, 3 years hip fracture risk. And similar issue, and also here to save one graft or a patient survival, one graft loss, you need to treat 14 patients, you can avoid one graft loss. So this is an important benefit on the long term. Overall, I would summarize and conclude. If we want to say about the con on the use of tacrolimus prolonged release, sure, there has been some issues and debate in the early phase of liver transplantation, in the post-transplant setting, in the ICU or immediate hospitalization. I had difficulties to adjust the levels. So dose adjustment was more frequently required. This is in a study, for example, 73% you need to dose adjustment in once daily versus 43. The second point, that TAC once daily is associated with an increased risk of disturbed absorption. So in patients with diarrhea or change in intestinal motility or paralytic ileus postoperative, you can have also need to adjust more frequently. So more cautions and the rapid dose adjustments might be needed also in patients who develop surgical complication, or like, for example, postoperative bleeding, re-intervention, you need to stop the drug, acute kidney injury, you need more adjustment. So probably this maybe 20 or 30% proportion of patients would most likely suffer a little bit more from using the TAC once daily early, but we do not have real evidence on this, to be honest. Finally, the patient perception to switch to the compliance is important. So when the patient in the early period has multiple drug, 2 or 3 times daily, so the patient by himself will not see the benefits of to use once daily compared twice daily. But on the long term, when the number of drugs has been reduced, probably the benefit and the perception of patients is better. For the Pro, finally, there has been similar efficacy and safety profile overall was found with the both immediate release and prolonged release TAC. Either also data we have studies in living donor liver transplantation as well as in cadaveric donor, similar results. On the mid and long-term follow-up, compliance is important. Non-adherence, mainly in pediatric and young adolescents, and some other factors that we could mention, could lead to antibody-mediated rejection also and late rejection. Finally, I will conclude to say that prolonged release tacrolimus will improve adherence to treatment and reduce variability to tacrolimus exposure. Conversion from intermittent release to prolonged release after 1 month or during before discharging the patient, or starting at the beginning with prolonged TAC-based immunosuppression, were found both to be associated with better graft and patient survival at 3 to 4 years. Thank you.
Thank you, Dr. Fauzi. That was a very informative talk. Do we have any questions? So I had one question in the meantime. If one was to give intermittent dosing like 2 milligram in the morning and 3 milligram in the evening, would the trough level change if we were to reverse the dosing, especially when the patient is not getting the same dose morning, evening for the intermittent dosing?
Yeah, this is a frequent situation that might occur, sure. Here you are more in general adjusting your trough levels on the BID on the dose of 3 milligram rather than the dose of 2 milligram. So in such situations, sometimes we are giving the patients when in BID like 2.5 to really know the real trough level. But in the situation converting from till once daily formula, we just calculate the 5 milligram and we switch to 5 milligram once daily. Unless you are using other formulas like extended release, the melt dose LCP, this is different because the absorption here is higher of such TAC formula. You might need to lower the dose. There is like 0.7 milligram. It's in the Caucasian population, and it's 0.80 or 85 in the Black population, has been calculated on previous PK trials.
Thank you, Fauzi. It was a fantastic talk, and I must thank you once again for taking off your time and being with us. One question to you was, like, once you start once daily early on post-transplant, and if patients have complications like bleeding or biliary leak and they need interventions, they may have to go to the theater again. So in such situations, how do you manage them? Like, do you give a break to that once daily, go back to twice daily, or or you have some other strategy? Because this is sometimes seen in 10, 20, 30% of patients, which you mentioned yourself. So how do you handle that critical phase when you're not able to administer once daily in your normal way?
Oh, this is an important question and has been raised with the company since the beginning. Intensivists like I too, we are reluctant to use prolonged drugs because we calculated that to know the real trough level of the dose you give this morning, you need to wait the second day in the evening. So if the patient develop a complication, you need to intervene, or acute kidney injury, you are losing like 12 to 24 hours to readjust your dose. And like I showed, these patients in general, did need a lot of adjustment in the early period, according to especially if it is a living donor, if it is a split donor, if it is a fast inducer or a slow inducer, according to the genetics of the cytochrome P450. So I'm not sure. So usually in our center, we started when the patient is very steady. That means he's left the ICU, he's in the hospital, and just a few days before discharge. So in general, we move on to the once daily, like 2 weeks after or 3 weeks. If you see the patient is stable, this could be the right time. But like I said, these are few populations that move a lot and you need a lot of adjustment. Now we are transplanting patients with very high MALD score, with renal impairment, higher risk of bleeding. So difficult to adjust the once daily, whatever for CNI and even other formulas.
Right. Thank you so much.
Thank you very much. Should we move on to the next speaker if there's no other questions? Dr. Saigal?
Yeah, sure, that's fine. Yeah, I think Dr. Rela is online already. Yeah, sure.
It is my pleasure and honor to welcome Professor Mohammad Rela to speak on the next topic, tailored immunosuppression in liver transplantation. Professor Rela is Chairman and Managing Director of the Rela Institute at Chennai. But more importantly, he's perhaps the one liver transplant surgeon, besides being a pioneer in many aspects, who truly straddles multiple geographical regions and has really influenced transplantation globally. Over to you, Professor Rela.
I need to be able to share my screen actually. Can the organizers allow me to share my screen? I have to give my
sure.
Thank you, Sanjiv Saigal, for inviting me, and thanks, Dr. Subhash Gupta. My talk is on, I'm still not able to share my screen. It says the host has disabled you from sharing screen.
It's enabled, sir. Please try once again.
Yeah, I've got it now. Thank you. And thank you for this title, Tailored Immunosuppression. And I just want to say, I think in today's world, I think every clinician and transplant hepatology, in fact, practices tailored immunosuppression. I don't think it's any more protocol-driven immunosuppression. We all make major changes to immunosuppression on a daily basis, depending on really the immunological status of the patient, the nutritional status, renal impairment, which comes even post-transplant, septic episodes, a fever. I think it very much is tailored to an individual patient. And I think protocol-based immunosuppression is a thing of the past, I think. But it's important to understand how we started. I think with the start of immunosuppression, if you look at before the cyclosporin era, all the focus was on really avoiding graft loss due to rejection. And with cyclosporin also, rejection was still a huge problem. It was only really when tacrolimus came into use that we slowly started to forget about graft loss due to rejection as a problem. So if you look at the cyclosporin era and the tacrolimus era, it's only during the tacrolimus era you're really bringing down the incidence of steroid-resistant rejection to probably less than 5%. And now we are starting to think about the long-term effects of immunosuppressions and the complications associated with immunosuppressions. So I would say the awareness of tailored immunosuppression has been there probably for the last 15, 20 years. And every clinician really tries to do the best for the patient. And I think in the liver, it's even more relevant that we don't over-immunosuppress patients because the graft loss due to rejection over a period of time in liver is much lower than in other solid organ transplant, and chronic rejection has not been any more a major problem in liver transplant. And the biggest advantage, you may have any number of immunological reasons why liver is a privileged organ. I believe that the regenerative capacity of the liver's ability to regenerate itself after injury, which doesn't happen in other organs, is probably one of the most important factors that allows for really absence of graft loss in the long period of time. But nevertheless, really, if you look at the outcome of long-term outcome of these are liver transplanted patients, there is clearly a reduction when you look at 20-year survival of these patients. There is a reduction in survival, and you'll be surprised to see that there is a 36% survival gap compared to the general population for liver transplant patients when you match them for age, sex, and comorbidity. So there is a significant reduction in survival in post-transplant patients. And the interesting aspect of this study is, I mean, until I saw that, I was quite surprised. We always say that in the liver transplant recipients, most of the graft loss or survival is within the first year, and once they survive first year, the 3-year survival, and once they survive 5 years, the graft is almost a horizontal graft over a long period of time. And I find that that is not true anymore. I think the graft is somewhat stable. I mean, the survival curve drops in the first year, as you see, and then it is somewhat stable for about 8 years. And following 8 years, there is a rapid drop in survival rate in transplant patients, the liver transplant patients. And you will see that most of the cause of death after the 8 years is non-liver related. Liver related complications are also significant causes. There may be fibrosis or recurrence of portal hypertension in children. But most of the non-hepatic causes, most of them, 2/3 of the causes due to non-hepatic causes, and they are malignancy, cardiovascular events, and renal impairment are probably the main causes. And all of this is in fact related to a protracted exposure to immunosuppressive agents. So I think it's become necessary that we do look at modification of immunosuppression for the benefit of the long-term survival of the patient, rather than really the short-term benefit. And it's very clear. The other side of the story is we worked hard to avoid rejection. I think now we know that 1 episode or 2 episodes or 3 episodes of steroid responsive rejection is not bad for the patient. In fact, the long-term outcome of patients who have had steroid responsive rejection is in fact better than patients who never had an episode of rejection. So that's an interesting statistics, and therefore it is important that we don't try to avoid rejection. I think mild or moderate rejection, which is responsive, is in fact good for the patients in the long term, as people believe that it may be one of the factors for long-term tolerance for patients. And again, this study shows exactly the same. In fact, the worst aspect of high immunosuppression is the long-term risk of cardiovascular risk and malignancy and renal impairment risk. So what does an ideal immunosuppressant schedule look like? I put there as a schedule because it's not always a single drug, because if you use a single drug, you may be using a higher doses or higher levels of the drug. Maybe combination is something we still need to think about to have them at a lower dose. So it's something which provides a stable graft function with reduced risk of severe rejection or steroid-resistant rejection is what we need to aim for. Mild or moderate rejection, in fact, is not a bad thing. Has minimal toxicity profile, and it has minimal long-term complication and an easy dosage schedule, like we saw Advagraph, where there can be a good compliance would probably be the best immunosuppression schedule. Now, Jeff McCogan from Australia wrote this review. This is about 6 years ago, where he said that there is no such thing as a protocol immunosuppression in liver transplantation. Everything has to be really tailor-made for an individual patient, and it is a balancing act. Which needs to be really thought about on a daily basis. And one needs to think about metabolic risk factors, reducing calcineurin inhibitors in renal function, and mTOR in malignancy. And this is really what we are looking at. And I think most of you would agree that nobody follows a strict protocolized immunosuppression protocol. And when we look at the survey, I mean, there has been some idea of having a steroid-free immunosuppression single drug such as calcineurin for immunosuppression. But then this survey by SRTR clearly shows that almost 60 to 70% of all transplant programs start off with a 3-drug regime with calcineurin, with MMF and corticosteroids, but corticosteroids are stopped over a period of 3 to 6 months, and the MMF is stopped probably over a period of 2 to 3 years. Now, some of these slides may be a repetition because the whole conference is about immunosuppression, and there have been talks on cancer, there has been talk on renal sparing immunosuppression as well, but I'll just summarize really a few more slides and stop my talk. So in cancer, there has obviously been drugs which have an anti-oncogenic effect, and there are drugs which actually stimulate cancer growth. Obviously, calcinurins have been shown to actually affect progression of or recurrence of tumor. On the other hand, the mTOR inhibitors have been beneficial in patients with cancer. The evidence for tacrolimus has really been very clear, and it's also dose dependent. When the trough concentrations have been more than 10 nanogram per milliliter, the risk of HCC recurrence have been almost threefold in this study. And also when the trough levels are between 7 and 10, by running the tacrolimus lower, you can actually halve the HCC recurrence in the post-transplant setting. And that holds good actually if you use, in fact, everolimus, add everolimus to your immunosuppression. And that again has shown a significant reduction in the recurrence rate of HCC for tacrolimus alone, with 13% recurrence versus everolimus at 4.1%. So everolimus has very clearly been shown to be beneficial. But do we need to then start every patient with HCC on everolimus is a question that we need to think about. And I think this study from Professor S.G. Lee is the lead author of this study, which compares two prospective randomized studies. It's a pooled analysis of the Eastern versus Western study. In the West, it's all been DDLT, and most patients have been within Milan criteria. And in the East, it's been mostly Asian centers and LDLT centers. And most have been, there is a significant increase in number of patients outside Milan criteria. And they have the pooled analysis of everolimus with tacrolimus or tacrolimus alone. They also look at renal impairment. When we look at cancer alone, it was beneficial in patients outside Milan criteria. So if we are following outside Milan criteria within UCSF, there is a clear difference. In the mTOR arm, it's 5.9% recurrence in comparison with 23% recurrence in the tacrolimus only arm in patients outside Milan criteria. So to summarize, for HCC, CNI minimization alone works. Not running tacrolimus levels of over 10 is beneficial in reducing the risk of recurrence. And if you're transplanting patients outside Milan criteria, obviously everolimus has a role. But if you get a post-transplant recurrence, whether you would want to switch to everolimus, is the advantage is doubtful. I think you need to combine sorafenib with mTOR, or you need to have some other strategy for these patients. Renal impairment, I'm sure, has been discussed previously. Yesterday's talk, you had renal impairment there. Tacrolimus obviously is toxic, and it causes sometimes irreversible or reversible vasoconstriction. And this is very much a dose-dependent complication, and it also causes hypertension and hypokalemia, which can all be hypertension responsible for renal impairment as well. I think handling tacrolimus is very important, and it's also a fact that the tacrolimus-induced renal toxicity is much more in the liver and intestinal transplantation compared to other solid organs such as heart and lung transplantation. Perhaps these patients, many of them have renal impairment even before going for surgery. Now, how do we, the minimization strategies for renal impairment patients? So one needs to think about either reduced dose of tacrolimus to start with from the beginning, or CNI delay in the initiation after 5 days or 6 days by using IL-2 antagonists. And this is what most people have done. Can we think about not having CNI at all? I don't think that's been an option. It's not been an option even in the long term, I believe, for renal impairment. If you have CNI withdrawal completely, the risk of really biopsy-proven acute cellular rejection is much higher when you use mTOR alone, and therefore it is not safe to withdraw CNI completely. And I've certainly seen in the early days of MMF introduction, when we used to really lower the dose of tacrolimus and start MMF, and there have been instances where people have actually withdrawn CNI and substituted with high doses of MMF, and there have been graft loss associated with it. I think CNI, even in a small dose, is essential for avoiding rejection in these patients. And there is certainly CNI minimization has benefits either in the form of delayed introduction or a low dose introduction. And in this study, you clearly see that the renal impairment, or a 30% increase from the baseline with tacrolimus normal dose, it's about 42% compared to 24%. Now, with respect to really tacrolimus, this study, which has CNI alone, or tacrolimus with mycophenolate, or delayed entry of tacrolimus after IL-2 receptor blockade. When you look at the three groups, in fact, the delayed introduction of tacrolimus has fared even better than the lower tacrolimus dose right from the beginning of less than 8 nanograms. I think this has probably now become a standard practice in patients with renal impairment to have a delayed introduction of tacrolimus with IL-2 antagonist being used. I think I will go on to really the use of everolimus in liver transplant patients, and this is the RESPECT study which we saw. There has been some comments about the RESPECT study because the levels that have been maintained have not been very uniform in these patients. The aim was to have a tacrolimus level of less than 8 nanograms, but a number of during the period in most of the patients, they have not really achieved the levels that the study was aiming at, and there has been some criticism about this study. Now coming to, this is what we talked about earlier, was a reduction in the tacrolimus dose as well as delayed introduction, but now there is also the opportunity to use everolimus with a low dose tacrolimus in order to improve renal function in these patients. And one of the other aspects that is not really focused on well is that even NASH patients who have normal renal function have a potential for renal impairment in the post-transplant period. And here you can see that within 2 years, 30% of NASH patients had stage 3 CKD as compared to only 8.3% of non-NASH patients. And therefore, one needs to really think about NASH patients as well as a potential for renal impairment in the post-transplant period. Again, in the NASH patients, there is also a possibility that one needs to think about mTOR inhibitors with low-dose tacrolimus, and because that actually reduces the incidence of cardiovascular events. And here you can see that TAC elimination, which I'm not sure is possible, reduces the cardiovascular events to 2.2%. As compared to tacrolimus, which has a major cardiovascular event of around 7%. Just a couple of slides about immunosuppression in children. They are different, and children really don't need very high levels of immunosuppression compared to adults, particularly if their transplants are done at a very young age. And also we found that in the early days in the comparative study between tacrolimus and cyclosporin, we were maintaining tacrolimus levels of about 15 nanograms, and the incidence of PTLD was extremely high. It was almost around 12 to 15% in the early days of introduction of tacrolimus. So indicating that what was okay for adults at that level. I mean, it wasn't okay even for adults, but they didn't have much PTLD. Children had a much higher incidence of PTLD, and therefore, in general terms, children require much less immunosuppression than adults. And there has been a lot of talk on steroid-free immunosuppression, not even to give them steroids during the immediate post-transplant period. And there have been suggestions that steroid-free immunosuppression is beneficial for growth and development in children. And there have been some study, but I don't think many people still avoid steroids completely. And where I've come from, really, Kings, they still use a small dose of steroid in the long term. And I will show you that there has been some benefit out of it. So these are the studies where they have avoided steroids completely and have demonstrated that the episodes of acute rejection is not very high compared to the steroid included protocols. Now, one of the aspects of steroids in the post-transplant setting, I know most of us discontinue steroids after 3 months or maximum after 6 months. There has now been a lot of talk on chronic rejection and graft fibrosis in the long term, and this is particularly relevant in children. And there have been some suggestion that using a small dose of steroids reduces the incidence of graft fibrosis in the long term. And also the graft fibrosis without inflammation, even though you see no inflammation, may be a sign of or immunological, or maybe a sign of chronic antibody-mediated rejection. So really the argument is still there whether one should be using steroids or no steroids in the long term for children. Thank you very much. And this is my last slide to say that really a tailored immunosuppression is what we practice on a daily basis. I don't think it's a new concept anymore. Good immunosuppression is something which maintains a stable graft function, minimizes severe rejection in the early period, and avoids toxicity in the long run, and then prevents the risk of disease recurrence in the long run as well. Thank you very much.
Thank you very much. Are there any questions?
So, Dr. Rela, it's absolutely fantastic talk, and I know you like this, like conceptual lectures, and I really enjoyed that. Now, tell me, we are very much into a stable phase. We know generally we understand how to act now, what to give. So, what is the next, couple of years or maybe a decade? What are we going to look into? Is it a genomic profiling of patients or something that are more targeted to a patient when we start the immunosuppression? Is there a next step which you can visualize as a visionary?
I don't know. I think don't you have a talk on that next or something like that? I think genomic profiling is something that may be coming in, and finding out how they metabolize tacrolimus to decide on the dosage of tacrolimus is all probably. I mean, it's all. Even we are really doing some of those aspects. But I don't think we have incorporated that into really the clinical practice yet. I'm sure all of these developments will be there. I mean,
yeah. The talk which I have kept actually is Dr. Jalal, who would be speaking on biomarkers for rejection in liver transplant, which is going to be very exciting to. That will be like a very specific thing, and but I think that probably the time is coming that we need to go move a step ahead of the routine tacrolimus and everolimus all, and then see how better we can improve the. But what you said is absolutely fine and fantastic. Actually,
what I mean by tailored immunosuppression is not really. Most people think about specific aspects or renal impairment or malignancy or children, but I think the tailored immunosuppression really is an art. I think I can see Dharmesh sitting there who will tell you what we do on a day-to-day basis in patients who look very sick, in patients who look septic. We comfortably withdraw tacrolimus completely and not worry about. We know such patients are not going to reject. I think it's an art actually, and it requires some element of experienced clinician to boldly take decisions like that, to completely withdraw immunosuppression for a week to rescue the patient. And then the patient looks septic and the bilirubin is going up, and we don't know whether this is really graft dysfunction due to sepsis or whether rejection is come into play. I think these are very difficult decision making, which only comes with experience. I don't think you can have a protocol or you can have really written algorithm to do what we have to do in an individual patient. I think everything that we follow these days is a tailored immunosuppression rather than protocol-driven immunosuppression.
Absolutely.
Dharmesh,
the challenge with the CYP profiling is that we do not know whether it would follow the donor pathway or the recipient pathway, and plus also the fact that the CYP enzymes are also expressed in the intestine. So even though it's all very exciting and we have a lot of papers and publications on the fast and slow metabolizers, but we still do not know, like you said, whether it would be clinically relevant or not. It just reminds us of the hepatitis C days, when the recipient interferon lambda genotype and the recipient and the donor's liver genotype, they used to decide as to what is going to happen to interferon-based treatment. So I think there is still some work to be done over there.
I think the hepatitis C days were probably the most tough days in the post-transplant period.
Oh, absolutely. So I think that's why what we saw by way of the renal outcomes in liver transplant was largely driven by hepatitis C fear. So people did not want those patients to reject, and that is why we ended up using so much of immunosuppression in that cohort of patients. And also, like I said yesterday, the influence of the renal guys, they always wanted high trough levels. They still do. And because we picked most of our immunosuppression knowledge from them, and that's why in early years we used to have patients running on very high TAC levels. Whereas now we know that even in the first month, 5 to 8 would be good, because the patient is also on a multitude of other drugs.
I think the Indian patients don't require that much immunosuppression.
Absolutely.
Because in the UK, we'll be starting them on 3 milligrams BD, running at 10 nanograms. And here we start them on 1 milligram BD.
Yeah.
It's unbelievable how low an immunosuppression we are practicing here. And rejection is still not a problem. I don't think graft loss due to chronic rejection or steroid-resistant rejection is that big a problem, even with such low immunosuppression. But I'm keen on multi-drugs, really. Single tacrolimus dose is not what I favor, I think. And the other thing I'd like to ask, Dharmesh, you use a lot of everolimus. Do you believe that a combination of everolimus with tacrolimus is superior to or better? I mean, so I don't think we should use superior in the sense of more powerful immunosuppression. Is it better than tacrolimus mycophenolate? I'm asking you this because I switched a patient who was on tacrolimus mycophenolate in a stable situation to tacrolimus, everolimus, and tacrolimus, and he had a very severe rejection.
Right. So these are two things, and we talked about this yesterday. So first was the fear of using both an mTOR inhibitor with an anti-metabolite, which is what the earlier studies suggested. And that fear is unfounded. So you can use everolimus and an anti-metabolite together, and you will probably end up using lower doses of both, which is better for the patient. So earlier studies all said that as soon as you add an mTOR inhibitor, you take away the anti-metabolite, and that was because of the cytopenias. Now again, if someone is stable on tacrolimus and MMF, one would not want to use everolimus. So what we were trying to discuss yesterday is that the maximum harm that is done by the CNIs with respect to renal impairment happens in the first 1 month. And most studies have introduced mTOR inhibitor only after the first month. So we are a strong advocate of an ab initio everolimus in a cohort of patients whom you know about. So this should be preemptive rather than event-based. So you should know that this particular patient has got this risk profile, and that is why I would want to lean on the side of a really low TAC and have an everolimus. So the experience with everolimus is now increasing, and we all know that it works very well when somebody has a bad rejection. It works very well in somebody who needs TAC at a much higher dose. So if you were to add even a little bit of everolimus, you would be able to come down on TAC substantially. So I think these are the things to remember. The only con is about the proteinuria and hypertension, and in a very, very small proportion of patients, the dyslipidemia. So these would be the 3 areas of caution, and amongst these, I think proteinuria is the most important.
Right. Thank you, Professor Rela, for a fantastic talk and some very good discussion. With permission of chairpersons, as we have,
there are some questions in the chat box, I think.
We have reached a time for your case discussion, Dharmesh. So I can take questions, then your case will be limited then, because
Okay, no
your case
problem.
is supposed to start now, actually. So I think it's better that we start your case, and I know you are going to generate some exciting discussion. So I think that would be better. And if chairpersons permit, then I can request Dr. Shekhar to invite the chairpersons for the next session.
Go ahead. Go ahead.
Thank you, sir. Now we move ahead to the next session, and I would like to invite our chairperson for the session, Professor A.C. Anand. He's Professor, Head of Department Gastroenterology Hepatology at Cunningham Institute of Medical Science, Bhubaneswar. Dr. Akash Shukla, Senior Consultant Gastroenterology at KIMS Hospital, Mumbai. Dr. Puneet Singla, Associate Director, Department of Liver Transplant GI Surgery at JP Hospital, Noida. Dr. Abhishek Dev, Principal Consultant Gastroenterology Hepatology at M.I.C.E. And Dr. Vikram Kumar, Principal Consultant Pediatric Liver Transplant and Gastroenterology at M.I.C.E. And first, we're going to have a panel discussion, and an interesting case discussion will be there. And the moderator for the panel discussion, Dr. Dharmesh Kapoor. He's a Senior Consultant Hepatologist, Yashoda Hospital, Hyderabad. And panelists are Dr. Kaushal Madan, Principal Director, Head Clinical Hepatology at M.I.C.E. Dr. Neeraj Saraf, Director Hepatology Gastroenterology at Medanta Hospital. Dr. Naveen Ganju, Consultant Hepatology, Experts Hospital, Bangalore. And Dr. Amit Rastogi, Associate Director, Liver Transplant, HPV Surgery at Medanta Hospital, Gurgaon. And Dr. Ashok Chaudhary, Associate Professor, Hepatology at ILBS. And Dr. Dinesh Balakrishnan, Associate Professor, GI Surgery at Amrita Hospital, Kochi. Over to chairpersons.
Thank you, Shekhar, for inviting us and doing our job also. It's left for me to just welcome my co-chairpersons, Akash Shukla, Puneet Singla, Abhishek Dev, Vikram Kumar. And I'll not waste much time, as Dr. Sanjiv Saigal has said, and I'll request Dr. Dharmesh to start with this case.
Are my slides visible?
Yes, sir, we can see.
Can you see the slides, please?
Yes.
Yes, sir. Yes, sir.
We can see the slide.
Right. Thank you so much. And as you can see, the case is courtesy the course director, Dr. Sanjiv Saigal. So this is not a patient that we had managed on our unit. And because the theme of this meeting is immunosuppression, so there will be some key areas of discussion which I think this case will bring about. So this is a gentleman and who was probably treated at Medanta, I would believe. 44 years male, no past surgery, no history of any medical ailments in the past. He was diagnosed as chronic liver disease in the year 2010. The etiology was not known and he was labeled as a cryptogenic cirrhotic. He was asymptomatic till September of 2020 when he had a COVID-19 pneumonitis and he recovered from the same. He developed an lower limb cellulitis before this index presentation to this hospital and underwent debridement and a physiotomy at an outside center 2 months prior to this current presentation. He was admitted with Dr. Saigal's unit with history of 1 week of jaundice, ascites, pedal edema, and somnolence of 3 days duration. He was shifted to the ITU due to increasing hepatic encephalopathy, sepsis, and hypotension. He was managed with broad-spectrum antimicrobials, inotropes, and other supportive measures. These were the lab data at the time of presentation. So as you can all see, he has got very high bilirubin, low serum albumin, a creatinine of 2.1. We don't have serial renal functions available. White cell count is high, the platelets are low, and the INR is 1.9. So this is the imaging that has been provided to us. So we can all see that this is a liver which has retracted from the parietes, and you can see a rim of fluid between the parietal wall and the liver. And it's not something that is uncommonly seen in patients with acute on chronic liver failure. So this patient was diagnosed by the unit as a grade 3 acute on chronic liver failure, a Child-Pugh score of 13, a MELD sodium of 34, a Cliff score of 56. And when his surveillance cultures were sent at the time of presentation, they were positive for E. coli. We don't have the information whether it was a susceptible strain or a drug-resistant bug. So let me ask this question first of Dr. Neeraj. Dr. Neeraj, do you need any other information for this patient's assessment? So what else would be important in a patient who presents to the unit like this?
Yeah, so I would like to know his clinical status in terms of his, at present, if he has, what are his lungs like, X-ray or a CT chest, and need for oxygen, ventilation, renal functions, is he on inotropes?
Right. So I think the information that was given to us is that the creatinine was 2.1 and he was shifted to the ITU with encephalopathy, and they don't mention whether he needed airway protection / ventilation, and they don't give us any information about the oxygenation. We don't have blood gas at our disposal, but probably, like you said, the trend of renal function, whether he's making any urine or not, whether he has any other features like a tense ascites, high lactate, an inflammatory marker which is elevated. So all those would be extremely relevant to the care of a patient presenting to the unit like this. So this is something to bear in mind. Now, this patient, and in the unit's team, it was decided that this patient should be taken up for transplantation. So should we continue the medical management and optimize this patient till the ACLF grade improves? Or do we go ahead and transplant this patient because we think that he might deteriorate further and go down the cascade of MOF and we lose the window to transplant him? And I would like to invite Dr. Ashok Chaudhary for his comments because he's done a lot of pioneering work in this area.
Yeah, thanks. I need to get a period of at least 4 days to 7 days, a period for optimization in the form of antibiotic to get his sepsis if he's not progressing further. That is one. Two, about that you rightly said, whether his response as far as ventilation or encephalopathy is getting a little bit stable, or the creatinine is showing any worsening trend or even stable, or he's maintaining good urinary output despite his creatinine on the higher side. So I'll wait for optimization. As you rightly said, we may lose the window, but 4 days waiting such a sick patient is don't think hamper him more. So in the 4 days, I can know the trend. If he's improving, definitely my transplant is going to have good results. Data. Just the normal. So my plan will be for optimization. I will wait for only for 4 days, as we have recently published a paper, and to see that.
So that means in the first 4 days, you would initiate the dialogue with the patient's next of kin regarding transplant.
Yeah.
And because you work in north of India, you would also be initiating the process of donor workup. Is that right?
Yeah, that's, we should go both plan A and plan B. Optimization as well as at the same time, we'll start the process of counseling for the transplant.
Any of the panelists would want to come in and suggest if they have transplanted patients like this in the first 3 to 5 days of their presentation to their unit? Anybody could chip in.
So I think Dr. Dharmesh,
Kaushal, please go on.
So I think transplanting within the initial 3 to 4 days is not an issue. It's not the issue of, the issue is that he has positive blood culture and urine culture. So that is what is possibly stopping us from transplanting him immediately. Otherwise, if the patient has come ready and you also feel that in the previous institute, most optimal therapy has been given and now the patient is not improving, he can be taken up for transplant, but for the positive cultures. That is the only hitch here.
Right. So this gentleman, like we are told, he is subjected to transplant with positive blood and urine culture, and that culture was E. coli. and they do not tell us the sensitivity pattern and whether the antimicrobials that he was on were, let's assume that this is a very high volume unit and whatever this patient was on would be appropriate. But it's also important to know the virulence characteristics of the bug. And therefore, if this was, say, an Acinetobacter baumannii or a Klebsiella pneumoniae, and I would like to put this question to Neeraj because I suspect that he might have been involved in the care of this patient too. So Dr. Neeraj, what is your take on transplanting patients who are microbiologically positive? So would you ever agree in an MDT to take this patient up for transplant?
Yeah, so Dr. Dharmesh, now that's a difficult question, and I think like each patient has to be individualized. So if you look at any guideline or any consensus, I think most people would say any active infection is a contraindication for a transplant. So sepsis definitely a contraindication if you have features of sepsis. Now in a ACLF situation, patient having a positive blood culture, I think we have to individualize. So for me, if the renal function is not worsening, if he is, his oxygenation is not too bad, he's not on inotropes, I think I would personally at least consider, even going ahead with a positive culture.
Any of the panelists have a different view? Right. So I think
same, sir. Actually, we would wait for a couple of days to see how he behaves further on, because patient coming from other units, you have to see yourself how the patient behaves. If culture is positive, if the patient deteriorates, they will declare themselves. But of course, as Dr. Ashok said, 3 to 4 days we would wait.
So would it make the life easier for the treating physician if I were to say that this patient comes from the community vis-a-vis comes from a hospital? And B, like I said, if I tell you that this patient has a CRAB or he has got a CRKP, would that change our decision making to take this patient up for surgery, or for that matter a VRE?
A little bit, sir. Most likely, because if a patient comes from a hospital, they might have a bug from the hospital which would be resistant, rather than having a naive bug from the community and with a history that not getting admitted recurrently to the hospital in the previous episodes.
Right. So, Dr.
Ramesh, you have told us that there is a history of fasciotomy recently.
Ji, sir. This patient was stable for many years, sir, and he had cellulitis and underwent debridement and fasciotomy at an outside center. So we know that there is a precipitin.
So the patient has come from a hospital.
Ji, sir. That's what I said. So would life be any easier if he comes from the community? So obviously the answer is yes. And if it is a drug sensitive bug, the answer is yes. So there are certain situations in which with the positive culture, we would almost never want to transplant patients. And that is when they have drug resistant bugs. In fact, an effort should also be made to run tests on these patients, even for colonization. So there are certain situations in which you should not transplant regardless of whether the patient is improving or not, if the patient is especially harboring a drug resistant bug. So that is the message I was trying to convey. So if it's an E. coli, this is a relatively easier situation. But if it was a drug resistant or a multi-drug resistant Klebsiella pneumoniae or an Acinetobacter baumannii, or this was XDR or a pan resistant bug, then you would hold back on transplant or any solid organ transplant for that matter. But like Dr. Neeraj said, there are no guidance on this. So they just tell you how to work up a donor, but they never tell you about these finer nuances. So this gentleman underwent an LDLT at this center. The graft weight was, there was a slight mismatch from what the surgical team and the treating team thought imaging wise, and the GRWR came as 0.7. So I think I would now like to take the views of the surgeons on the panel, starting first with Dr. Dinesh, because I think their unit has published on this. So Dr. Dinesh, what is your take on the GRWR? What does it mean actually? And do you think in a sick patient like this, we can push the limits?
So actually, many times we don't have a choice. It's a live donor program. There are the members of the family will be screened. So we do not just look at the GRWR. If the graft is a good graft, it's not steatotic, anatomy is okay, then ensuring that there is no congestion of the anterior sector is probably what we can do. So we would accept a graft with a lesser GRWR than 0.8. Probably we would take an extended right lobe graft, in that we would take more MHV than we usually take, and ensure that there is no congestion of the anterior septum. So yes, we would accept a graft with a less than ideal GRW.
So if I were to just ask or slightly twist the question and say that this GRWR of 0.7 is what you got on the table, but when you had imaged this patient, you thought that it was 0.85 or 0.9. Would you have the same answer?
Yes, yeah.
So supposing you got the GRWR on imaging only as 0.6, would you have a different surgical plan for a patient like this?
That is what I answered. Yeah, we would accept a GRW of 0.7, but ensure that there's no congestion of the anterior septum. We are more worried about the quality of the graft. We would accept a 0.7 graft. Though, we know that in a patient with high metabolic demand, you need a good graft, but the function is more important. So a non-steatotic graft, absolutely no congestion. But if it's a complex graft, like there are multiple outflow veins, then I would be worried.
Dr. Amit, what's your take on this?
I would slightly differ with what Dr. Dinesh says. I think, I don't exactly remember this case completely, but probably this is an intraoperative low GRWR that we got, because electively in such a situation, 0.7, how busy the unit might be, how sick the patient might be, we would avoid. So maybe it was 0.8, although the volumes look a little different. It is 774, and 0.7 means the patient is 110 kg plus.
Yeah, absolutely.
Is there a...
This surprised me also, but this is the case provided by Dr. Saigal. Yeah.
So
but
maybe
that's fine. Yeah, we all see very overweight or obese patients, so nothing unusual. But I think this is what you guys got on the table.
Such a patient, even if, see, we are pushing the limits too far. The patient is sick, we know, but then the patient is culture positive, and then the GRWR is also very borderline. So most likely this is somebody who had 0.8 or 0.85, and it turned out to be 0.7 intraoperatively. But electively, in such a situation, I think we should not go below 0.8, because then there are too many variables.
Right. And then just in the same vein, would you like to define what you would call a marginal graft on the living donor side? So we all know the definition of marginal grafts in the deceased donor setting. So what would be such a graft?
Marginal donor, if I have to say, I think there are two aspects to it. One is the graft weight, and the other thing is quality of the graft. So if any graft which is less than 0.8 would be classified as a borderline graft, if the quality is okay, or the graft weight is more than 0.8, but the quality is not good. Say, for example, somebody has 5 to 10% fat and GRWR is 0.85 or even 0.9, that will effectively make it less than 0.8. So somebody with a good graft but low volume, or a good volume with a steatotic graft, or the graft from somebody who is 50 plus age, 55 is the limit that we keep. So all these conditions would qualify as a marginal graft.
Right. Thank you so much. So his intraoperative period was uneventful. He was initiated in the post-operative period on the standard immunosuppression regimen for this unit, which is steroids, tacrolimus, and MMF. We really aren't told in what sequence and in what dose one would do this. So Dr. Neeraj, probably you were involved in this care, in the care of this patient. So in a sick patient like this, what would be your protocol of immunosuppression? No, Dr. Neeraj, are you there? Dr. Naveen, would you like to take that question?
Yes, sir. Of course, in such patients, when we know that the patient was already very sick and infected before the transplant, we would give steroids, maybe a little lower dose. Tacrolimus initially could be postponed because creatinine was 2.1. Depends on how the creatinine was perioperatively and how he behaved. And MMF, of course, very late. We could wait up till 2 weeks also, see how the patient behaves. Steroid also could be tailored and decreased down intra-op. The induction also could take, if it is 500 as protocol, we could give 250 as well.
Right. So I think this question or this issue was addressed by Dr. Saigal yesterday in the questionnaire that he had sent to various transplanting units. And what one gathered from that was that even the intraoperative dose of steroids that is used by the units, that varies depending on whether a patient is sick or not. I don't know if Professor Rela is there. If he is, maybe he would want to make a comment on what the intraoperative dose of methylpred means. Prof, are you there?
Yeah, I'm there. I'm there.
All right. So this was a questionnaire which was read out by Dr. Saigal yesterday, in which many of the respondents suggested that the intraoperative use of methylprednisolone, they would tweak that dose if the patient was very sick. I know this is a very favorite topic of yours. Would you like to comment on that?
No, it's not. It's not. I don't believe that the intraoperative dose is given for the sake of immunosuppression. Really.
Absolutely. So this is what was being discussed
so
yesterday. So that's for a
loading it or
complete
stopping it or skipping it, in fact, is extremely dangerous because it's mainly to protect the patient during reperfusion for the cytokine storm. That is the whole purpose of intraoperative dose. It's not immunosuppression dose at all.
So I think that is one message one would want to convey, that even if you were to tweak that, you'll probably end up harming this patient more, because he would have a very heightened inflammatory response in the postoperative period. And high acuity patients, we would not know whether their postoperative cholestasis is as a result of what you should have done in the OR or something else. So I think there is no need to tweak that. Right. So I'm so glad that you were there for this. So this is what this patient's lab data looks like in the postoperative period. So as we can all see, postoperative day 1, the transaminase is 370 and ALT of 233, and his bili is 28.3. Postoperative day 3, the bili has dropped to 10. Enzyme still about 3 times upper limit of normal. So the TAC level is 2.1 at this stage, which means that this patient has been initiated on TAC, and immunosuppression is increased by the treating unit. And on postoperative day 7, they find that there is a blip in the bilirubin as well as in the transaminases. So, Dr. Neeraj, are you there?
Neeraj was wanting to come back as panelist, so there was some.
No problem. So, Dr. Ashok, would you want to take that? So this patient's...
I got disconnected, sorry.
Okay, so this particular patient post-operative course, we see that the bilirubin on day 1 is 28, enzymes 370 and 233. It started to fall on day 3, and day 7 again there is a blip in the transaminases as well as the bilirubin. The unit increased the immunosuppression on day 3, thinking that the TAC level was low. So what is your interpretation of the tests of liver function?
But what's the clinical state of this patient? Is he
even all of that is, he's been extubated and he's in the ITU and he's passing urine. We can see that the creatinine value on day 3 is 1.2, and that is why the unit felt that on day 3 his immunosuppression was low and he was the tacrolimus was high. On day 7, we find that even though the trough levels are 5.4, but the enzymes and bili have gone up.
Yeah, so obviously till day 3 he is fine. On day 7 his bilirubin has gone up. Doesn't look like rejection to me.
Right.
It looks more like maybe sepsis or some other cause of graft dysfunction. And
yes, that's correct. So this particular patient has an early graft dysfunction. Though having said that, we don't have access to a number of other important things as to what is happening to the INR, what is happening to the drain outputs. So they are also extremely relevant in a patient like this, as also the sensorium, the features of SIRS, whether they are present or not. But this is the information we've been provided with. So his bilirubin fell and then started to go up again, and it peaked to a level of 26 milligrams per deciliter. And the transaminases soared to about 6 times upper limit of normal, and the cholestatic enzymes were also high. So let's just talk briefly about this. Dr. Kaushal, you work primarily in a living donor transplant unit. So would you like to define for us early allograft dysfunction in the context of living donor transplant?
So I think apart from once you've excluded the other technical issues which lead to graft dysfunction in the early post-op period, I think early allograft dysfunction as it is defined in LDLT consists of hyperbilirubinemia, coagulopathy, with or without features of portal hypertension and encephalopathy. So I think the most important thing which differs in LDLT setting from DDLT setting is the appearance of ascites, along with hyperbilirubinemia and coagulopathy. Because the concept is that it is mainly driven by a small volume graft or small for size syndrome kind of picture, wherein even though the graft volume absolutely was normal, but since the patient was sick, for that sick recipient, this graft turned out to be of low volume, and that leads to early allograft dysfunction in LDLT setting. So apart from other differential diagnosis, this would definitely fall into a category of early allograft dysfunction in an LDLT patient.
Dr. Amit, would you like to add something to that?
I would keep the possibility of sepsis also in mind. In fact, I would think of sepsis first before, well, day 3, the TLC is rising from 6,000 to 11,000. The enzymes are rising, the creatinine is also rising. So it could be both. I agree that with low GRWR, this will be in my mind, but I would even keep sepsis before increasing the immunosuppression. So these would be 2 thoughts which I would.
Yeah, I'm not saying I'm excluding sepsis. Since you asked me to define EAD,
that's fine. So that's fine.
Sepsis is definitely a possibility.
Yeah. So inherent to the definition of allograft dysfunction is that you have ruled out all other things, including the plumbing disorders as well as systemic infection. So that is inherent to the definition. So this gentleman, we are told, has got high drain output. So Dr. Naveen, what is your take on high drain outputs in a patient post-transplant? Somebody like this, and would you just like to spell out the differential?
Yes, sir. So somebody like
Dr. Amit, sorry.
Do you have information about the shunt being done in this patient?
No, sir, that information is not there.
Okay.
So of course, talking about this patient who already was sick with high metabolic demands and had a smaller graft of 0.7 GRWR. So this patient would fit in, if everything else is excluded, in small for size syndrome, with the high ascites and high bilirubin at day 7. Of course, we don't have information about the coagulopathy and encephalopathy, the sensorium of the patient, but if everything else is, it would fit in that. So the definition, I think, would go like, and day 7, if we have a bili of more than 10, INR of more than 1.6 with ascites encephalopathy, in such a patient with low GRWR would fit in a category of small for size.
Right. And would you like to give a differential diagnosis of high drain output? Again, I think this is
of course technical, sir. We have to see if hepatic veins and other things are okay, if there's no clot or some technical issues with that. In sepsis also, sometimes we can see the drain output going up with the stiff liver and not so well liver, most likely.
I think I can suggest one with the high drain output, low GRWR, small for size should be coming into a bigger picture with the cholestatic pattern. Thank you.
Right. So this patient's further workup revealed that he had a mild prominence of the right posterior sectoral duct. We haven't been given the details of the number of ducts or what anastomosis was fashioned, and there was a perihepatic collection. The collection was drained. We are not told whether it was ascites or it was bile. His blood culture continues to test positive for E. coli, and his CMV DNA is negative, and the Doppler is normal. So is this a small for size syndrome? Dr. Bala, what is your take on that? Because again, your unit has published on this not so long ago. So do you think that this patient has got a small for size syndrome, and would you like to define it for our audience?
Well, I think I am more worried about the sepsis. See, this patient, when you're taking him up for surgery, the blood culture was positive. So in our unit, we do not take up a culture positive patient for a transplant. As many of the panelists said, we would treat the patient with antibiotics and wait for at least 4 to 5 days for stabilization. So I think the issue here is sepsis. Well, definitely the GRW was 0.7. If there are no technical issues, then I would put sepsis as the #1 cause for the cholestasis on day 5. Definitely, as Dr. Naveen said, the graft would be stiff when there is sepsis. The patient might have been on inotropes in the first few days. I don't have information for that. So sepsis would be #1 differential diagnosis. Small foci also can be considered. I have no information on the INAP, but we often see ascites for quite some time after liver transplant. So I'm not sure whether we can define small and say that this is small foci. Looks more like a cholestasis of sepsis.
Dharmesh, would you like to look at the chat box also? One odd questions are there.
Sir, can we take them at the end of the discussion, because that will just take away from the flow of thoughts.
Okay.
We will surely take them up, and if there are any suggestions, I would request anybody to probably just interject and say that, please. So supposing this patient was not culture positive, Dr. Dinesh, and this patient on table had a GRWR of 0.7, and you know that he's a high melder, would you have done anything extra in the OR?
Extra on table, you mean?
Yes, yes.
No, we do not do shunts to reduce the portal pressure. We would just ensure that the anterior sector is not congested. Technically, otherwise we would not do anything intra.
Dr. Amit, what's your take on that? So
we would definitely intervene in such a patients. As a unit protocol, we've been doing it. Even if the patient is not so sick, even if the patient is elective and the GRWR is less than 8, we would think of something. And we have a paper which we have published, and we have made an arbitrary guideline which we feel is scientific. If the GRWR is less than 0.8, we would have maybe 3 situations where the GRWR is between 0.75 to 0.8, between 0.7 to 0.75, and less than 0.7. So between 0.7 to 0.75 to 0.8, slight low, we would probably get away with just splenic artery ligation. Between 0.7 to 0.75, most likely we will do a shunt, but sometimes splenic artery ligation might help. But that less than 0.7, we would definitely do a shunt. So we are the unit who believes that portal pressure can be detrimental, and we have to decrease it, because if you don't do it, what else would you do? That becomes a problem. So less than 0.8 or definitely less than 0.75, we would intervene. In this patient, even if this was not a sick patient, we would have made shunt, and probably in this patient, we would have made shunt. So 0.7, we would make a shunt.
Right. And do you do any other pressure studies, the portal vein pressure or the portal vein flows, or do you just go by the weight?
No. So we would, so there are, once you have low GRWR, then there are 2 schools of thought. One, which we belong to, feel that pressure is more important, and the other school believes that the volume of perfusion is more important. We feel that volume is a slightly observer based and might not be such a clean, plus you would do ultrasound after the liver is perfused. So by the time injury would have started, so we go by pressure. If the total pressure is more than 20, we would try to bring it down, ideally to less than 16. So we would, so if the pressure is 20, 21, we would make a shunt and try to bring it down to ideally less than 16, but definitely less than 80.
Sure. So coming back to the theme of the meeting, and how would we now modify the immunosuppression? Increase, decrease, or same? Dr. Naveen, would you want to take that? I think we just need to rush through the remaining
So
slides.
this patient, actually, if he's cholestatic, sir, we have to actually decrease the immunosuppression, because the TAC levels would suddenly jump with cholestasis. That is one thing. Sepsis is another thing. So we need to keep a close watch, keep looking at the procals and PCTs, but most importantly, keeping TAC level low and repeating frequently, so that with cholestasis, if they jump higher, there'll be high chances of this thing, and delaying MMF as well, as long as we can, because this patient, if they are sick, as was mentioned earlier, they would not reject as much as in this case.
Right. So I think this is probably something that I added from my side. Always any undrained collection. This patient already had 1 collection, and histology, probably both of them, but in that order. So this patient was subjected to biopsy, and again we saw this yesterday. Dr. Mukul had presented slides on rejection, and you can see these ballooned feathery hepatocytes, which is the hallmark of cholestasis. You see cholestasis as which is hepatocytic as well as canalicular in this slide. And then this is a portal tract, which clearly tells you that there is no endothelitis, there is no ductulitis, and you do not see any sprinkling of inflammation in the lobule. So you were actually not dealing with the patient of TCL mediated rejection. And this was probably all because of sepsis or cholestasis, intrahepatic cholestasis due to sepsis. So I think this would be probably one of the last questions. Maybe I think Ashok, you can take that. You are a Plex Avid unit. So what is your take on someone who's got significant cholestasis, has got a graft dysfunction like this patient has? Would you be a proponent of plasmapheresis in this situation?
No, most of the time we just wait for a while with manipulation at the first person like sepsis and the rejection, balancing with minimum of tacrolimus and inhibiting antimetabolites and main stable steroids. And plasmapheresis, we most of the time differ in this type of patients, and we just wait for 5 to 7 days or 10 days, just see the course. We don't prefer to go for plasmapheresis, particularly when only purely cholestasis and think of having a small pus size or sepsis is hovering. So I'll just wait and watch with the minimum of immunosuppression.
So do you think the high bilirubin in any way is detrimental to the graft outcome?
Yeah, that is definitely detrimental, but there is no measure to go for. We have to see for the sepsis to resolve, if any biliary or any collections or outflow. And another one thing, what we do often is that we see the total perfusion for the gram of the tissue, it's more than 200. Little bit of beta blockers, sometimes we can add to help also in that way. So these are the small things we add on, but definitely we want to go for plasmapheresis.
So
Dr.
what beta
Kaushal
blocker
wants to
would
make
you
a
use?
point. Sir, Dr. Kaushal wants to make a point.
Yeah, sir. Sir Kaushal, please.
Yeah, so I think the issue which you raised of bilirubin, so there's a concept of bilirubin toxicity in the post-operative period. So I think if you have adequately corrected your sepsis or treated your sepsis and excluded all other causes, there wouldn't be any harm in going ahead with plasmapheresis, say 3 to 5 sessions in this patient. This will give us time, reduce the bilirubin, and the concept of bilirubin toxicity also would be taken care of.
Any of the other panelists for
actually just a thing, if and just a suggestion, if somebody wants to do plasmapheresis which would cause immune paralysis and we are waiting for this patient, like he might get septic, would anybody want to use filters rather than plasmapheresis? Because the immune paralysis is much more with this one. I know the kidney is borderline, there can be bile cast nephropathy and other things also in this patient. If we are this thing, what is the suggestion? Because plasmapheresis can cause more infections as well, of course, that we know. Filters versus plasmapheresis, a doubt and a question to the panel.
So you are suggesting plasmapheresis along with filtration, right?
No, sir. Without plasmapheresis, only filter. Bilirubin filters that are available these days.
I think Naveen is suggesting filters which specifically remove only bilirubin.
I do, sir.
So anyone wants to take this question? I have zero experience with either.
Yeah, so I think your first thing, balance between sepsis and risk of rejection. I think we definitely need to, the risk of rejection is not as much and probably lower the immunosuppression, and sepsis is a bigger problem. We as a unit would do, I don't remember what happened in this patient, but we do plasmapheresis often in these situations. And I mean, I can't really give you numbers, but with reasonable success. So I would favor plasmapheresis.
Right.
Dr. Subhash Gupta also wants.
Yeah, Dr. Subhash.
So please unmute yourself.
Yeah.
I remember this case very well. I think that part has somehow got missed. I was waiting for it. On the biopsy was a transjugular liver biopsy, and that showed a sort of gradient of 5 or 7. And I think just before the biopsy, that was dilated, the hepatic vein. I think he improved considerably after that. So I don't know whether, this case I remember very well. This is a very sort of more than 70% of the unit people didn't want to do this case. They said that he's got E. coli in the culture and, but he was a VIP. He was known to Dr. Kaushal, Dr. Vikas Singla, spent some time in Medanta. I remember this case very well. But the turning point was the hepatic venous dilatation. We don't know whether it was the cause or whether it was rejection, but subsequent to that, he improved dramatically. Didn't need to do any plasmapheresis, nothing.
But I think the biopsy is not suggesting, at least in the tract, that they have said, of course, there isn't a central vein shown here. There is a portal tract, but these are the two slides provided to me by Sanjiv. So I don't know if there is some information that he has, and maybe
remember this case very well. We should ask him.
We will ask him for the final word. So I think the take-home message is that, at least was also said by someone else, that if someone has got a microbiologically proven sepsis, one should be extremely cautious in taking these patients up for transplant. And like I said, community acquired versus nosocomial, whether features of sepsis are there or not, trend that you see in a given patient, and what is the virulence of the bug. So I think all these things should be factored in, along with a sufficient duration of an appropriate antimicrobial before a call is taken to transplant such a patient. And like was also mentioned, a combination of adverse factors to be avoided in a high acuity patient, and I just enumerate a few here. These should definitely not be there. So you don't want all the bad things to be happening to a given patient. Most importantly, and which is the theme of this meeting, not all enzyme elevations and bilirubin blips are TCMR. So oftentimes we tend to think that if the enzyme has jumped, say, 2 or 3 folds over a short period of time, along with a rise in bilirubin, that this is a rejection. So the patient profiling is extremely important. And you should have a low threshold for cross-sectional imaging and liver biopsy when in doubt, especially if you want to pulse. So that is something that would really be the message from this case, that if at any time you want to pulse a given patient, you should have histology at your disposal before you take that call. Oftentimes I see that referrals come saying that the patient was pulsed, and because it did not improve, and after that the biopsy was done. So I think you cannot interpret the liver histology well at that stage. Thank you so much. And maybe Dr. Saigal, we can have a word from you, because
I think Dharmesh, fantastic presentation, very interesting, discussion you had, and I think a couple of points were really, impressive, especially that, when not to pulse. I think that's a very important point, because our I'm audible, right? Because our tendency to pulse with rising enzymes is something which needs to be taken with very lot of caution. And I mean, end of the day, like, this patient did well, and as Dr. Subhash mentioned, I mean, it's the end result which is really important. But there are a lot of learning points which we had during the course of the case, and I think Dharmesh, you had absolutely been brilliant in in the entire discussion.
The patient
Now
was
I'll hand it over. I'll actually pass it on to Professor Anand, because we have a next state of art lecture.
No, I've received a message. I've received a message from the organizers that we have exceeded time and we should not go for more questions on this case. And I think we'll move on to the next presentation.
So maybe we can later on answer these questions by chat box only.
Okay. By chat box it can be answered. And I'll request Dr. Akash Shukla to introduce the next speaker. Dr. Akash Shukla. Dr. Akash Shukla, can you hear me?
I think there's a problem in my audio. So sorry.
I can hear you. No, you just unmute yourself.
Dr. Akash, you are unmuted. Please speak.
All right, can I request Dr. Puneet Singla to kindly introduce the next speaker?
So I would like to welcome Dr. Jalal for the next state-of-the-art art lecture that is on molecular diagnostic tools and biomarkers for rejection in liver transplantation. So Dr. Jalal, please.
Oh, thank you for the kind introduction. Thanks to the organizing committee for inviting me. I think my background is a little dark. It's early in the morning. I'll share my screen. Thank you, Sanjiv and everyone. It's nice to see you all. Let me share my screen. One second. I just want to show. Okay. Can you see my screen here?
Yes, sir.
Hello?
Yes, sir, we can see.
Okay, you can hear me, right? Okay, all right. Is the screen visible?
Yes, sir, it's visible, sir.
Okay. All right. So we're going to talk about excuse me. Sorry, I just need to go back to. So that's fine. So there's a very dark background here. I just need to make sure that you know, the slides I can see properly. All right, so the topic for discussion is molecular diagnostic tools and biomarkers for rejection or liver transplantation. Okay, we go briefly about the history of immunosuppression and the challenges we're facing, and we'll review the biomarkers to optimize immunosuppression, and then we'll talk about molecular diagnostic tools in the diagnosis of rejection. So, you know, this starts with a failure. Every big thing starts with a failure. And as you all know, we already discussed that Dr. Starzl first performed the successful liver transplant in Denver in 1967. So initially, 1963, he failed. And he didn't give up. 1967, 11 transplants were done, actually, total 16, but the longest survival was 34 days because there had been high incidence of graft rejection. What we needed is better livers and more so better immunosuppression. So in July 67, one kid got transplanted. Post-op, patient got ALG and azathioprine and steroid. And subsequently, few more patients were transplanted. And that led to longer survival. But really didn't change until cyclosporine came in picture from soil fungus by Borel. It was approved by FDA in 1983. So this is actually not Grand Canyon. This is Texas called Palo Duro Canyon. We all know that subsequently, the next big step was tacrolimus in 1990s, followed by sirolimus. The immunological control is important. And also we know that transplanted livers rarely reject. And it has gone so successful now that in US, every 9 minutes, someone is added to the waiting list. And on average, 95 transplants take place every day. And one organ donor can save 8 lives. In US, the results are outstanding, not the best, but still very remarkable. 5-year survival exceeds 80%. And in Europe, if you see, it started low in 1980s, very poor survival. But as it progressed with the immunosuppression protocol improvement, it reached same as here. However, as we discussed earlier today, that the problems are side effects from the immunosuppression for long term. So a long way to go. What are the challenges? It's a balancing act. We have the immunosuppression-related complications, problem with adherence, and the cost. We want to minimize or even withdraw immunosuppression if possible. However, if we do it early enough, to do the benefit the renal metabolic parameters, as we all know, where the maximum benefit comes with early withdrawal or reduction in immunosuppression. Also, it caused development of active rejection. So how does it happen? It has been discussed by Dr. Arora outstandingly. So we got the foreign antigen from newly transplanted organ to the APCs, resulting in activation of T cells. The activated T cells then release the interleukin-2, which binds to IL-2 receptors on the surface. In this cascade, interaction between CD2 and B7 ligand is also needed as a second signal for optimal T cell activation and IL-2 production, leads to more infiltration of graft by host T cells and damage the graft. So it's more inflammation than anything else. So we have direct pathway where the recipient T cells recognize the allogenic donor APC through donor MHC, or you have got indirect pathway where the recipient APCs are phagocytosed by, donor APCs are phagocytosed, so donor MHCs are phagocytosed, taken up by recipient APC, and then internalized by T cells, or it's a semi-direct pathway where actually the recipient APCs acquire intact MHC molecules and with the donor APCs, and then give it to the TCR activation. We all know that in presence of inflammatory cytokines or pro-inflammatory cytokines, interleukin 12 or 4, CD4 T cells become Th1 or Th2 cells and causing the damage. On the other hand, if you have TGF-beta without the pro-inflammatory cytokines, then this is conversion to Tregs, which are protective. The whole thing is balance in life, that between these pro-inflammatory cells and anti-rejection Tregs. So the challenges are, again, the current monitoring after transplant relies on clinical judgment on the measurement of the drug levels, which is very antique. No proper assessment of real suppression of the immunological system. LFTs or biopsies are either suboptimal or impractical. And obviously, we need a personalized approach. So what we can do about it? So it's the definition of a biomarker. That's the theoretical part. A characteristic that is objectively measured and evaluated as an indicator of normal biological process, pathogenic process, or pharmacological response to a therapeutic intervention. That's the definition of biomarker. But ideally, what you're looking for, something which is sensitive with a true positive rate. It identifies transplant patients who are suffering from rejection accurately, specific with true negative rate, discriminate rejection from other issues. We commonly encounter this problem. Other cause of liver dysfunction, infection, or even Hep C infection, which has been non-invasive. We can get it from saliva, peripheral blood, or other body fluids. Rapidly available. We don't want to wait for months to get it back. Inexpensive, and with a large sample size, the trial has been done prospectively. At least one independent validation has been done. So we are looking for this for the last 30 years, even more. So this was urinary neopterin and a biomarker, attempted, failed. Still relying on liver enzymes, first to figure out whether the patient is going for rejection or not. However, if you look at the sensitivity and specificity of liver enzymes, it's very low. The area under the receiver operating curve is only 0.5. Outputs are slightly better, but not outstanding. The first potential biomarker study was cytokines, because of the reason outlined before, the mechanism. So if you see here, again, I'll go through next few slides, not to test your eyesight, but just to show how many studies have been done and failed. Whenever there are too many studies, obviously you know nothing is working. So the best study actually from eosinophilia, which positive performance, but again, long way to go. So those are inflammatory markers. What about non-inflammatory markers? Alpha GST, even Dr. Nagral did it, and other parameters, and really still a lot of conflicting results. So what about bile biomarkers? Well, I don't know how you collect the bile all the time they teach you, but again, it didn't work. Some patients develop ascites. They tried inflammatory marker from ascites as well. And as you see, that didn't work either. So there's a lot of gray areas, we have a lot to work. Nowadays, things have moved, the era of omics. We have genomics, which is genome-wide association studies to identify the increased susceptibility to ACR, proteomics, more importantly, transcriptomics. So transcriptomics is focusing on messenger RNA, microRNA, and long non-coding RNAs, which regulate the gene expression. And of course, we have metabolomics. This slide shows all this in a summary. The immuno has been FDA approved, but hasn't picked up in the liver world very much. And everything else still still not the best to identify. Okay, so if we look at that led to a very bold approach. This is a meta-analysis and a systematic review and meta-analysis published in 2019. If you look at the 560 studies, 104 full text articles, but only 15 qualified for assessment. And out of that, 4 went for quantitative synthesis. Again, these are the 15 studies just to show how they have been analyzed. But the conclusion is the interleukin-2 receptor expression demonstrated highest diagnostic accuracy, while the peripheral eosinophil count was only marker tested in more than one study. Still, liver biopsy remains superior to non-invasive diagnostic biomarkers, but need more studies. What about the DSAs? Are they relevant? We are learning a lot about it. So we have preformed donor-specific antibodies exposed to foreign HLAs prior to transplant. The de novo DSAs, the recipient is exposed following the transplant. And as you know that with HLA-2, that can lead to graft fibrosis and increased risk of rejection. And in steroid-resistant patients, maybe it has a value so that it can lead to diagnosis of antibody-mediated rejection. So do we have any hope, the light at the end of the tunnel? Well, possibly we do. So if you look at this cell-free DNA, immediately following transplant, allograft ischemia causes a reperfusion injury that leads to donor-derived fraction of cell-free DNA to rise. It comes down subsequently, and then when injury happens again, it starts going up. One of the important things in biomarker and transplantation is to diagnose and predict rejection and early, and so that before the graft dysfunction happens. So in the studies, this study with Jos, he touched a little bit yesterday with rejection versus perfect transplant, or rejection versus acute injury but not rejection. It's got acute dysfunction, not rejection, or acute rejection versus non-acute rejection. If you look at the AUC, with very good, it's more than 0.9. But more interestingly, the proportion of donor-derived cell-free DNA increased serially, preceding elevation of liver enzymes and clinically evident graft dysfunction, and also decreased serially following the resolution of rejection. Another study here, they used the data from clinical trial and organ transplantation cohort and did blood gene expression, both Hep C and non-Hep C patients. And what they found with the blood gene expression studies, they took 36 gene assays, which pre-identified. Again, AUC is 0.92. So we have some hope. What about the molecular diagnostic tools in the diagnosis of rejection? As you know, the current standard of care for the diagnosis, as I mentioned, is still histology, following BAMF guidelines. However, even with the expert pathologists, they have wide variation to make the diagnosis of T-cell rejection. It's low to moderate, 0.15 to 0.62 in one of the studies. So there's a lot to do, especially now when you're talking about histological diagnosis of antibody-mediated rejection, which is even more difficult to make. Now, people are recognizing that molecular analysis of liver transplant biopsies are necessary to detect rejection, to resolve ambiguities, and can assist to guide immunosuppression regime. So this study, interliver study, this is a system they used. They used the gene profiling with the diagnosing rejection in liver transplant biopsies using microarray measurement of gene expression and machine learning. So we have relatively normal, rejection, injury, late, and also fibrosis. If you see, they're trying to see the scatter point and see whether it can detect rejection more convincing. So they came up with this diagnostic system report, which might be commercially available after validation in multi-center trials. The BAMF, the working group, realized this point. So what they're saying is that they also identified 70 gene B-hot panel that includes most pertinent genes related to rejection, tolerance, viral infection, and innate and adaptive immune responses. So that working group, they believe a pathogenesis and pathway-based molecular approach would be valuable for investigators and promote therapeutic decision-making and in clinical trials. And this is available to everybody. So data integration platform design is cloud-based. Now everything is cloud-based. And if you see the data production, histology, molecular, clinical, and the web interface, and to centralize, check, and validate the data, and then participating centers can build the analytic tools. So the take-home points are, with the advancement of next-generation sequencing technology and diagnostic assays, donor-derived cell-free DNA, mRNA, microarray profiling of differentially expressed genes, as well as characterization of cytokine responses and immunophenotypic shifts following the transplant, it may be possible in future to predict and diagnose rejection, especially early. The non-invasive biomarkers also may help in minimizing immunosuppression, individualizing care, and preventing long-term side effects. However, at present, none of the biomarkers are ready for prime time. They need validation. And also, we need to engage expert pathologists to use both histology criteria and molecular analysis and derive an integrated classification. With that, thank you again for the opportunity. I will take questions.
Thank you very much.
Thank you, Dr. Jalal. Dr. Akash Shukla, would you like to take on from here?
Yeah, sure. Thank you. Thank you so much. I would like to now invite, because for
one have some questions also on this talk.
Yeah, sure.
She was complaining.
We can take a couple of questions, I think.
I had it handy.
I didn't find any questions in the chat box.
Yeah, Akash, just to clarify, we got 5 minutes dedicated, question answer session after each talk. And just to introduce, like Professor Jalal is a very dear friend of mine, and at one time we have been in the same institute, and he is a very active hepatologist from US now. So I wanted actually to understand about a future step in this rejection story, because we restrict ourselves to liver biopsy and we don't know what's next. So with that intent, I think Dr. Jalal has done a great job. Prasoon, just wanted to know from you, you did mention about cell-free DNA and all, which I think is an interesting thing. So what is the practical utility of these newer tools? Are we doing some ongoing studies? Is there any available data on these? Because most of studies are a couple of years back. So any current, exciting, some sort of trial going on, which you can highlight for our knowledge?
Yeah. So again, most of the trials are center specific. That's the limitation for all the biomarker studies. And that's why we need to have multi-center approach. The cell-free DNA study which I quoted actually from Levitsky's group, they have two, and it's published just a couple of months ago, in 2021, cell-free DNA study. And the other one, which I mentioned about gene microarray, was published last year. So again, there's a lot of movement going in the direction of microRNA, gene expression studies, and cell-free DNAs. If you look, last few years, last 5 years, I could see 5 to 10 studies came out. So, but again, it needs validation in wider setting. I think from the pathology side, that's where the BAMF working group came up. They realized that there is more work to do. They, as pathologists, they're not doing a great job by this classification system alone. And same way, the clinicians need to come up and work together to move forward.
Dr. Subhash Gupta has a question.
Yeah, sometimes we use surrogate markers such as EBV virus load or CMV viral load as a sort of marker for immunosuppression. So do you think I read one article on EBV virus copies in the transplant period to decide on the level of immunosuppression. And certainly we use a lot of this in our unit, where we look at CMV viral, not so much for treatment, but as to know the level of immunosuppression the person has been subjected to. If the CMV counts are absent, then obviously there is sufficient immunosuppression. And if they're high, then we know they are over immunosuppressed. I just want to know what are the thoughts on this, or Dr. Jalal and the other panelists on this.
So I'll say about my take on it, but obviously I'll wait to hear from other panelists. From my side, the problem is, as you know, the CMB can mimic rejection, can induce rejection, and then it can confuse the pathologist. But yes, I mean, it may say that patient is over immunosuppressed, but we definitely don't use it as surrogate marker in our setup. But I would like to hear from other people.
Dharmesh, Kaushal, are you using viral loads?
No, sir. It's actually too insensitive to be used in this setting, so we don't, unless there is a suspicion either of a CMV infection disease / in PTLDs, one would be doing the EBV loads, and in pediatric patients we do that, especially when there is a mismatch, but not to know the level of immunosuppression.
So basically what Dr. Jalal has told us is that there is a light at the end of the tunnel, but for the near short-term measures, we have to bank on histology and bank criteria only. Is that clear? Is that what the message is for the people?
Yeah, that's the message I wanted to give so far.
Okay, thank you very much. Dr. Akash for the next talk.
Thank you.
Thank you very much. Can I ask a quick question to Dr. Jalal, if you're still there?
Sure.
Yeah. So you did talk of Jivas. So what exactly are we looking at when we are talking of Jivas in this subgroup?
So what the people did is they're trying to identify a subset of genes which can predict rejection. So they're comparing a subset with the liver biopsy to win rejection versus the blood is already taken. Before the rejection happens, they're still measuring it. And with the Jivas, they're trying to identify any specific genes, a set of genes, which can predict or even diagnose rejection.
Okay, thank you very much. And I would like to now invite the next speaker, and that is Professor Vinendra Pamecha, who is a fellow of European Board of Surgery in hepatobiliary and pancreatic surgery, currently the professor and head of liver transplant and HPV surgery at the ILBS, New Delhi in India. So over to you, Dr. Pamecha.
Okay, can you hear me?
Yes, we can hear you.
Okay, and you can see my slides as well.
Yes.
Thank you very much, Dr. Akash, and thanks to Professor Subhash Gupta and Dr. Saigal for the kind invitation. So what I'm going to do over the next 15 minutes or so is to talk about early graft dysfunction diagnosis and management. So I'll discuss about the controversy in the definition, then the risk factors, and then how to diagnose and manage this condition. Okay. So allograft dysfunction, if you start with primary non-function, which is basically the graft doesn't really work, and this happens within 7 days. Its incidence is about 1 to 5%. It is more common in cadaveric setting than live donor liver transplantation. You rarely see a primary non-function in live donor liver transplantation because of the healthy grafts and the way this operation is being done. And then when we come to early graft dysfunction, this is basically defined from day 7 to maybe 3 or 6 months. The incidence is about 10 to 30%, and it is associated with a graft loss of around 10 to 25%. So the mortality is somewhere between 10 to 25% in this group of patients. It is more commonly seen in live donor liver transplantation than cadaveric transplant. And that's because of the partial graft, and the liver has to regenerate and then meet the metabolic demand of the recipient. So because of the size of this graft, that's why it is more common in the live donor liver transplant setting. Late graft dysfunction is defined maybe after 3 to 6 months. The definition in the literature is not clear about the duration from where to define this particular entities. So why it is important to know this? Because the survival is inferior when we compare it with patients with adequate graft function. There is a prolonged hospital course which is very resource intensive as well. And it is important to identify early to prevent complication and maybe to decide about retransplantation as well. So these are the definitions which are there in the literature. And these were earlier definitions which were mainly based on levels of ASTs. And that was basically more than 2000 or more than 2500 ALTs within first 7 days of transplant. That was the definition being used for initial poor graft function. Then in 2010, Althoff defined the definition, which was based on bilirubin and INR. That is a bilirubin more than 10 milligram per dl on day 7 or an INR of more than 1.6 on day 7. And they also included the AST component, which is basically more than 2000 within the first 7 post-operative days. So this is the definition which was derived from cadaveric setting. And there's been quite a lot of controversy whether this can be used for the live donor setting or not, because the way the graft functions are a bit different in cadaveric and live liver transplant settings. So this is a definition then being validated into live donor liver transplant settings as well. Again, this was done in A2R data, that is the American data, which was used as same bilirubin or INR on day 7. And basically the predictive value of all these other definitions are quite low. Okumara defined it as again day 10, bilirubin of 10 and INR of 1.6 on day 7. Again, the predictive value was low as well. And Ikagami actually had further specified the definition being bilirubin of more than 20 for 7 days after post-operative day 7. And that was very specific actually. It was, and once you have that type of patient, then the mortality in that group of patient is very high. That is above 90%. We ourselves have tried to define it further, and we thought that there should be dynamicity in the definition in order to exclude all other components of which can lead to early graft dysfunction, because we all know that the early graft dysfunction is an entity where you have to exclude all the other treatable causes. Then only we can come to conclusion that this is primarily because of graft dysfunction. So our definition is basically bilirubin of more than 10 plus INR of more than 1.5 plus a urea of more than 100 for 5 consecutive days after day 7. And we had a very high predictive value of around 98% on this patient. So if you have this type of patient, then the mortality of this patient will be above 90%. In spite of all resources being used to prevent that. So this is what it is important, because then you can decide on retransplantation whether to offer a retransplant or not, and that becomes particularly important in the live donor setting because of the the availability of graft will be a very rare in live donor liver transplant setting. So you need to have a very specific definition to define this entity. So what are the risk factors? The early graft dysfunction, if you see, it's a spectrum of things which can cause this. This may be donor related, that is age, BMI, comorbidity, prolonged ICU stay, hemodynamic instability, or if the patient.
Did you have your dinner already?
Sorry, not yet. I haven't had the dinner yet.
I think you can just ignore that.
Okay, so that was good. So, okay. Am I audible? Am I okay?
Yes. You're very much audible. Okay.
Oh, I thought it's not that boring that people are worried about dinner.
No. Please go ahead.
Okay. So you need to then the other things are cause of death. So this is more common with neurological causes of death. So elderly patient with cerebrovascular accident, those donors are at a higher susceptibility of developing early graft dysfunction if you use those. Then obviously donation after cardiac death, marginal donors, and serum sodium as well. Then graft-related fracture like stenosis, steatohepatitis, then the techniques of flush, again, there have been lots of techniques which have evolved over the time. And different techniques have been shown that they can actually cause early graft dysfunction as well. Then recipient, that is the most important. What is the metabolic demand of the recipient? That is a MELD score. Then again, whether it is a group compatible, incompatible, again, comorbid status. If you're transplanting a patient with ALF or ACLF, in particular ACLF, which are very high risk, then again, they are at a high risk of developing early graft dysfunction. Then a previous surgery, previous sepsis, which was being discussed in the previous session, that how sepsis actually can alter the course of events in a particular patient. Previous episodes of AKI, sarcopenia, very common in Indian patient actually, because most of them decide late. Again, refractory site is very much common in Indian patients. We need to keep an eye on all those things. Then portal vein thrombosis, post-operative complication. Again, intraoperatively, hemodynamic status, blood loss, if there is a long warm ischemia time, how much time the surgery took, and whether this was a complex reconstruction, and logistics about whether it was a prolonged cold ischemia time, particularly in cadaveric setting. So why I'm enumerating all these factors is whenever you're evaluating a patient, you should keep all this spectrum in the mind, and also for a center to learn that how we can actually decrease the incidences of this, or not to add multiple factors in order to develop early graft dysfunction. And then coming to partial grafts, that is live donor liver transplantation. The entity initially was thought to be a small for size, but now we have learned that it is a portal hyperperfusion which causes. So it's not exactly GRWR which is related to it. It is actually how much is the portal flow and pressure, and how much is the actual graft weight, which can lead to a small for size syndrome or a small for perfusion syndrome. So just comparing DDLT versus LDLT, in DDLT it is more common because of ischemia perfusion injury and a longer CIT and WIT, and marginal livers are being used more and more. Whereas in LDLT, it is portal hyperperfusion, liver has to degenerate, and also it is technically more complex operation with a more risk of infections as well. So that's where the things are different in terms of development of early graft dysfunction. So it's a spectrum of injury, which can be from mild hepatic dysfunction to just isolated hyperbilirubinemia, or it can lead to a prolonged cholestasis, ascites formation, coagulopathy, leading to septic complication, and which can lead to renal and pulmonary failure. And if this doesn't get better or not timely intervened, then it will lead to a retransplantation or death. So that's the spectrum. And most of the patient actually will be within the spectrum of isolated hyperbilirubinemia associated with sepsis. And most of this will recover over the time, but you need to really treat them very aggressively in order not to develop problems. So coming to how to go about this. So if you've got a patient who is improving, who's hemodynamically stable, his lactate is coming down, acidosis is improving, he's got an adequate urine output, is got an improving INR with decreasing bilirubin, and he's got a normal glucose metabolism with a improving mental status as well. That all means that you've got a healthy graft function and you just continue same management. But if the patient is not showing all those things, signs or some of this, then you need to really check into what the LFT pattern is. If it is predominantly hepatocellular pattern, then, and if it is associated with signs of liver failure as well, like prolonged INR, encephalopathy, hypoglycemia, or lactic acidosis, then basically you need to see whether these are improving over the time. Then it is just maybe an ischemia reperfusion injury. If they are static or progressive, then you really need to rule out vascular causes, or you need to really rule out on the AMR side or ACR, which can happen in this. If this liver failure is present, that means it may be a primary non-function, or it may be a vascular causes like hepatic artery thrombosis, portal venous thrombosis, or non-thrombotic infarction or ischemic hepatitis. Obviously, you need to do an urgent imaging, which will be to start with an ultrasound. An ultrasound actually can show you if the vascularity is good, then maybe you need to do a biopsy to rule out all these other causes. If there's biliary dilatation, then you need to do an MRCP, which can be followed by ERCP or PTC, depending on whether they got a cholestatic pattern or not. Then if it is a predominantly cholestatic pattern of liver enzymes, then you need to see whether again they got a signs of liver failure. If they got signs of liver failure, then you need to see whether it is a small foy syndrome or it is just septic induced cholestatic. If there are no signs of liver failure, then again you need to rule out biliary causes or drug induced injury, which will present as cholestasis, and you have to evaluate accordingly. So how to go about it? So you need to have a thorough clinical assessment. You need to check on the hemodynamics, You need to thoroughly check on in terms of how the clinical status of the patient is. Ascites definitely they will be training more ascites after the transplant if they are developing early graft dysfunction, whether it is associated with sepsis or not, but they all will actually have increased drain outputs. You need to do regular gas and check on the labs how the progress is happening. And then you have to investigate them with ultrasound Doppler cultures you need to review. And obviously you need to see the fresh cultures as well. And you always have to maze them with CT scan of chest and down. Chest is important because there are lots of this patient will actually develop chest related complication as well. CMV you have to always check on, and if you still don't find a reason, then you have to biopsy them. And then biomarkers have been developed which can sometimes give you information which direction the patient is going in. And there was discussion about EJD and sepsis. We don't know which comes first, but they do coexist quite a lot of time, and they will impact the outcome of a patient. And basically it is always difficult to say which one came first. But when you have EJD, then the rate of sepsis is very high. This is our own data. So once in the patient who had EJD related mortality, this incidence of severe sepsis was around 85% compared to 33% in the ones who didn't have EJD related mortality. So sepsis is very high in this group of patients. And that's why they have prolonged hospital stay, ICU stay, retransfer to ICU as well, and the overall morbidity is high as well. So how we can find sepsis early in this group of patients? And there are simple things which can actually predict sepsis, like how the platelets counts are after the transplant. So what we have seen is in patient who doesn't have sepsis, the nadir platelet count will be reached on day 3. The ones who develop sepsis, the nadir platelet count will be on day 5. So if you've got a patient who has got consistent thrombocytopenia, suspect sepsis or a suspect early graft dysfunction in them, and you have to be careful in terms of hiking up immunosuppression there. And you can see that the ones who had continued to remain thrombocytopenic did develop sepsis on day 7 as well. So that's a very good predictor of where the patient is going on. And you can actually modulate your immunosuppression based on how the platelets are behaving after the transplant. And this has been shown in the DDLT setting as well, and ours was in the LDLT setting. Again, thrombocytopenia is associated with early graft dysfunction, and both post-transplant sepsis significantly impact the thrombocytopenia as well. So how to prevent sepsis in this group? I'm not going to go into details of this. Basically, you have to take all the precautions, so minimize immunosuppression, early extubation in order to decrease the chest complication, early removal of drains, then always feed them. Nutrition is most important. We basically start feeding on day 1 itself. So we'll start with ORS on day 1. And if they're tolerating well, then we'll just feed them with the NG, and we'll continue until they are getting better. So sometime our patient will be on feed because, for maybe a couple of weeks actually, because most of these Indian patients are very sarcopenic and they need nutritional support. And you need to keep an eye on fluid balances very much. I'll show you how fluid balances are important in this particular group of patients. So coming to immunosuppression, so what we learned over the time is in our group of patients, basically they don't tolerate high doses of steroids well. So what we were seeing that the incidence of severe sepsis was very high when we gave them 1 gram of methylpred at reperfusion. So then we slowly decrease it. And then basically now we only give 100 milligrams of methylpred on reperfusion. And what we've seen is the incidence of severe sepsis has come down significantly in this group of patients. When you have got an LDLT graft, there is not much of ischemia reperfusion injury. So you don't need high doses of steroids in the initial postoperative period. You can get away with a minimal immunosuppression, and that helps in preventing sepsis as well. Then it is sometimes actually difficult in live donor setting to differentiate between sepsis and rejection. And sepsis, obviously, you will have signs of fever, tachycardia, tachypnea, rising lactate, altered sensorium. Again, thrombocytopenia and cytopenias are very common with sepsis. And in sepsis-induced cholestasis, it will be an isolated hyperbilirubinemia. The rest of the things will be okay, but the bilirubin will go very high. In rejection, Most patients will be clinically well, fever may be there will be higher cytokine output, their cytopenias will be less common, but there will be raised eosinophils, and there will be doubling of transaminase. Why I'm presenting this is because this happens very common in live donor setting, that when you are going low on immunosuppression, you always think maybe it is rejection, but you have to keep an eye, because once you are low on immunosuppression, rejection, then you have to pick up the rejection very early on. You can't just let it go. So whenever there is a doubling of transaminase, you need to pick up the immunosuppression very quickly, actually. Then vascular causes, again, you need to, these are preventable and correctable causes. And the important thing about vascular causes, if you pick up early at asymptomatic stage, 80 to 100%, there will be salvage rate. If the patient is symptomatic because of a vascular cause, then the salvage rate, graft salvage rate comes down to 50%. So that applies to heart, PVT, and outflow problems as well. So you need to detect early at an asymptomatic stage, and that's why routine Doppler early on in the for twice a day for the first week is important in live donor setting. I'll just skip this bit. Yeah, there was this talk of in the panel discussion, people were talking about the small for size as well. So as I said previously, it's a portal hyperperfusion related injury. And this is just to show our data on that it's not exactly the graft weight. So this is basically 71 patients with less than 0.8 and lots of patients with more than 0.8. So there was no difference in EGD related mortality based on graft weight. But when we come down to less than 0.6, that's when the mortality becomes significant. So it is very smaller graft which are susceptible of portal hyperperfusion injury. So if you got a good outflow, then it is unlikely that you will develop small foci syndrome until 0.6 or 0.65. If you go below that, then that's where it becomes a problem. And that's where you need to think about modulating portal flow, which can be done with a portocaval shunt or a splenectomy or a snake artery ligation, which will decrease the portal flow and improve the liver regeneration. So there are risks associated with this, which is portal hypoperfusion, portal vein thrombosis, sepsis, and encephalopathy. So these are some of the criteria which have been let down about when to do a graft inflow modulation. It's based on pressure or flow or a gradient. I think gradient is more important rather than absolute values, because of how is your CVP will determine how your portal flow is going to be after the operation. And that's an important parameter to take in when you want to do portal inflow modulation. In post-operative period, if you have that entity, then maybe splenic artery embolization can help. There is some data on that, but I'm not sure because there is always risk of splenic abscess development and the development of sepsis, and whether you will be able to salvage the patient or not. I'm not 100% sure, but it is worth considering in a particular group of patients. Again, coming to fluid management, that how in small graft, if you're not looking after your in the ICU properly, can become actually in a small foci syndrome. So if you've got an overloaded patient with a high CVP, that will actually reflect onto your develop as a functional congestion, and it will develop it will reflect on your portal flow as well. And this we have shown that the CVP actually correlates with end PVP pressures. So a high CVP will actually correlate with the portal pressure after the reperfusion once the graft has gone in. And this actually will lead to higher AST, ALTs and high lactate values as well. And this will translate into higher development of early graft dysfunction as well. So you need to keep a very close eye on your fluid balances, should not overload the patient as well. And the cutoff for the CVP is around 10. So you should not let your CVP go above 10. So if you don't do volume resuscitation, use more ionotropes than volume resuscitation when the patient is unwell. And this is some of the work which we have done to prevent early graft dysfunction. This was a randomized controlled trial on the arterial perfusion on bench. And we've shown that if we do this, then the early graft dysfunction decreases in LDLT. So this is my last slide.
Wrap it up quickly.
Yeah, this is last slide. So management, you need close monitoring. You have to have a hemodynamic monitoring in terms of flow track and everything in order to see what your cardiac output is, what your SVR is, in order to assess the fluid requirement and according to titrate them. Then again, ventilator support. If the patient is in encephalopathy, don't wait long, just tube them early on. And if they're not in encephalopathy, you need to give them good NIV support in order not to develop chest sepsis. Fluid balances, as I already said, nutrition I already covered. Then prevention of sepsis and reduce immunosuppression. Always you have to treat the modifiable factors. The list is there. This all need to be aggressively looked into and treated before you come down to the definition of early graft dysfunction. The role of plasmapheresis, I would think there was some discussion in the panel discussion as well. There can be a role, there can be a patient where plasmapheresis should be considered if it is not septic. So if they are blood culture negative and though no source of sepsis, then bringing down bilirubin actually might help the patient as well. CRRT, if the ammonias are very high, then again CRRT may be helpful. And then again, if nothing is working, then you really need to look into retransplantation. And the big question is home to retransplant and how to identify those patients. That's where our definition can help people in identifying those group of patients. So early allograft dysfunction is common multifactorial entity, more common with live donor liver transplantation. An ideal definition is elusive. Then you should keep an open mind when you're evaluating this type of patient. Prevention is always better. Avoid, basically should not have a second hit. So when you got factors, you know that they're going to lead to early graft dysfunction, then you need to monitor the patient and manage them in a way that they don't develop second hit like hypertension, hypoxia. They all need to be taken care of in order to avoid a second hit. Then early detection is key, and all the modifying factors should be aggressively treated. And with good supportive treatment, majority will recover, but there will be a proportion of patients who will develop graft loss and need retransplantation, and identifying this is key. Thank you very much. Thanks everyone.
Thank you, Dr. Pamecha. We can now invite questions. And I think Naveen wants to ask one question.
I'll read out the question on his behalf.
I think so.
Has the decreasing of induction steroids increased graft dysfunction? He brought this up because of the discussion with Professor Rela in the last after the last talk, where he mentioned that induction steroids are mainly for preventing inflammatory cytokine storm. So your comments, please.
Yeah, so the answer is already, you already answered my question. So the steroids are to decrease the inflammatory cytokines, and this is what happens with the IR injury, which happens with the cadaveric liver grafts. In live donor liver transplantation, that doesn't really happen. There is not much of ischemia reperfusion injury. So you can get away from giving high doses of immunosuppression to start with. And then you can always monitor the patient which way he is going. And then you can decide whether you want to give, optimize the immunosuppression over the course of the next few days. So the problem with our patient is basically if you give them high doses of immunosuppression to start with, then you've gone onto a irreversible road, and it's difficult to come back. Okay, and once you're making them susceptible to severe sepsis, and then some of this patient, then you will lose out because of severe sepsis. On the immunosuppression side, you always have the opportunity to hike it up and then optimize it. But once a patient goes into severe sepsis, then it's very difficult. They're very difficult to manage.
Thank you very much.
That's why our policy.
I think we have exceeded time, and organizers are getting restless about the next session. I see my co-chairperson, Dr. Vikram Raut, is on line. I'll request you to close the session, please. Dr. Vikram Raut.
Hi, good evening. I think next session is on.
Hello. I would like to invite our chairperson for the next session, Professor Joy Paul.
Thank you very much.
Thank you very much. Thank you very much for all the speakers and the panelists for this session.
Thank you. Thanks a lot.
Without wasting too much time, I think we'll move on with this panel discussion. And not panel discussion, sorry, it's a symposium on ABO-incompatible liver transplant and the immunosuppression, which is specially chosen for these specific category of liver transplants. And with me, I have Dr. Naimesh Mehta, Pankaj Puri, and Vikram Raut as co-chairpersons. May I invite the first speaker, Dr. Shaleen Agarwal, who is the Director of Liver Transplant and HPB Surgery from M.A.C.E Super Specialty. And he has to speak to us about strategies for ABO-incompatible liver transplant. So Dr. Shaleen, please share your screen and start your talk.
Thank you very much, Dr. Sujoy. So at the outset, I would like to thank all the chairpersons, Dr. Sujoy, Dr. Nimesh, Dr. Raut, and Dr. Puri, for giving me this opportunity. And of course, my thanks to Dr. Sanjiv Saigal, who is the organizing chairman of this wonderful meeting. So my brief today is to talk about strategies for ABO liver transplantation. And I think it's an honor to prepare ground for the next talk by celebrated Professor Igawa, who has actually, and I would be sharing a lot of material from what he has researched and what has come into practice and clinical vogue for ABO-incompatible liver transplant all around the world. So I'll just start with a little background. Way back in the late 70s, the concept of that liver is a privileged organ and rejection in liver transplantation is less as compared to other transplants, particularly kidney transplants. That concept was given by Professor Stasel, and that was based on his report of 11 cases of pediatric ABO-incompatible liver transplant. And none of the protocols that have been laid down over the last 10 to 15 years were followed or were available at that point of time. And still, out of 11, 8 of his patients survived more than 2 months, and acute rejection was seen in only 2 of these. So there's initially in those years, there was a lot of enthusiasm about ABO-incompatible liver transplant, and the actual mechanism of rejection, especially antibody-mediated rejection, was not clearly understood at that point of time. However, in the subsequent decades of 80s and 90s, when other people tried to follow Professor Stasel's example, the results were totally dismal. And the reason probably being that most of these transplants in the subsequent decades were in the adults, and the graft survival was to the tune of less than 30% at 1 year. These strategies such as increasing the level of immunosuppression and the use of ATG did not help, and therefore the concept of ABO-incompatible liver transplantation went into cold storage for almost 8 to 10 years. So the main challenge in ABO-incompatible liver transplant is acute rejection, particularly what we call the antibody-mediated rejection, and it was the Achilles heel of this kind of or this type of liver transplant. How does it manifest? Basically, it is a kind of single organ diffuse intravascular coagulation. That has what been that term has been introduced in literature, and it consists of widespread hemorrhagic necrosis on explant pathology, as well as biliary necrosis with diffuse intrahepatic biliary strictures. So before we embark on to strategize about a successful ABO-incompatible liver transplant, we should know about the underlying mechanism of graft injury. So as we all know that B lymphocytes play a pivotal role in organizing this or initiating this antibody-mediated rejection. And along with them, we have the memory B cells and the plasma cells, which take part in initiating the antibody-mediated rejection. ABO blood group antigens are expressed widely in the liver, including the vascular endothelium, the biliary epithelium, and the RBCs also carry these antigens. So the antibodies to the foreign blood group in the graft bind to these, that is the recipient antibodies to the foreign blood group antigens in the graft bind to these antigens. That leads to complement activation and formation of what we call is known as the membrane attack complex. This membrane attack complex causes injury to the vascular and the biliary endothelium epithelium respectively, leading to capillary necrosis of these endothelia and epithelia respectively. When there's a large-scale vascular thrombosis, it manifests as hepatic necrosis and acute graft loss. While if there is a limited, slowly progressive microvascular thrombosis, it manifests in a more, I would say, benign condition, that is a diffuse intrahepatic biliary strictures. So this is how the AMR develops in ABO-incompatible liver transplant. And this is just a cartoon showing what I've just said, that the antibodies bind to the blood group antigens that are carried on the vascular endothelium, leading to complement activation, followed by formation of the membrane attack complex, which in turn results in injury to the endothelium, cell apoptosis and lysis, and finally thrombosis of the microvasculature, leading to graft damage. So what are the goals in ABO-incompatible liver transplant? So the main goal is prevention of rejection, and in particular antibody-mediated rejection to the foreign blood group or the unmatched blood group antigens in the graft. So this can be achieved in two ways. One is you remove the circulating anti-ABO antibodies in the recipient before you put in the graft with an unmatched blood group. And secondly, you prevent or reduce the production of these antibodies in the subsequent post-transplant period. So one is that you lay a ground or you create a soil in the recipient where the unmatched blood group graft can be accepted. And then you take care that these antibodies, once you have removed them, are not again, they do not develop again or produced again to cause graft injury. So now we come to the strategies that have been adopted and are now universally used to achieve these two goals. One is plasmapheresis, that is, this is the mechanical removal of the circulating antibodies. As a similar technique, immunoadsorption, and the variants of these techniques, that is the apheretic techniques. Then you have the pharmacological means, that is injection rituximab, which is basically an anti-CD20 monoclonal antibody. CD20 is the receptor that is carried on the B cells. Then other modalities that have been used to prevent or treat AMR are use of IVIG, SNECTMI, local graft portal, or the intraarterial infusion therapies. So I'll devote some time to each of these strategies in the next 7 to 8 minutes that are remaining. First and foremost is apheresis. The goal is removal of circulating ABO antibodies. This is a very mechanical procedure. The target for antibodies that have been laid down by various centers varies from as low as 1:8 to as high as 1:64. So each center has put down its own protocol as per the antibody titers at which they are comfortable taking up a patient for ABO-incompatible liver transplant. And the methods for achieving these antibody titers are plasmapheresis, immunoadsorption, cascade plasmapheresis, and the double filtration type of plasmapheresis. Plasmapheresis removes the antibody along with the recipient plasma, which is in turn replaced by donor plasma from the random donor plasma from the blood bank, as well as albumin. And the percentage of each of these two therapies, or that is plasma and albumin, varies from center to center. We have been using it from 50 to 70% plasma. These days we use 50% plasma and 50% albumin. And the plasma which has been removed from the recipient's own plasma is discarded. That is the main drawback of this technique, plasmapheresis, because along with the plasma, a lot of coagulation factors and the useful protective antibodies are lost, putting, at least theoretically, the potential recipient at risk for infections and bleeding during surgery, increased bleeding during surgery. So an alternative to plasmapheresis is the technique of immunoadsorption, where you have specific antibody columns and the plasma is filtered through these columns, and there's only selective removal of the blood group antibodies, and the rest of the plasma is put back into the patient's circulation. So the advantages of immunoadsorption are basically, since the large volume of plasma is not being lost or discarded, the hemodynamic stability is better maintained, and there are no adverse reactions related to infusion of foreign plasma. And this is again a pictorial representation of how the two techniques differ. In plasmapheresis, basically, there is a separation of blood cells from the plasma, and you discard this plasma, as a result of which the circulating ABO antibodies are removed, and you replace it with the fresh plasma and albumin. While in immunoadsorption, you are just passing the separated plasma through an antibody column, and where these antibodies are removed, and the plasma is the same plasma, that is the recipient's plasma, is put back into the patient's circulation, leading to better hemodynamic stability and lesser risk of adverse reactions related to foreign plasma. Coming to rituximab, basically rituximab has been the game changer in this entire picture of ABO-incompatible transplantation, whether it's liver, kidney. First introduced in 2003, and since then there's been resurgence of interest in ABO-incompatible liver transplant because of dramatic improvement in the outcomes. So what does the rituximab do? It suppresses the B lymphocytes. However, it does not act on the plasma cells and the memory B cells, and that is why, despite complete suppression of CD20 positive B lymphocytes by rituximab, you can still have rise in antibody titers, as we all have seen. Basically, it's a prophylactic therapy and results in a kind of chemical splenectomy. Why chemical splenectomy? Because spleen is the main storage organ for these B cells, including the plasma cells as well as the memory B cells. Onset of action of rituximab is within 2 to 3 days, and it lasts up to 66 months, maybe more. So what should be the timing and dose of rituximab? It has not yet been standardized, but usually, as per what Dr. Igawa has also recommended in his after his research, is that it should be at least 1 week prior to the planned transplant. And I think most of the centers, including ours, follow a 2-week waiting period. That is time difference between the administration of rituximab and the transplant. Again, the dosage which has been recommended by the Japanese Society is 375 milligram per meter square. And in adults, a dose of less than 300 milligram is usually considered inadequate. We use a standard dose of 350 milligram, and this has come by hit and trial, and this is not standard. Different centers have been using different doses. But what is clear is that single dose is adequate. Multiple doses does not decrease the level of that is suppression of B cells. Even one dose is good enough, but it in turn leads to increased incidence of fungal and CMV infections in the post-transplant period. Coming to splenectomy, as I just said, that spleen is a storage area for the B cells, plasma cells, and the memory B cells. Therefore, splenectomy was widely adopted in the pre-rituximab era and still being used by some centers selectively. But the main disadvantages of splenectomy during the liver transplant are that technically removing a hugely enlarged spleen along with collaterals is not an easy task. It is easier said than done. It may be associated with massive bleed and even patient loss as a result of bleeding has been reported. Even if you do you are successful with the splenectomy, there's an increased risk of postoperative infections, portal-vein thrombosis, and pancreatic fistula. And there has been study published which have compared levels of AMR in splenectomized versus non-splenectomized patients, and no difference or no impact of splenectomy was found on the incidence of AMR. And now with the introduction of rituximab, operative splenectomy has been replaced by chemical splenectomy. However, splenectomy still have a role in emergency liver transplant for ALF. There are some reports to that effect, but still the role of splenectomy has reduced very much. It has gone into the background. It's not practiced any longer. Coming next to IVIG, it's basically the function is complex, not clearly understood. All we know is that it has an immunomodulatory function. It leads to B cell apoptosis and suppression of B cells. It inhibits complement-mediated injury by reducing the generation of MAC. And it is a part of desensitization protocols in some centers, but again, it's not favored widely. May have a role in the treatment of antibody-mediated rejection, again doubtful. And Japanese multi-center study did not show any benefit of using of IVIG. Local graft infusion therapy, it involves the placement of catheter in the graft portal vein and then infusion of pharmacological agents such as methylprednisolone, prostaglandin, and gabaxate mesylate. Mechanism of action is multifarious, including anti-inflammatory, vasodilation, and prevention of platelet aggregation. However, catheter-related complications outweigh the benefits. That includes thrombosis, vessel rupture, and abdominal bleed, including graft loss. Therefore, it's no longer used in elective liver transplant, but may have some role in emergency LT in ALF, as has been reported from some Japanese centers. So coming to the desensitization protocols, all the protocols that are used currently are modifications of the Japanese protocol, and it's been widely successful. The currently reported AMR rates are less than 60%, with 3-year graft survival more than 80%. So splenectomy is no longer used. Rituximab is given 2 weeks in advance prior to transplant, and standard triple dose immunosuppression is used. In the Japanese protocol, they start tacrolimus and MMF 7 days prior to transplant, but that has been modified by various centers, including ours. ABO-incompatible liver transplant in fulminant hepatic failure, there's very limited experience, no standard desensitization protocol. Use of rituximab immediately pre-LT and post-reperfusion has been reported. However, plasma is the mainstay of methodology for reducing the antibody titers. Some centers have used splenectomy and local graft infusion. Monitoring for AMR, again, there's no single predictor. Combination of methods. The usually used predictors are rise in antibody titers, derangement of liver enzymes and bilirubin, reduction in portal flow on serial Doppler that we have observed. And liver biopsy is not the gold standard. C4d positivity, as has been reported in kidney transplant, may not be true for liver transplant. Treatment of AMR consists of prevention is the best part, and the strategies that have been used are plasmapheresis, IVIG, steroid boluses, and proteasome inhibitor bortezomib has also been reported in the treatment of AMR. Now, briefly, since my time is up, I'll go through the protocol that we have been using and developed over the years. So prior to desensitization therapy, we do the antibody titers and the CD19 and 20 percentages. We use a single dose of rituximab, 350 milligram in adults, 2 weeks prior to LT. The apheretic technique that we prefer is plasmapheresis. Immunoadsorption is used for refractory cases, and a combination is used when the patients have very high baseline titers. And we first mop up the antibodies, remove the major bulk with plasmapheresis, and then mop up with immunoadsorption. The target for antibody titers before transplant is 1:16. Post-LT monitoring for AMR is on the basis of twice daily antibody titers for 2 weeks. Doppler studies, again morning, evening for 2 weeks, and daily blood counts and biochemistry, routine biochemistry. We use the standard 3-drug immunosuppression from day 1. Don't start it pre-LT. Anticoagulation, and CMV prophylaxis are used, and routine liver biopsy is not a part of our protocol for monitoring for AMR. So this is our protocol, desensitization protocol that we use, very similar to the Japanese, except for that we don't start MMF and tacrolimus 7 days prior to transplant. We start on POD1. Our protocol for managing suspected AMR is we use plasmapheresis, and the indications for plasmapheresis are 2 serial rise in antibody titers even with normal LFT, or if there is a rise in bilirubin and enzymes along with rise in antibody titers, or there's a derangement of LFT and reduction in portal flow. Sometimes we have used plasmapheresis even when the titers are normal. Steroid boluses are used frequently when there is derangement of LFT and reduction in portal flow despite normal antibody titers. And this we have observed in last several of our cases that we have done is that it happens during the end of the 5th to 7th day of post-transplant that we see a rise in derangement of LFTs and reduction in portal flow, and steroid boluses have been very helpful. IVIG is not a part of our protocol. And just I'll finish with a few last few slides to share our experience of ABO-incompatible liver transplant. Till date, we have done 74. The first was done in 2014. And with increasing experience, our results have improved, and so have the numbers. So we have done all age groups. 11 patients were infants. And we have done fairly sick patients, with all patients being CTP-C, MELD score of median of 20. We have done ABO-incompatible NCC patients. The most common blood group combinations were B to O or A to O. And the range of baseline titers has varied widely from 1:2 to 1:2048. Desensitization is the mainstay is rituximab and plasmapheresis, as is shown here. The median number of sessions used was 2, ranging from 1 to 11. All were LDLTs, majority of them being modified right lobe grafts. And coming to the outcomes, AMR, again suspected because we didn't prove it with biopsy, was seen in 23 out of the 74 patients. 8 patients had early allograft dysfunction, and this is following the definition when you exclude all other causes, technical as well as sepsis, as the cause of early allograft dysfunction. Bile leak occurred in 6. Sepsis was seen in 11 patients. And post LT in hospital mortality was in gross appears high. Total 18 deaths have been recorded out of the 74. But when we count the deaths that could be attributed to early allograft dysfunction or sepsis, they were 13.5%, which is not much higher than for the non-ABO or the ABO-compatible group. So I think with the increasing experience, the results have improved, and the results of ABO-incompatible are not very different from compatible liver transplant. And this is my last slide, just to summarize that strategies for ABO-incompatible liver transplant are continuously evolving. Multiple desensitization protocols have been published, but for all these protocols, rituximab and apheresis are the mainstay. Invasive interventions like splenectomy and local graft infusion therapy are no longer preferred. And for a successful outcome, close monitoring is the key. That is, you monitor in the form of daily antibody titers, LFTs, Doppler monitoring during the early post-op period. And if you follow all this, as has been our experience, the results are bound to improve and equal as with ABO-compatible liver transplant. Thank you for your kind hearing. Thank you very much.
Thanks, Shamil, for giving a very conceptual talk and also sharing your results. If there are any questions, maybe we can take one or two before we move on to the next talk. If there are none, then I'll ask my co-chair, Dr. Naimesh, to carry on and introduce the next speaker.
Thank you, Shaleen, for a wonderful talk. And let me invite Professor Hiroto Igawa, who's going to speak to us on antibody-mediated rejection in ABO-incompatible liver transplant. Professor Igawa is the head and chair and professor at the Department of Surgery, Tokyo Women's Medical University from Japan. Let's hear how he deals with the AMR, and let's start with the discussion. Dr. Igawa, please.
Oh, thank you very much. Please start the video. Thank you for the opportunity to share my knowledge and experience about ABO-incompatible liver transplantation. Today, I congratulate Professor Gupta and Saigal that you have the transplant hepatology course 2021. I have nothing to disclose. Today's issue is pathology and diagnosis and management of ABO-incompatible liver transplantation. This is a mechanism of AMR, antibody-mediated rejection. The B cell are developed to the plasma cell. The plasma cell make the antibody. The antibody connect to the antigen and the surface of the B cell tissues, and make inflammation with help of complement and inflammatory cells, and destroy the surface of the B cells and make a thrombus in the organ who was injured by circulatory disturbance. The complement play a very important role in AMR. This shows the cascade. And C4D is very unique substance. Usually the complements are diminished immediately after reaction, but the C4D remained the place. This is very important substance for the diagnosis of AMR. This is such a carbon after the fire. This one shows the stain of the C4D IgM or IgG along the sinusoid of a patient who died of severe AMR after ABO-I. This is the typical HE pathology, and vasculopathy is the key. The left panel is hypertrophy of the hepatic artery. The right panel, inflammation of the hepatic artery. Especially the bile duct is received and the blood flow only from the tiny hepatic artery. So the injury of the vessel is very limited to the small arteries. The patient developed a bile duct injury, but the patient developed the massive blood flow injury. So the patient developed the liver necrosis. This is not different. This is longitudinal findings. This is the very important finding, early pathological finding of AMR. Professor Haga, the Kyoto University, reported 2006. The small thrombus of the artery, the edema, and necrosis, and C4D stain. This is severe AMR, the hemorrhagic necrosis. So once we see this, we have to change the liver. Diagnosis management. This shows the time course and AMR, the types of AMR. So the pre-existing DSA might play a role, but usually the de novo DSA has important role for the AMR. But anyway, we do the desensitization targeting the B cells, memory B cells, to decrease development of the de novo DSA production. This is just theory of the B cell desensitization. So the tacrolimus depress the development from B0 cell to B1 cell. Rituximab kill the B cell. And the Celcept suppress the B cells, all B cells. This is our current standard regimen for prophylaxis in ABO-I. So we give the rituximab 2 weeks before, usually, and we might do the plasma exchange when the patient's titer is very high. The important thing is we give the tacrolimus and the Celcept before liver transplantation, if possible, at least 1 week. The dose is not shouldn't be so high. And now we do not do this. No, we don't do the splenectomy. B-cell depletion is a key. I show this is an old slide without rituximab. The patient developed a B-cell increase just immediately after the reperfusion. 3, 6, 12 hours, the increase. So I gave the rituximab to patients. So we have to give the rituximab before the transplant. This is my painful case, 2000. So I did not give the rituximab because her titer was very low. but the number of the B cells increased immediately after transplantation, and also memory B cells increased. I gave the rituximab. The number of B cells, memory B cells decreased, but the titer increased, and the patient developed a severe AMR, and the patient died. After the case, I gave rituximab for all patients. And rituximab depletes the B cells in the spleen. The control is the hepatitis C patients who received the splenectomy for the postoperative interferon therapy. So all cases, anyway. And I also checked the B cell subset in lymph nodes, usually around the portal vein or the stomach. Surprisingly, rituximab did not decrease the B cell, the memory B cell, and the lymph nodes. This is the time relation between the B cell, the depression, the timing of the rituximab. So if we give the rituximab early, we can deplete the B cells enough. But if late, some patient, the B cells increase. The optimal dosage regimen. It means what is the safe minimal dose? That's one slide. So this is a 375 milligram per ml square. There's a 5 milligram per body, a 300 milligram per body, 100 milligram per body. I calculated, and that red asterisks show the AMR here. So we need 185 milligram per square of rituximab for safety. And the patient survival also significantly different between the patient with enough rituximab or small rituximab. Prophylaxis might reach to the upper limit. What is the next treatment for AMR after transplant, or how predict risk of AMR? This is the devices to combat to AMR. You know we can use rituximab, splenectomy, plasmapheresis, IVIG. And the bortezomib, still we have small evidences. The IDES, a C1 inhibitor, C5 inhibitor, IL-6 inhibitors. These are the very promising, but very, very expensive. This is my idea for strategies for possible or clinical AMR. When the patient developed inflammation, a fever, the CRP elevation, with or without liver function increase, just give the steroid pulse and the liver biopsy. Actually, do the liver biopsy fast and give the steroid pulse. If the liver biopsy shows the portal necrosis and edema and the C40 positive, this is the early phase. And after we already gave the steroid, to watch. If the patient improve, it's okay. But to develop, we need the next step. Or this biopsy show the hemorrhagic necrosis. We just do the plasmapheresis, IVIG, rituximab, the bortezomib. I show the one case report of bortezomib from Kyoto University. They are successfully treated the patients who developed the AMR resistant to the steroid pulse, plasmapheresis, the rituximab after transplantation. Just 2 doses of bortezomib decreased the antibodies, and the patient was saved. And no severe adverse effect. how do we predict this factor? So I show my painful case. After the 2000, I haven't have the AMR, but the last year I met 2 cases of AMR. First one is a 40-year-old lady with PSC. I gave the 375 milligram per square, and the schedule was postponed 1 month to ensure safety against the COVID-19. The BCL was 2% before transplantation. I did not add another dose. I regretted it. And no transfusion during the liver transplant. Just blood loss was 500. No splenectomy. We measured IgG subclass and C1 binding IgG from this case. So the titer at the maximum to 128, it is not so high. But the patient developed a fever, the liver function increased. So, I did the liver biopsy and fully treated on steroid pulse, PEGs. And again, she developed the liver function dysfunction. So I gave the rituximab and IVIG. Clinically, she improved very nicely. But before the discharge, she had the fever, the liver dysfunction again. And we treated the fully, but we gave the bortezomib. So let's see the IgG subclass, IgG3 subclass, and the C1q, green one. So during the first attack, C1q, C1 increased. And after decrease, the C1q and the IgG1 increased again. But after the bortezomib, the both decreased. But unfortunately, she developed a liver abscess, and she was rescued by liver retransplantation from the 66-year-old father. This is the portal necrosis edema and the C40 on POD8. But the second biopsy, I saw the hemorrhagic necrosis. This is another case, subclinical AMR. He is a male, but a PBC. Donor is his wife. He had the fever and liver dysfunction. This time, and also he developed the increase of IgG and the C1q. I did the pulse steroid and the plasma exchange and the IVIG. And he was rescued without any complication. So this is the portal edema necrosis and C40 deposition. So lessons from my case: autoimmune disease such as PSC, PBC could be high risk. A B-cell depletion should be strictly for autoimmune diseases. When blood loss is small, splenectomy could be a choice. Liver biopsy is recommended in any clinical event. Even when antibody titers are not high, increase of C1 binding or IgG or IgG1 subclass could be a risk indicator. This is not a popular method. The bortezomib should be used at the first attack. Complement inhibitors, IL-6 inhibitors could be promising. Thank you for the attention.
Thank you, Dr. Egawa, for a very illustrative talk. Are there any questions? My co-chairperson, if they have any questions, Dr. Pankaj Puri can take over from here, please.
Thank you. Thank you very much for the nice talk, sir. And we'll go over to the next talk. The next talk is by Dr. A.S. Soin, who's the Chief Hepatobiliary and Liver Transplant Surgeon and Chairman at the Medanta Institute of Liver Transplantation and Regenerative Medicine at Medanta, the Medicity. And he'll be talking on outcome of ABO-liver transplantation, the Indian experience. Dr. Soin, please.
Thank you very much, Pankaj. And thanks, Sanjiv and Subhash, for organizing this and inviting me to talk here. And thanks, Hiroto. Professor Igawa has spelled out the problems with AMR very nicely. He's, of course, a renowned world expert in this field. And I've actually got some overlaps between the last two talks and mine. So please bear with me, but what I'll do is I'll take you through what our protocol is and what our experience has been. And here it goes. Let me start sharing the screen. Yeah. You can all see my screen, hear my voice.
Yes, we can see you, see your screen, and if you put it on full screen, yeah, that's fine.
Okay, so the problem with ABO-incompatible liver transplantation is, of course, the antibody-mediated rejection, which you already heard. Basically, it means in the clinical sense that there will be hepatic necrosis, especially in those who are older than 8 years. There'll be markedly elevated enzymes, there'll be necrosis CT, you saw the CT films that Dr. Igawa showed you. And this usually happens a week or two after liver transplantation. The second dreaded problem with AMR is, of course, intrahepatic biliary complications, which basically means there'll be refractory sclerosing type cholangitis on cholangiography, and this typically happens 1 to 3 months after liver transplantation, sometimes even much later. So I'm actually going to split my talk into a quick look at how you select patients and pre-transplant optimize them. And then a little bit about immunosuppression, because this single theme conference actually focuses on immunosuppression and then postoperative management and outcome. So in the preoperative phase, I'll tell you what we do with recipients who have ABO-incompatible living donors in our situation, and then talk about recipient selection specifically in relation to how sick they are. That means high MEL patients, patients who have PSC, which Hiroto clearly said is a difficult group of patients, patients with HCC, because it is often thought that patients with HCC will do worse with ABO-incompatible liver transplantation, and we'll see if that's true. And then, of course, a quick word about optimizing these recipients before surgery. So when we have an ABO-incompatible living donor, if it's a A to B or a B to A type of incompatibility, we generally put them in our swap database, and 80% of the times we are able to match them with the opposite pair and are able to do a swap transplant. If there is a to O or a B to O or a AB to O type incompatibility, then these are the guys who actually need ABO-incompatible liver transplantation, except for a minority who can actually have a volume swap. Now, who are the ideal recipients and donors in these cases? An ideal recipient should not be very sick. It should be an elective transplant, MELD ideally less than 22. They should have a good performance status. Their renal function should be good, and there should be no serious sepsis, of course. It is ideal to exclude advanced HCC, and but within UCSF, HCC would be acceptable. PSC and PBC may have more predilection to more AMR, but that doesn't mean that you don't do that. An ideal donor is obviously young, with a GRWR of 0.8%, more than 0.8%, and does not have any steatosis in their liver. And good combinations to do this are A2 to O, where, of course, the immune reaction is very minimal, if at all. But the problem is that we in India hardly have any people with A2 blood group. In recipients in whom CD19 counts are less than 50, CD19 counts are surrogate markers of CD20 positive cells. And in those in whom the initial anti-A or B antibody titers are less than equal to 1/256. Now let's look at HCC. The evidence from Korea, and I've got 3 papers here, And one's a National Cancer Center, and they've shown that the ABO-incompatible liver transplantation has no adverse impact on oncological outcomes in patients who are transplanted for HCC. And then the Samson Medical Center have shown the same thing. And of course, the Assam Medical Center, at this time, they had close to 300 patients that they published, but currently they have done more than 500 ABO-incompatible liver transplants, and they've shown that the overall and recurrence-free survivals in patients with HCC are comparable between those who have had compatible and incompatible LDLTs. So, as long as the recipient is within UCSF, you're okay doing a patient with HCC with an incompatible donor. In terms of pre-liver transplant optimization, I would optimize their renal function, I would make them recover from sepsis, and I would downstage the HCC if it is beyond UCSF. Now let's look at immunosuppression pre and post liver transplantation in these cases. Now, the whole point of immunomodulation and then subsequent immunosuppression in these patients is to either clear the pre-existing anti-A or B antibodies or prevent their production. And you can clear them by total plasma exchange or TPE. And you can decrease their production by doing a splenectomy or giving them mycophenolate or other antimetabolites. And of course, by administering anti-CD20 antibodies, which is rituximab. You've seen a similar cartoon in the earlier talk. So these are the various steps of how the antibodies form and then interact with the endothelium. And in turn, there is arterial thrombosis and destruction with the complement activation. And of course, release of pro-inflammatory cytokines. And these are the strategies to preemptively treat AMR or prevent AMR, which means administration of rituximab, doing a splenectomy, because spleen is where the B cells mature into plasma cells, which actually make the antibodies. Plasma exchange to clear the pre-existing antibodies, IVIG to competitively neutralize the attachment of these antibodies to the endothelial cells, and so on. But these four are the major strategies that we use. Now, rituximab is, as you all know, is an anti-CD20 antibody. And it basically acts on most of the B cells and plasma cells to inhibit them through complement-mediated cytotoxicity, through ADCC, and by direct lysis and or activation of the apoptotic pathway. Now, the aim of pre-transplant immunomodulation is that you should administer rituximab to get a CD19 count of ideally 0, which I told you is a CD20 surrogate, or 1. And this typically happens somewhere between 10 and 20 days. And do plasma exchange to be able to get anti-A or B antibody levels, IgG and IgM, less than 1/16, less than 1/16. Dr. Egawa showed you this nice paper of his where he talks about the survival among patients who received rituximab more than 185 milligram per meter squared versus those who received less. And it's clearly the cutoff where patients start to do well. And most of the people now administer 300 to 375 milligram per meter square 2 to 3 weeks before the planned transplant, and then start MMF and tacrolimus a week before, and give total plasma exchange 1 to 3 sessions. And then post-operatively and intraoperatively, we don't really do any splenectomy. There is no local infusion. And post-operatively, you continue with tax, steroid, and MMF. And the differences from ABO-compatible transplantation are that intra-op, we would give higher doses of prednisolone at 15 milligrams per kilogram instead of 10. And I would give higher dose of steroid post-op at 1.5 mg per kilogram for the first 3 days, followed by 1 mg per kilogram for 2 weeks, as opposed to just 1 mg per kilogram for 5 days and then taper. MMF And then tacrolimus is again kept initially for the first 4 weeks at 2 higher than it is in the compatible transplant, and then later on perhaps 1 higher. This is usually 5 to 7 for compatible transplant. So a little bit higher immunosuppression is what we would go with. And we would monitor the anti-AB titers, IgM and IgG, pretty much every day for the first couple of weeks, and then alternate days in the next 2 weeks, and keep them low. And CD19 counts are monitored really more for academic purposes, and we would do that up to 3 months. Now, a word about emergency liver transplantation. That means recipients who have ALF or ACLF, can they actually have ABO-incompatible transplants? We've only done 1 successfully. So what would we do? We would confirm the liver transplant that is happening, confirm the donor, then administer rituximab as soon as possible before giving as many days as possible before the transplant. Delay the transplant for 5 to 7 days if possible using CRRT. And then you give plasma exchange 2-3 times, up to 5 times to attain the right anti-AB, IgM and IgG levels. And then give IVIG at 0.8 grams per day, like 2 days before and 5 days afterwards. And then the usual ABOI doses of tacrolimus and MM. Try and give them before the transplant as many days as possible. So many would do a splenectomy. We did not do a splenectomy in our single case because, like I said, that's where the B cells mature. And like Dr. Saigal said, you either bleed the recipient out during surgery, or if the blood loss is not too much, then a lot of people prefer to do splenectomy, especially in the emergency situation. And post-transplant immunosuppression, same as in the elective cases. And then now a word about post-operative management, AMR diagnosis, treatment, and outcome. I will skip the AMR diagnosis and treatment. You've just heard that. But what I would say is that we basically look at AMR. We suspect AMR whenever there's an elevated LFTs, especially when accompanied by raised anti-ABO titers, and when the donor-specific antibody titers are more than 5,000 MFI, and when the histology shows periportal edema, necrosis, arterial thrombi, and C4D staining. There are BAMF criteria for livers with AMR, and basically, if you have the features we just described with a positive serum DSA and exclude other causes of liver damage or dysfunction, then you've got a AMR at your hand. And again, the way to counter that is bortezomib, plasma exchange, IVIG, and IL-6 inhibitors. And what we would do is treat them with steroids, IVIG, total plasma exchange. We haven't done bortezomib. I'm not sure what Dr. Egawa's experience is with this. There are some anecdotal reports that it works wonders. So the outcome, like I said, after ABO-incompatible transplantation, especially by experienced centers, this is again data from Professor Song, shows that they have excellent survivals after incompatible transplants, just same as compatible transplants. And I'll take you through. So just a little word about our protocol. What we do is I've already said what we do with the CD19 counts and the measurement of the IgG and IgM antibody levels. But we would not give rituximab to children less than 5 years. We would just treat them with plasmapheresis pre-op with or without MMF, and electively give IVIG if we've only given plasmapheresis. And the rest of the management tends to be the same as in adults, which I just showed. Out of our nearly 3,539 transplants, we've done 28 ABO-incompatible transplants. Their ICU stay has been 5.4 days, hospital stay 17 days. AMR, it happened to 2 patients, one responded to treatment, we lost the other patient. ACR 5, that's 17%. Vascular complications, HAT in 1 patient, that's 3.5%. Biliary complications, 14%, which is slightly higher than about 9.5 to 10% that we have in ABO-compatible transplants. 90-day survival is 82%. We lost 5 patients early, and 1, 3, and 5-year survival at 82, 77, and 74%. So I'll summarize here one by one the 3 sections that I've talked about. As regards to selection and pre-transplant optimization, I would do a ABO-incompatible transplant if swap transplant is not possible. Ideal would be a stable recipient with a MELD less than 22, an HCC with an UCSF, no sepsis, good donor liver, and low anti-AAB titers. And I would optimize recipients by treating their sepsis, renal dysfunction, and downstaging their HCC if necessary. And then about the peri-transplant immunosuppression, I would give anti-CD antibody for B and plasma cell suppression. And I would remove the circulating antibody with plasmapheresis. Rituximab dose 300 to 375 mg per meter square, 2 weeks before. Tacrolimus and MMF from day -7. TPE 2 to 5 exchanges to make the levels of IgG and IgM at 1/16 or less. We haven't done so, but I would consider splenectomy in emergency cases, and IVIG, yes. And post-transplant immunosuppression is slightly higher than compatible transplants. As regards post-operative care and outcome, post-op AMR is the main potentially serious problem. And I would suspect it if the LFT and anti-AOB titers are elevated. I would confirm by DSA titers and biopsy. I would treat with steroids, IVIG, total plasma exchange. We don't have any experience with bortezomib, but possibly that should be used. And post-operative complications are similar to compatible transplants, but there is, of course, a higher intrahepatic biliary complication rate. And elective ABOI outcome is similar in experienced centers to ABO-compatible LDLT. And I believe it can increase the live donor pool by 30%. Thank you very much.
Thank you, Dr. Soin. Thank you for that crisp and wonderful talk. And if we have a co-chairperson, Dr. Vikram Raut, would you take over the question and answers, please?
I think while Vikram comes in, I must thank all the 3 speakers for a really, really good quality, lectures, insightful talks. Special thanks to Dr. Igawa, who's been actually live with us and has promised that he will be here with us for the question answer sessions. So I think with these 3 talks by Dr. Soin, Dr. Igawa, and Dr. Shalin, if we have the opportunity of asking questions, we'll be happy to go for that. We'll have some time for that.
Can I ask a question?
Sure.
Yeah. Professor Igawa, I enjoyed your AMR talk as always. What is your, you have suggested that bortezomib should be used early. Is there a large experience in the world with the use of bortezomib?
No. So this time, that is in my first case. So I prepared, but I didn't meet the case. But this time, I had the experience. And so I have some company, for the example, the Professor Oda in Hiroshima. He also had one cases in the liver, but he has some cases in kidney AOB incompatible. So we did not have a severe side effect of bortezomib. It's a safe medicine and not expensive so much. Almost at the same price and rituximab in Japan. So it's easy to use and also definitely kill the plasma cell. So the titer decrease absolutely. So that this in my case, I wanted to use the bortezomib earlier, but the hospital policy did not allow me to use that the timing. So I used the rituximab and the IBIZ again. I mean, not again, IBIZ after transplant, but it worked, very worked. The decrease, but the maybe the severity of the AMR was too strong to depress by rituximab and IBIZ. So if I meet the if the steroid pulse did not work, and the patient had continued to have the fever and the CRP, high CRP, I use bortezomib.
Thanks.
We have one question from Dr. Subhash.
I'm just wondering whether MR imaging will help in detecting antibody-mediated rejection. The reason why I ask is it's been used a lot in cardiac transplant now, MR imaging. And suddenly we find biopsies in somebody who's unwell, certainly with, the sort of percutaneous biopsies, transhepatic, although we have the expertise for it, we find biopsies a bit difficult to do. I know what others feel about it, Professor Gavan, Dr. Soin, and Dr. Shaleen. We find biopsies, and we've tended to rely a lot on MR images. And sometimes it does pick up sort of areas of necrosis and edema and periportal cuffing. And we use that for sort of changing a treatment regimen. So I just wanted a view from all the experts who are here on whether it has a role or whether, it could help. Yes, biopsy would be the gold standard, but sometimes it's just too difficult to do.
Well, we have no experience with MR to diagnose rejection, but yes, of course, if you were if the patient was at a stage where you were suspecting an intrahepatic biliary complication, of course, MRCP would obviously help.
So I would like to share because I've been working with Dr. Gupta for a long time, and that I've seen that. See, it may have a corroborative evidence, like when you're clinically suspecting that this could be rejection, when you see rising titers, deranged enzymes, patient otherwise clinically well, worsening cholestasis, and if your MR additionally shows some area of liver necrosis. So I think it's a corroborative evidence. And when you don't have the patient situation is not that, like you don't want to do or risk the patient with a liver biopsy related complications. So it may add to your suspicion of AMR, and you may proceed with the subsequent management on those grounds. So I think definitely there is an element of changes, especially areas of necrosis that you see that MRI may be helpful in such situations.
The cardiac transplant guys use a lot of MR nowadays.
I'm saying the MR changes might be late now, Shaleen.
Yeah, that is true, sir. That's true for the, but we are talking of situations where you want to avoid a liver biopsy. So this is, I'm not saying it's a corroborative evidence. So necrotic areas definitely may appear late. By that time, I think already AMR.
Even edema you can see, not just necrosis. Periportal cuffing is quite, I don't know, the cardiac guy seems to use a lot of MR imaging in diagnosing rejection nowadays. Cardiac MR.
The periportal edema that we're talking about is on histology. I'm not sure if it appears on gross imaging.
I wonder if Dr. Igawa has any experience with use of MRI?
What you mean is a diagnosis for biliary complication. You mean MRI means that? Yes, we use MRI for the diagnosis of biliary complication secondary to AMR, but it is too late. So the biliary complication means the cannot save already. So before the patient develops biliary complication, I mean stenosis, we have to save the patient by anti-inflammation treatment using the early diagnosis of the liver biopsy?
So in our experience, transjugular liver biopsy is possible almost in every case. So
Yeah.
I would
The key is usually day 5.
I would go for a biopsy at a very low threshold in an ABO-I. It's better to find a normal biopsy than to delay the biopsy.
No, I think the reason for raising this question probably was because, as Dr. Gupta said, that in cardiac transplants, they're using MRI, but I think there is a very standardized picture of myocarditis on a cardiac MRI, and that's why they are relying more on it. Whether hepatic changes or hepatitis before full-blown AMR sets in can be viewed on the MRI. So I think we need more studies, and we need to standardize those changes of hepatitis as they have done so in myocarditis for cardiac transplant. So I think it is an extrapolation from that, and maybe it's a useful or interesting area of further research.
Yeah, cardiac AMR is very interesting area.
Dr. Subhash, you had a hand raised.
Yeah, no, I just asked my question. I should lower my hand now, I guess. But I think we've used it a lot, I must say. And day 5, we all have, and in fact, they will get a steroid bolus in our unit on day 5, irrespective of titers and the values. I've done a huge number, actually. We've done 70 cases. And nowadays, in fact, everyone's familiar with the protocol. But we really found MR helpful in a number of occasions. It tells you sort of collections, it tells you bile ducts, it tells you middle hepatic vein, right hepatic vein. And in 2 cases, I remember we picked up areas of geographical change on the MR. It's not MRCP, that is for biliary complications. We're talking MR of the liver, which is slightly different from MRCP. And you do pick up changes, and you do sort of help aids in the subsequent management. But even if you did a biopsy, by the time it gets reported, it may be too late. So on one hand, the MR changes may be late, but the biopsy changes may be early. But by the time the report comes through, one day you do a biopsy, the next day probably the report comes in. I think in Birmingham, they used to give us the report the same day, but I don't think any other unit in the country, maybe Medanta is different, they report the same day, but we do not get the report the same day.
Yeah, we are lucky to get the report within 6 hours. It doesn't matter what time of the day.
So we need a quick liver biopsy, at least 1 day.
I think since we are running late, we should now wind up the session. Thank you, everybody, for
Thank you very much.
And wonderful deliberations. Thank you, sir.
Yeah.
Thank you.
I'll hand over the mic to the organizer.
See you next time.
See you next time, sir.
Yeah, I mean, I was personally thank Professor Higawa, for being here, and as promised, he stayed with us for the live question. Thank you, Professor Higawa, once again. Thank you very much.
Now we move ahead to our last session of the day, and I would like to invite our chairperson, Dr. Mahmood Al-Mehtab. He is Associate Professor of Hepatology in Bangabandhu Sheikh Mujib Medical University, Dhaka. Dr. Sibram Prasad Singh. He is the Head Department of Gastroenterology, SCB Medical College, Cuttack. Dr. Sweta Singh, Director Liver Anesthesia Critical Care at CLBS M.I.C.E. Saket. And Dr. K.R. Vasudevan, Director, Department of Liver Transplant at JPN, PSRI Hospital, Delhi. Over to chairperson, and I request them to invite our next speaker and start.
Good evening. We now start this session, which is a mixed session. There will be 3 lectures. May I invite the first speaker, Manav Vadhavan. Manav will be speaking on immunosuppressive drugs monitoring, what the clinician needs to know. Manav needs no introduction. He's the director of Liver and Digestive Diseases Institute and the head of Hepatology and Liver Transplant Division at the BLK Super Speciality Hospital, New Delhi. Manav, please.
Thank you, Dr. S.P. Singh. Special thanks to Dr. Saigal for asking me to talk on this. Now, I've been asked to speak about immunosuppressive drug monitoring. Now, I put a bracket in the title itself here because I'll try to highlight the difference between immunosuppression monitoring and immunosuppressive drug monitoring. They're two different concepts. So, although we don't do much of immunosuppression monitoring, but that's a way forward. This is my favorite slide when I talk about any immunosuppression. Alloreactivity basically is the reaction of the lymphocytes, the recipient's lymphocytes to any foreign antigen. In this case, that foreign antigen is the graft which we are giving. As you see, the reactivity of T cells of the lymphocytes is maximum in the first 15 days, tries to plateau, and by the end of first month, it starts coming down. And that is the basis of all immunosuppression you use in liver transplant patients. You start with a higher dose, you go to a plateau, and slowly the amount of immunosuppression required is much less because the drugs required to suppress the lymphocytes is very low as you go later on in the course after transplant. So, as I said, there is a concept that immunosuppression and immunosuppressive drugs may not correlate with each other. So, let me give you a simple example. There are 5 patients who have a tacrolimus level of 8. The level of immunosuppression, that means the level of suppression of the T cells, may be different in each one of them. One guy may have a rejection at a TAC level of 8. The other guy may have infection at a TAC level of 8. So the immunosuppression does not, the drugs do not reflect the immunosuppression. So what are the ways to measure the level of immunosuppression? That means measure the immune status of the patient. We don't have any one of them commercially available, but we have 3 or 4. Dr. Prasoon did talk about some cytokines, chemokines, and the biomarkers of cell-free DNA, which may tell you that the T cells are getting activated in advance before the onset of rejection. We have virus-specific T cell assays. We have T cell activation assays. Luminex, Silex came with a lot of bang, but again, they're not commercially.
Dr. Manav, I'm sorry I'm interrupting in between. I think your Bluetooth is not working. We cannot hear you, sir. So we cannot hear you. I think your Bluetooth is drained out, sir.
So is it working now?
Yeah, now it is working, sir. Your Bluetooth was drained.
Something wrong.
Now you're audible, Manav.
Now you're audible, sir.
Oh, perfect. Thank you. So, so that means right from the beginning I was not audible. Shweta.
No, you were audible. Okay, yeah, start from the beginning.
You could Manav actually go back to
2 slides.
3-4 slides.
Yeah, just 2 slides.
No, just go back one more.
Yeah, from here.
Yeah, from here, if you restart, it will be very nice, Manav.
Oh, that's restarting. That's a complete slide.
Sorry for that trouble, but it will be wonderful to listen to you on the.
Okay.
We heard.
I would have been happier if you had. Sorry.
Yeah. Thanks.
But
thanks.
I thought that there was something wrong at my end. Couldn't hear you at all.
Okay. So let me start from the beginning. So that's the first slide. That's alloreactivity actually is the first slide. So the topic I've been asked to speak is immunosuppression drug monitoring.
Yeah, we heard all that. We heard all that. We heard the part about your favorite slide and how you.
Did you hear about monitoring immune status?
No, you can start from here.
Okay, so the concept is drug levels do not indicate the level of immune status in a patient. A simple example is 5 patients having a TAC level of 8. One may be over immunosuppressed and other guy may have rejection. One may be overtly septic, develop sepsis or prone to sepsis, and one guy may be adequately immunosuppressed. So a particular level does not reflect the immune status of the patient, and the assays which have been touted to measure the immune status, I've just listed them down here. Dr. Prasoon Jalal did talk about some cell-free DNAs and biomarkers. Cytokines, chemokines have been used, not very successfully. A lot more data is required. T-cell activation assays came with a lot of bang around 10 years back, but as of now, they're not commercially available. What they do is they look at proliferation of T-cells in response to specific antigens. And they measure ATP usage in the T-cell. The Silex assay actually measures the ATP usage. Luminex sees the response in the T-cell proliferation. Then you have virus-specific T-cells. That concept also is there, but none of them are commercially available. We are actually looking forward to have some assay which can tell us the immune status so as to modulate the immunosuppression rather than the drug levels itself. Dr. Gupta talked about CMV DNA as a marker of immunosuppression. Now that's a very insensitive marker, but what has been used, especially in kidney literature, is toctinovirus. Now this is a ubiquitous virus. It's it's a non-pathogenic virus, and the levels do go up. It is present in almost everybody. And the levels do go up with over immunosuppression. There is some data in the renal transplant, but not in liver. But that's one candidate. But this is not what we are doing. So I'll move on to what we do. This is a conceptual thing. So let's look at the approach to immunosuppression. We have 2 phases of immunosuppression. We have induction phase and we have maintenance agents. Antibody induction and hydrosteroids are used for induction phase. Hydrosteroids are used across board. We did hear a few speakers talk about lower dose of steroids in the intraoperative phase. But antibody induction is basically not used these days mostly. The only role it has is in the renal sparing protocols. Somebody who has a kidney disease, somebody who has a hepatorenal syndrome or borderline kidney functions, we often use IL-2 receptor antagonist, specifically basiliximab. And that's probably the only role of antibody induction. If you want to monitor antibody induction, there are no levels to monitor here. So once you give a specific antibody, the target engagement is within 12 hours. So by the end of 12 hours, the drug levels in the blood will be 0. So you have surrogate markers. The surrogate markers to measure immunosuppression in these patients are TLC, lymphocyte counts, and specifically CD3 counts, which is used for ATG. So that's how you can surrogate measure immunosuppression, but you cannot measure levels in antibody induction. Let's come back to the core of the talk, the maintenance immunosuppression. You have mycophenolate, you have steroids, you have CNIs, you have mTORs. Mycophenolic acid assay was commercially available in India, I think till 2017. Dr. Lal's Path Lab used to do it, but they discontinued for 2 reasons. Literature came up that the relationship between levels of mycophenolic acid and the immunosuppression status, they don't correlate well. Secondly, it was not even predicting the adverse effects. So if somebody has a higher mycophenolic acid level, it does not mean that this guy is going to have TLC depression or a bone marrow suppression. That's the reason nobody uses it. Across all organ transplant, it is not used, and it is not even available now. Steroids, we understand more steroids, more immunosuppression, but we take off steroids in most of the cases, except in autoimmune hepatitis or late acute rejections. We taper off steroids by the end of 6 months, so we don't need to monitor their levels. That brings us to tacrolimus, the core drug which we monitor day in and day out in all our transplant patients. The trend these days is tacrolimus monotherapy. We try to take off most of the patients off mycophenolate by the end of 2 years, maybe at 1.5 years. And we monitor tacrolimus early after transplant, and even some people do it late after transplant. I'll talk about that. But this is something which is important. I don't know how many of us go into the technique of measuring tacrolimus. It is very important for us to understand as clinicians, as hepatologists, as transplant surgeons. There are 2 techniques available. One is the liquid chromatography mass spectrometry technique, LC-MS. The other one is CLIA, the chemiluminescence immunoassay technique. The cheaper one is CLIA. The more expensive one is a solid phase HPLC liquid chromatography technique. The difference between the 2 we have to understand. Somebody who has a good graft function, a normal stable LFTs, the coefficient of variation between these two techniques is not much. They actually replicate each other. But somebody who has graft dysfunction, when the bilirubin is high, when the graft is not working well, there is a significant difference between these two values. The HPLC values, the chromatography values are much more reliable, they are much more accurate, and they're actually lower than the CLIA values. And that's what we should specifically look for. You're monitoring tacrolimus early after transplant. You transplant a guy who has a MELD of 25, his bilirubin on day 5 is 10. You do a chemiluminescence assay, it is likely to give you a very high levels. You should do a HPLC specifically. I don't know how many hospitals have HPLC in-house, ours does not. So we are in-house doing only CLIA. We do ask for HPLC when we need in somebody who has a deranged liver function. So that's one thing which we need to remember. Secondly, I thought this all of us understand the trough levels, but for the sake of simplicity, I thought I'll talk about it once more. Trough level basically means the lowest level of the drug in the circulation. In case of conventional tacrolimus, we use twice a day dose. So it has to be measured before the dosage, either in the morning or in the evening, usually 12 hours. That's the gap we have. If you are using once a day tacrolimus, it should be measured again before the OD tacrolimus dose. So many times we order a tacrolimus, the nurse sends it 1 hour after the patient has taken the dose, which does not reflect the trough level. So that's something again we need to remember and take care of. How often do we monitor? That's an important thing. Now I told you early post-transplant, we should use HPLC. We at our center would measure at least twice weekly, in first week or second week, and subsequently weekly. The frequency of measuring will depend on the graft function. If the patient has stable graft, we'll keep on decreasing the frequency of measuring. It will go down to monthly in first 6 months. Subsequently, it is even less often, maybe once in 2 months. But what I want to impress upon the audience is possibly in liver transplant patients, after a few years, if you have stable graft function, we may not even need tacrolimus levels. So I often get patient queries. 3 years after transplant, absolutely normal functions, the TAC level comes as 1.2. The patient is scared. The report says the normal levels are 5 to 20. Would you like to increase tacrolimus or not? So I just reassure them, just don't worry about it. 1.2 is good with me. If the liver function graft is normal, this patient does not have autoimmune hepatitis. This patient has no previous rejections. I'll not worry about tacrolimus levels. So how much we should monitor? I would like to ask the experts also here, the expert panel, Dr. Saigal, everybody who's around. What is their experience? Do they really do drug levels after a few years? And if they do, how often they do it? This is something again which we need to remember as a LRLT unit. Across India, LRLTs are more common than disease donor transplants. Law permits us to use only related donors. The trough concentrations required, the level of immunosuppression required in a related donor is much less. Evidence comes from twin studies. If you have a twin transplanted, you actually need no immunosuppression. The more the HLA matching, the less is the immunosuppression required. So biologically relative donors, recipients require less immunosuppression. And this has been shown very well in the A2ALL study. I'm not quoting literature here. You can go back and read this. 2 cohorts, biologically related donors and recipients, the risk of rejection was much lower. The protocol was absolutely the same. Now, this is something which actually where you need to look at monitoring drug levels. The long-term complications of post-liver transplant are actually correlated they correlate with the level of immunosuppression, level of immunosuppressive drugs. So higher TAC levels early on and even late after transplant predict all complications. Look at the complication: renal dysfunction, hypertension, hyperlipidemia, diabetes. All of them correlate with either the tacrolimus levels or the steroid dosages. We have already taken steroids off the picture. We only use it for 3 to 6 months. So CNIs are primarily responsible for most of the long-term complications, medical complications after transplant. So what do we want to do? We want to identify the patients who are at risk. We want to identify the problems early, and we want to minimize the damage before it is too much. I'm not going to teach you about renal sparing protocols. You've already heard about all these studies previously from various speakers. Dr. Rela talked about it, Dr. Dharmesh talked about it yesterday. So early everolimus with low dose tacrolimus may be the way forward for all patients who have renal dysfunction. Even for patients who have dyslipidemias, hypertensions, that may help. Dyslipidemia, it may not help, sorry, for hypertension patients. But this is something which I thought I'll draw your attention to. Out of the 3 maintenance drugs, tacrolimus, everolimus, and mycophenolate, the best toxicity profile, the safest drug to use is mycophenolate mofetil. And if I have to use a drug to minimize CNI, which has most harm, I would use mycophenolate. I just thought I'll give you some data on this. These are a few studies which have been published on CNI minimization from 3 months after transplant to 1 year after transplant. The moment you decrease prograph, the renal functions improve without increasing any rejection if you're continuing your mycophenolate. And that's a drug which I use for all my NASH patients. That's a drug I use for all my metabolic syndrome patients. So the tacrolimus monotherapy applies to a low risk standard patient. Low dose tacrolimus with mycophenolate applies to patients who have higher risk of either metabolic syndrome or renal dysfunction. You need to monitor their TAC levels, get them to minimum, maybe 1, 2, 3 after 6 months, and try to help these guys. And that's a protocol I follow. We follow at our unit. Early after transplant, even 8 is a higher. We generally maintain 5 to 6. We get it down to less than 5 by the end of first year. In a standard patient, we'll taper mycophenolate and shift to once daily tacrolimus if possible. We try to identify renal dysfunction and metabolic syndrome early. And in NASH patients, they also come in this category. We use eGFR instead of creatinine, and we stitch to either a low dose tacrolimus with mycophenolate or an mTOR with a very low dose tacrolimus. That's what we do. My last 2 slides, I'm sorry, I exceeded the time because the first 4 minutes, I was not making sense. You were not able to hear me, but these are important slides. This is one point where you want to monitor your levels when you are using drugs which either increase or decrease your immunosuppressants. They are drugs which are used across board. Look at this: calcium channel blockers, diltiazem, verapamil, nifedipine, commonly used for patients who have hypertension, macrolide antibiotics, all the azithromycin group antibiotics, metoclopramide, Perinom, we use it so often, domperidone, Pantocid DSR is almost a universal prescription, anybody who has acidity, fluconazole, voriconazole, all these drugs increase tacrolimus levels, and excessive tacrolimus levels cause more toxicity that we have seen. They may not indicate the immune status, but they indicate the adverse effects. So we have to take care of that. Similarly, we have to take care of the drugs which decrease these levels. You may precipitate rejection. Anticonvulsants are number 1 in that. Rifampicin, the ATT, and terbinafine. My summary slide, sir. Drugs level do not correlate well with level of immunosuppression in an individual patient, but may predict the adverse effects very well. Hence, CNI minimization should be attempted in all transplanted patients. Early on after transplant and in presence of graft dysfunction, prefer chromatography technique for measuring tacrolimus. In my opinion, few years after transplant, level monitoring may be redundant. It may not be required at all, especially in low-risk patients. And please identify those who develop renal dysfunction or metabolic syndrome early and try to help them. Thank you. Thank you for your patient listening.
Thank you, Manav. That was a very crisp presentation on this very important subject. I'm sure the others will have something to ask. Dr. Vasudevan?
We proceed with the other presentations and then take the questions later in the interest of time.
I mean, what we can do is, because there are not interrelated, so we can have quick answers because it will be better. I mean, just you made a comment, and I thought it was very important, the point you made, that immune suppression versus drug monitoring, which is a very good point, and I strongly appreciate you for that, because immune suppression overall is something which, as a concept, should grow further. My point to you was that you did mention that after 3-4 years, what is the need of doing a drug level if the patient is stable? So I'll tell you why I like to do it still. A, that if I do a drug level, maybe in 6 months' time, once a while, it ensures that the patient is compliant. They sort of somehow get a hammering in their mind that we have to take this medicine because doctor is going to ask for a level at some stage. And at the back of my mind, I'm absolutely clear, as you mentioned, that if graft is normal, I'm not too much bothered. I may not even see that level much also. But it is just, strike to that person that, yes, I have to take on this drug for indefinite period, number 1. Number 2, that you did make a very strong comment that higher levels in the long run are associated with a risk of higher complications. Perhaps, unknowingly, if somebody is having a stable graft function, but is unnecessarily being on, 8, 10 TAC level, which we don't know, probably it might help me to, reduce his dosages in the long run. So they're the two reasons I thought I should just share, if that makes sense.
I completely agree with your first point, sir. It does help in compliance. The second point, usually by the end of first year, you already have made sure that his levels are very low. So I'm talking about years after transplant. So you already know that you're trying to maintain a level of 2. It's unlikely that it will go up to 8 and 10 on the same dosage. But yes, your point is right. Well taken, sir.
Subhash?
Yeah, Manav, very nice talk as usual. But I have some, we've completely ignored cyclosporin, which is nowadays we find we use it quite often, because your sick patients and encephalopathy is there. And, we find that tacrolimus does cause neurotoxicity much more than ever. The point that I was actually wanting to make was with cyclosporin, we used to use to get efficacy of C2 levels. Because C2 levels correlated with prevention of rejection, whereas C0 levels, the trough levels, correlated with toxicity. And similarly for tacrolimus, I think the peak level may be important to prevent rejection rather than trough levels, which correlate with sort of adverse events.
So please. Sorry.
Yeah.
So that's a very valid point you are raising, sir. Absolutely agree with you. Cyclosporin, whatever I've talked about, tacrolimus applies to cyclosporin. The concept of trough levels and peak levels, we presume, that's what I'm saying. So you cannot burden your patient with too many levels again and again. Secondly, we presume that if somebody who has a very high trough level is likely to have a very even higher peak level. Although they are not, they are independent of each other, I agree with you, but none of us does C2 levels these days. We are not using much cyclosporin. Even when we are using, we are not.
Yeah, but when they compared efficacy of tacrolimus, cyclosporin with tacrolimus, when they looked at C2 levels, then the efficacy was similar. Anyway, but that's something that we are using a lot of cyclosporin for various reasons nowadays. I think, I'm sure you do as well. It's not as a drug to be sort of completely thrown away. It has its place.
It has usages. It has its own benefits.
I mean, one use where you can get red cell aplasia with tacrolimus, and then you're forced to use cyclosporin. There's no choice.
That happens 1 in 1,000. But I agree with you. It has its own usages.
Thank you, Subhash, and thanks, Manav. I think we have to proceed for the next lecture. Thanks. And for this, may I ask Dr. Shweta, invite Dr. Shweta Singh to please introduce the next speaker for the next talk.
I'd like to invite Dr. Sunil Taneja, Associate Professor at PGI Chandigarh Department of Hepatology, to talk about NASH after liver transplant and its impact, the impact of immunosuppression and NASH after liver transplant. Sunil, over to you.
Good evening, and thank you, ma'am, for the introduction. And at the outset, I would like to thank Dr. Saigal for giving me this opportunity. Are my slides visible?
Yeah.
Yes, they're very visible.
Okay, so my job here is to talk about NASH after liver transplant, and my particular focus will be on the impact of immunosuppression on NASH after transplant. And over the next 15 minutes, I will be discussing about the role of immunosuppression on increasing NASH after transplant, metabolic syndrome after transplant, and how do you diagnose and manage these patients post-transplant. So we all know that NASH is thus becoming the most common indication for liver transplant. And if you look at this data from US, it's the second most common indication for liver transplant right now after alcohol. And by 2030, it's going to be the leading indication for transplant world over. And this is obviously worrisome, and we need to take all measures to control this epidemic of fatty liver disease. So let us look at the metabolic syndrome before and after transplant. And if you look at this area, you have diabetes and hypertension in around 10 to 15% of patients before transplant. Dyslipidemia is seen in around 20%, obesity in around 15 to 40% world over, and metabolic syndrome is usually diagnosed in around 5 to 30% of patients. And this is primarily seen in patients who have NASH as the etiology of liver disease, followed by hepatitis C and alcoholic liver disease. And what happens after transplant, you see it becomes double. In fact, diabetes and hypertension is seen in around 30 to 70% of the patients. Dyslipidemia is seen in around, again, 50 to 70%, and metabolic syndrome is seen in around 60% of the patients. So if you have metabolic syndrome before transplant, after transplant, this risk doubles, and you will have more complications related to metabolic syndrome post-transplant. So why do you really have this metabolic syndrome after transplant? Around 30 to 70% of the patients become obese or overweight after transplant. Obviously, this is because of the reversal of the catabolic state, because pre-transplant, most of the patients are sarcopenic, frail, and subsequent to transplant, they tend to improve. We use a lot of immunosuppression in our patients, and this obviously leads to metabolic syndrome, which I will discuss in my subsequent slides. And obviously, the physician also feels that the patient is gaining weight, and this is a good sign after transplant, and we are not really looking at the complications which they develop post-transplant of the metabolic syndrome. So two definitions which I will be using in my subsequent slides are: one, what is recurrent NASH? Recurrent NASH is recurrence of NAFLD in patients in whom the primary indication for transplant was non-alcoholic fatty liver disease-related cirrhosis. And de novo NAFLD is defined as the occurrence of liver steatosis or steatohepatitis in transplant recipients after transplant for indications other than NAFLD, like alcohol and hepatitis C. So another thing which I want to emphasize here is that there are no histological features to differentiate recurrent from de novo NAFLD after transplant. And this distinction is primarily based on identification of the pre-existing metabolic parameters, like presence of diabetes, hypertension, and obesity pre-transplant. So let us look at the incidence and risk factors for NAFLD after transplant. And this is a systematic review and meta-analysis. 17 studies were included in this paper, around 2,300 patients. And in this 15 studies included retrospective analysis of the post-liver transplant liver biopsies. 2 studies used imaging for outcome assessment. Overall, 7 studies evaluated the occurrence of recurrent NAFLD or NASH. 3 evaluated de novo NASH and 7 evaluated both de novo and recurrent NASH. So let us look at the results. Look at the incidence rates. Recurrent NAFLD is seen in around 80% of the patients 5 years down the line. And de novo is also seen in around 78%. But if you look at the difference in recurrence of NASH, at 5 years, recurrent NASH is seen in around 38%, whereas it is 17% in de novo NASH. So obviously, presence of metabolic factors before transplant leads to early recurrence and higher degree of NASH after transplant. So what are the risk factors for post-liver transplant non-alcoholic fatty liver disease? Primarily, it is the metabolic parameters, presence of diabetes, dyslipidemia, and obesity. You can also have genetic predisposition. For example, if you have PNPLA3 GG genotype, you have a higher risk of developing allograft NAFLD or NASH after transplant. Obviously, there is a role of microbiome, which we all know. And then immunosuppression plays a definite role in development of post-transplant metabolic syndrome. And Hep C, alcohol, and NASH are other contributing factors leading to development of NASH or NAFLD post-transplant. So what is the effect of the immunosuppressive medication? Obviously, these all medications have deleterious effect on metabolic parameters. The worst of all is corticosteroids. It can cause obesity, impaired glucose tolerance, dyslipidemia, and hypertension. The CNIs are known to cause impaired glucose tolerance, dyslipidemia, and hypertension, and mTOR inhibitors likely cause dyslipidemia. And how do these medications cause this metabolic derangement? If you look at CNIs, it is primarily because of increased insulin resistance and decreased insulin secretion. They also decrease the bile acid synthesis, which leads to increased risk of dyslipidemia. Both cyclosporin and TAC are diabetogenic, and this happens by increasing the insulin resistance and inhibition of steroid metabolism in a dose-dependent manner. So if you're using higher doses of tacrolimus or CSA, there's a high risk of development of diabetes. This also causes decreased insulin secretion, which is due to direct beta cell toxicity via vacuolization and degranulation or through inhibition of transcription factors that modulate B cell growth. For example, apoptosis, if you have the secretory dysfunction, you block the GLUT pathway as well as switch over to the type 2 fibers in the muscle, which regulate the gluconeogenesis. And it seems that TAC appears to be more diabetogenic than cyclosporin. And this is a very nice systematic review, which showed that tacrolimus is superior to cyclosporine in terms of hypertension. However, the diabetogenic potential is much higher as compared to cyclosporine. So if you have patients who have a high risk for developing diabetes, it is always better to switch over to cyclosporine. And if the sugars are not getting controlled by this, cyclosporine would be a better drug to be used in such patients. So what are the risk factors for metabolic syndrome after liver transplantation? Whether cyclosporine or tacrolimus cause more of metabolic syndrome after transplant. This is a meta-analysis which showed that cyclosporine is not really associated with increased risk of metabolic syndrome as compared to tacrolimus, except in one study. Overall, there was no difference between tacrolimus or cyclosporine in the occurrence of metabolic syndrome post-transplant. So both of them can cause metabolic transplant post-transplant. None of the drugs fare better in causing metabolic syndrome post-transplant. A word about mTOR inhibitors. mTOR inhibitors are known to cause dyslipidemia, and they lead to elevated levels of triglycerides, LDL cholesterol, total cholesterol, as well as the small density LDL. And this is again because of the decreased bile acid synthesis, and there is increased free fatty acid pool and increased hepatic synthesis of triglycerides. Rapamycin also causes decreased fatty acid oxidation, leading to expansion of this free fatty acid pool. Obviously, these drugs are known to cause dyslipidemia, and let me show the comparison of CNI with mTOR inhibitors. So if you use CNIs, obviously the risk of dyslipidemia is there, but it is less as compared to the mTOR inhibitors. And all these studies show that the p-value is significant when you use everolimus or sirolimus, and dyslipidemia is more with these drugs as compared to the CNIs which are being used. So let's move on to corticosteroids. We all know that steroids are detrimental and they can cause obesity, induce glucose intolerance, hypertension, and hyperlipidemia. But the good point is that we have started rapidly weaning off steroids, and steroids are off in most of the patients by 3 to 6 months. So the rapid weaning of steroids limits the steroid side effects, and only indication which remains of using steroids is acute cellular rejection, where high dose is used. And this is also short term, and hence the long term effects of steroids are usually not seen now. So what is the impact of early corticosteroid withdrawal on graft survival in liver transplant recipients? This is an elegant paper of 330 patients, which showed that graft survival was significantly lower in the early steroid withdrawal group. And late steroid withdrawal group had a significantly high rate of early acute episodes of rejection. However, there was no difference with regard to new onset diabetes after transplant, hyperlipidemia, or cardiovascular events between groups. So that means that if you use steroids on long term, they might not be as detrimental as it has been really considered, because most of the time we are just using a small dose of steroids. And just look at this meta-analysis. This studied 7 studies, and that all of these studies reported that long-term use was not a risk factor for metabolic syndrome. And 5 studies were eligible for meta-analysis, which confirmed that the pooled OR of 0.74, suggesting that long-term steroid use in small doses really do not cause metabolic syndrome. So is it important to monitor recurrent or de novo NASH? There are no recommendations as such from any society at present. And there are no recommendations for monitoring of patients who do not have transplant and have NAFLD by other societies also. So there are studies where people have looked at a normal ALT and ultrasound, and if there is no steatosis on ultrasound and you have a normal ALT, there is a high chance that the patient will not develop NASH. So what else can be done to monitor patients with recurrent or de novo NASH? People have used MRI. MR elastography has a very high diagnostic accuracy for detection of advanced fibrosis. There are studies available in post-transplant patients. However, the limited availability of MRI and the high cost precludes its use in general practice. Transient elastography of FibroScan has also been used in non-transplant settings, but there is no established data from adults in liver transplant patients. There is some data from pediatric post-transplant population where it has shown a good sensitivity and specificity and a high positive predictive value and a negative predictive value in detecting allograft fibrosis. So this probably can be used as a modality for diagnosis of steatosis and fibrosis in patients post-transplant. So what are the implications of NASH? If you have recurrent or de novo allograft cytosis after transplant, are there any long-term outcomes? So very nice paper by Narayanan et al. With they showed that allograft cytosis was not associated with post liver transplant survival, nor any cardiovascular events. So if you have simple fatty liver, there is no harm which is done to the patient. However, NASH is associated with cardiovascular events, and overall survival is less if you have NASH developing after transplant. So let's look at this meta-analysis, a very nice meta-analysis published in Transplantation in 2019. They also showed that steatosis is not associated with poor post-liver transplant survival. And look at the fibrosis development after transplant in patients who have metabolic syndrome. If you have recurrent NASH, fibrosis develops in around 5 to 11% of patients. One study showed around 25% at 5 years. But in patients who have de novo NASH, only 2 to 10% of patients tend to develop advanced fibrosis. So suggesting that recurrent NASH is more risky, more dangerous, and tend to progress over a period of time. And the most important predictors of fibrosis in this meta-analysis were presence of obesity and dyslipidemias. Immunosuppression does not fare here. So that means using of immunosuppression does not lead to metabolic syndrome and its complications as such. So overall, the data suggests that non-alcoholic fatty liver disease is common after liver transplantation, uncommon cause of liver-related mortality or graft loss, and 5-year survival is excellent considering the low rates of NASH with progressive fibrosis. So progression to cirrhosis over a period of 5 years is quite less, and hence you can say that you have excellent survival if you transplant patients with NASH or metabolic syndrome, and even if you use immunosuppression in whatever way you want to use. So how do you manage post-transplant non-alcoholic fatty liver disease? Obviously, lifestyle modification is very important. We've been talking about weight loss, calorie restriction, exercise, and there is a role of coffee in prevention of development of fatty liver disease. You have to take care of comorbidities, hypertension, control of diabetes, dyslipidemia. People have also suggested bariatric surgery in selected patients where there is morbid obesity. And obviously, you need a multidisciplinary effort for this. You need to have physicians, endocrinologists, cardiologists to take care of all these complications. And we need to have tailored immunosuppression, as Dr. Rela spoke about this earlier today, that we need to quickly take off steroids, decrease CNI use, and may consider favoring everolimus, as everybody has suggested in the previous talks. So how do you manage post-transplant metabolic syndrome? How do you play with immunosuppression? Obviously, you need to reduce the CNIs and add mycophenolate mofetil. As Dr. Manav also suggested, that they tend to switch over to mycophenolate if you have post-transplant metabolic syndrome, and conversion of cyclosporine to tacrolimus if you have dyslipidemia as a major problem, because cyclosporine has little less side effect of dyslipidemia as compared to tacrolimus. The aim of diabetes control is to bring down the HbA1c to less than 7 by lifestyle changes and medications, preferably insulin or the use of metformin. And steroids should be avoided, or early taper of steroids should be considered, and switching from tacrolimus to cyclosporine if there is a poor glycemic control. For hypertension, you need to control the blood pressure and minimize the use of steroids and calcineurin inhibitors. So to summarize, recurrent and de novo NASH is common after liver transplantation. Immunosuppression may increase the frequency of hyperlipidemia, diabetes, and hypertension, and increase the risk of prevalence of metabolic syndrome. Corticosteroids are associated with increased rates of diabetes, hypertension, and hyperlipidemia in short term. However, long-term use is not being there for corticosteroids now, and hence these complications can be avoided. CNI and mTOR inhibitors also affect many parameters of metabolic syndrome to various degrees and contribute to long-term morbidity and transplantation. Hence, we should try and curtail the use of CNIs and cut down the doses and bring down to the minimum dose which is required to maintain good graft function. So before I conclude, let me just show you the research gaps which are there. We need to have elucidation of the natural history of recurrent and de novo NASH. Whatever data is available is short-term, and maximum data which is available is only up to 5 years. We need to have preventive and management strategies for the control of metabolic comorbidities, especially the pharmacotherapy for recurrent and de novo NASH. There is no established pharmacotherapy right now. and optimization of immunosuppression protocols, tailored immunosuppression as suggested by Professor Ed. Thank you very much.
Thank you, Manav, for an excellent talk. I'm sure we have a lot of questions, although we're running late. So,
I think, Sunil, that was a very good talk, very well summarized. I just wanted to make one point here. In fact, we had, like designed one NFLD guided INSL guidance document in which, you're probably also part of it. And I was supposed to be the captain of the so-called, post-liver transplant NFLD stroke NASH, and try to generate guidelines for recurrent and NASH. And we had a team, Dr. Manav and Dr. Neeraj, and we all were there. So I wish we are able to bring that out, because that's more towards our own patients in Indian perspective. And I think such efforts are really useful. And like you spoke today, brilliant, very good talk. And I think with Dr. S.P. Singh also being guiding, I think this post-transplant part of NASH is still unexplored. We still don't have any medications for post-liver transplant NASH. All the newer drugs are there, but I don't think there's any structured trial. And I'll be really, because I'd seen my OPD practice, patients coming up with, putting on weight, grade 2, grade 3 fatty liver on follow-up, some do biopsy and they have F2, F3. I mean, we're not sure we should use, the newer drugs, OCA and all. So I think that's something unexplored, and you have rightly pointed out the issues. Maybe comment from, Professor Mahmood, Professor Singh and others would be very useful.
Sunil, from your talk, it appeared that you are soft towards people with metabolic syndrome. Unlike patients who have alcoholic liver disease and who have transplantation, you are very strict with them. You must stop taking alcohol and all those things. Don't you think that similarly you should be tough with people who are obese, overweight, and who have NASH-related cirrhosis for whom transplant is done? And subsequently, if they again go back to their old ways,
I think I completely agree with you, sir. The issue is that most of the complications which tend to develop after transplant is one obviously related to immunosuppression. Post-transplant metabolic syndrome is going to happen. So tailored immunosuppression is now being used in most of the patients. So what we are trying to taper is we quickly taper the steroids. We try to bring down tacrolimus to a minimum dose. As Dr. Manav said, after 1 year, we tend to bring it to just one drug. So that is what is being done. Lifestyle modification is required for transplant patients, non-transplant patients, on everybody, I would say. There is no focus on preventing medicine in India at all. 50% of our people in India are having fatty liver disease, but there is no focus on prevention of fatty liver disease. So obviously, when these patients will go on to develop cirrhosis or decompensation and subsequently transplanted, their lifestyle is not going to change. So I think I completely agree that this should be the focus. But still now, preventive medicine has not evolved to an extent in India where we can take care of these complications.
Can you take some blame for that?
I think, sir, physicians are obviously there to blame for that, sir. So the kind of approach we have in our OPDs is giving pills to the patient. Okay, so this is because of whatever we have. We have so many patients, we have a kind of rush where we have to completely finish our OPDs. But then we need to have this preventive aspect, and these guidelines by the government, which has come up, the inclusion into this national program of NAFLD. I think this is going to help towards kind of lifestyle modification and bring down these complications.
Yeah, I lose a lot of my patients because I am tough with them regarding lifestyle modification. I tell them, if you're not going to change your lifestyle, if you're not going to abide by what you should be doing, then you better don't come to me. You can change a physician who
So I think it is very difficult to lose weight and maintain that, sir. Even if you tell them, they would do it for 3 to 6 months, but subsequently maintaining that weight is very difficult, pre or post transplant, whatever you say. So control of obesity is one of the most important factors which leads to development.
I will only agree partly with you, because see, it's a wholesome management. When you are trying to manage alcoholism in a patient, alcohol disorder in a patient who has alcoholic liver disease, you focus not only on the patient, also on the family. But in patients who have metabolic syndrome, who have obesity and other, I don't think you focus much on the family. Because I mean, they also contribute. They contribute a lot. Are they, Shweta, you have to, is Shweta there? Any further questions?
Yes, sir. There is a comment and there is a question from Dr. Chawla for Sunil. Sunil, he says, good talk. And he's asking, is there a role of budesonide in the management of prevention of NASH? Can we use budesonide early after transplant?
Sir, I think steroids are not being used much in transplant now. And even if you look at the doses which were used earlier and intra-op or immediately post-op period, we have really tapered the use of steroids. So maybe, if you really look at the literature now, or if you look at the experience in India, steroid taper is seen in all centers by 6 months. So hardly people are using steroids beyond 6 months unless there is acute rejection episodes. So maybe you can use if really required in patients of autoimmune hepatitis. Otherwise, I don't think so there's any indication to use budesonide as such. Dr. Saigal can add to this.
Yeah, I know. I agree with you, Sunil, that if there's a need to use steroids, that's the autoimmune group where the low dose is continued. Otherwise, we would like to taper it off in 3 to 6 months time in most.
And won't steroids, Dr. Saigal, anyways contribute to NASH?
Of course, yes. I think that if you are on long-term steroids, we know they put on weight, they have dyslipidemia, they have impaired glucose tolerance, no question about that. So I think that if there is no need, then one should, get away from steroids in these transplant patients.
I think Sunil has addressed that issue also very nicely in his talk.
Yeah.
So I think we need to now move on to the next session, and may I ask Professor Mamoon Mahtab to invite the next speaker.
Thank you very much. It is now my pleasure to invite Professor Subhash Gupta, who is the chairman of Center for Liver and Biliary Sciences at MAMS Healthcare, New Delhi, and he'll be presenting the LTSI guideline for liver transplantation during COVID-19 pandemic. Professor Subhash Gupta, please.
I hope I can share my screen. Let's see whether share screen. Yeah. Can you see my slides?
Not yet, sir.
Can I see my slides?
Yes, sir. So
Yes, sir, we can see your slides now.
So it seems I'm the last man standing. Even one of the chairpersons seems to be driving off from the meeting. But anyway, I will try and cover this as quickly as possible, not keep away from your dinner
No,
time
sir,
engagement.
you have all the time.
I'll not keep you away from your dinner. So when we were framing this guidelines, and that was sort of towards the end of the second peak, we thought maybe, we've seen the end of it, and thank God for it. But of course, we now have Omicron. So these guidelines, again, very relevant. And what it seems now that even those who've had infection or have vaccine, unless they have had Pfizer or Moderna, they're likely to get infected by this new variant. And therefore, these sort of guidelines will continue to remain relevant even now. So this was designed to keep in mind that there would be further surges in infection. So the beginning of the pandemic, liver transplant activity came to a halt. And, in fact, NATO stopped cadaveric donation as well, which was, quite disturbing because there were many obviously sick patients, and you have COVID, and at that time, of course, we all felt that COVID was a time limited thing and would just go. But obviously, it's now going to stay with us for a long, long time. And therefore, that was the idea of having some guidelines as not to deny sort of life-saving procedures to people who need the transplant. So liver transplant is a life-saving procedure like kidney transplantation, where you have dialysis, but at the same time, we should not compromise recipient outcome. We cannot prevent, particularly in living-related programs, donor infection. And of course, liver transplant activity requires huge number of healthcare workers, and they must also be protected. So the methodology used for these guidelines were that first a questionnaire was made and circulated within the LTSI group. And then separate opinion was taken from high volume centers within the country. And we included a number of infectious disease specialists, and we also looked at what had been published. And the questions were about 16 questions, and I've listed them here, but I'll be discussing each one of them separately, so I won't go into them right now. So these are the questions that were framed, for which opinion was sought and for which guidelines were laid down. So as far as liver transplants were concerned, the indications were concerned that at the time of surge, reduced activity, very common sense thing, but very relevant. MEL score it was suggested in the guidelines to be used to prioritize in case of diseased donor liver transplantation, and living donor transplantation mainly for ACLF, acute liver failure, and HCC. And we've seen a surge in ACLF mainly because of during the pandemic, there's been a sort of overuse of alcohol. In fact, Hepatology had an article on that the pandemic as the fuel and therefore the surge in alcoholic liver disease. And also we said that patients who had recovered from SBP who have recurrent encephalopathy should also have expeditious transplantation. So this is very common sensing that was picked up from Journal of Clinical and Experimental Hepatology, and those people who had acute liver failure, SBP, hepatorenal syndrome should be prioritized to have transplant quickly. This was the urgent group, and there was a semi-urgent group where with hepatocellular carcinoma, which could not be managed by local regional therapy. So the second question to the society and the members were, what about liver transplant for acute liver failure? Particularly because we're getting patients who would, with acute liver failure, who would test positive for COVID, what do you do? I mean, in no other practice, say someone has gangrene of the intestine and he's also COVID positive, can you deny them surgery? Similarly, if an ALF patient tested positive for COVID, transplant should not be denied. But of course, opinion from should be seen to make sure that they don't have just simple COVID sort of on blood testing, but they don't actually have the COVID disease with inflammatory markers, chest signs, and help from ID specialists was essential. All donors may have been similarly exposed because in our country, recipients and donors are related. And sure, if the donor tests positive, then that had a different connotation. And of course, because in ALF, we cannot wait long. So we said the group decided that 48-hour interval was enough to repeat the test. And in case we needed to do it, then full precaution must be taken with the team so that the ALF patient is not denied liver transplantation. What about disease donors? In case of the donor test positive for COVID, obviously donation should not proceed. This is what the group felt. But since then, there have been many reports from abroad where donors have tested positive and they've gone ahead with transplantation. But our group felt that if our donor tests positive, then we should not proceed. So abroad, I think certainly lung transplant, then they would not go ahead. But liver, there's not been a documented case of transmission from liver donation. So I think some countries in the West, would use donors with who have tested positive. And the complex perfusion, such as DCD and machine perfusion, should stay suspended till the positivity rate was less than 5%, which we thought we were getting there. But of course, with the new Omicron variant, we may again see a surge. So minimally invasive hepatectomy and other protocols, the group felt that they should be allowed to happen. Blood and blood products should be minimized, as donors should not be, healthy donors should not come to hospitals for donation. So it is judicious use of blood and blood products. Vaccination policy for patients who were with chronic liver disease should be vaccinated, as infection tends to be severe. And LTSI felt that the insistence for vaccination prior to transplant was not practical. Therefore, if possible, one could give it 3 weeks prior to recipient and donors, or maybe partly effective. Following transplantation, the group recommended that vaccination should be done 3 months after transplantation. What about antibody testing in recipients and donors? The group, the LTSI felt that does not recommend testing for antibodies, limited value, not indicative of immunity, and at best, if unvaccinated, may be a marker of previous infection. Post-transplant antibodies usually are not detectable even after vaccination. So then there was a question of when to test before the procedure. It was felt that it could not be like other surgery, that you could test it immediately before, because liver transplant requires arrangement of blood products and team, and therefore 72 hours was acceptable. Isolation following testing, and some within the sort of clinicians in the group, so they were somewhere from hospitals which required 2 mandatory tests. And in those situations, the LTSI felt that local protocols should be respected. And if the recipient tested positive between 3 weeks and 3 months prior to proposed date of transplant, there was no need for a repeat test. This is a very important point, because at that time what was happening was frequent tests were being asked to be done. But if they've been asymptomatic in the last 3 months after testing positive, then there was no need for repeat test. What about donors who tested positive? The group felt strongly that anyone who had moderate to severe disease should not donate, risk of pulmonary thromboembolism, lung fibrosis, and donors with asymptomatic to mild infection should not donate before 7 weeks. So this was the guideline, but also the group felt that in case of urgent situations, where there is a recent ASA guideline that suggested that 4-week gap may be appropriate, donor vaccination could happen 1 month after donation. What about donor and recipient testing post-surgery? Now, this was a controversial point, sort of difficult practice, because we were having liver transplant so resource intensive that we often had health workers and doctors coming and saying they've been exposed. So we needed guidelines so that people not taking time off just for the purpose of suspected exposure. So donor and recipient testing post-surgery, tests for 7 days if there was significant exposure, which was defined as without full mask, more than 15 minutes, and less than 2 meters distance. If symptomatic, of course, they needed to be tested immediately. And the donors test positive, may be important not to create undue alarm, because these are healthy fit donors who usually will have a mild course, and they should be moved to a designated area. However, decisions should not be left with the ID team there, because these donors are our complete responsibility. What about once they've recovered? What about shifting to non-COVID areas? ICMR guidelines suggest discharge if asymptomatic without repeat testing. However, if the recipient is not recovered from the operation, they could be moved to non-COVID area. And states like Kerala required a rapid antigen test at 10 days and 7 days before shifting. But there are clear directives from the state authorities. Obviously important to follow these guidelines, otherwise LTSI guidelines would be the norm. Now, as I said earlier, there were team members who were constantly sort of suggesting that they've been exposed. So all team members should be vaccinated, asymptomatic, and after low exposure, there's no need for testing. Non-vaccinated members should avoid high exposure. Full precaution should be taken when it is not clear about the COVID status of the patient. What about drug therapy? Because many of the drugs interact with the immunosuppressive medicines that we use. So azithromycin, if you're using that, CNI dose needed to be adjusted. IVIG and plasma therapy may have impact on graft function and should be monitored if they're going to be used. But of course, this subsequently we now know that plasma therapy has very little role in COVID infection. We used Keserimab and Imdivimab in one of our patients post-transplant who got sort of within 7 days who tested positive, and it really worked wonders, and therefore the society felt that it should be included as one of the guidelines. Immune resuscitation syndrome is known to happen when patients are recovering, and therefore you may have to bump up the dose of immunosuppression if you want to prevent rejection. MMF should not be stopped if the immunosuppressive protocol is low dose CNI with MMF. We also had difficulty in keeping these patients in ensuring that they are fully oxygenated. So prone position was okay after liver transplantation, and tracheostomy again could be carried out. And these are difficult maneuvers, but even with liver transplant would not result in graft twist and outflow obstruction, and they should be carried out when indicated. What about donors who turn positive after donation? Vaccination should be encouraged in donors. And if they test positive fever and respiratory symptoms, thorough examination should be done to rule out post-operative events. Abdominal contractions and pleural effusions may coexist and may be the cause of fever, and they should be managed. And the care of the donors must be jointly with the team and should not be left to the COVID team. The recipients who turn COVID positive after discharge, we must encourage all of them to get vaccinated. So now we know that none of the vaccines except Pfizer and Moderna prevent you from infection, but certainly they do prevent you from severe infection and must be encouraged to all transplant recipients. And if they need care, a member of IDE team should be contacted, ensure that they're looked after. Immunosuppressive medicine may be adjusted if they haven't been adjusted for a long time. If they're a year out, antimetabolites can be stopped. The use of monoclonal antibody should be considered and administered if eligible. They're freely available now. Treatment of blood pressure and diabetes should be rigorous. And in the end, the society felt that a mandatory COVID-19 consent was necessary. Should be aware, patients, families, donors, that it's a major procedure. The pandemic, there's a risk of contracting an infection, and a major surgery on those who have recovered or is currently not known. And there's a small but finite risk of major complications, and even mortality cannot be ruled out. It's particularly important for the donors to be cognizant of this possibility. So in the end, these guidelines are prepared by the LTSI executive and published in Journal of Clinical and Experimental Hepatology. So I'm grateful to the executive, Dr. Surendran, Neeraj, Anand, Subramaniam, Charles, Nemish, Dr. Varghese, Dr. Shweta, Dr. Metu, Vishwanathan, and the rest of the team, and Dr. Ravi for putting this together, and the entire LTSI members who looked at these guidelines carefully. Thank you for your attention.
Thank you, Professor Subhash Gupta. So, if there are any questions for the Professor Gupta, please. I don't see any questions in the chat box. If anyone present has any comments to make. I think, as usual, Professor Gupta spoke very nicely. All the queries have been sorted out. No queries for you.
I think everyone wants to get to their dinner time engagement.
So, in that case, I now invite Dr. K.R. Vasudevan, co-chair of this session, to wrap up the session with the concluding remarks, please.
I enjoyed and learned from all this through from 4 o'clock today. I'm sure everyone has. Thank you to all the speakers, and thank you for the opportunity to Dr. Gupta, Dr. Sanjiv Saigal, and the team. I hand over the proceedings to Dr. Sanjiv Saigal for the final words.
Thank you, Vasudevan. I will now invite Dr. Shekhar, who had been here for the last 2 days consistently with me, to propose a vote of thanks before we close. Dr. Shekhar, please.
Thank you, sir. I extend my gratitude to all the esteemed speakers, chairpersons, and panelists for the wonderful sessions and excellent discussion. And I'm very thankful to all the delegates for their active participation in making this virtual conference immensely successful. We have received more than 650 plus registrations. And I would like to congratulate Dr. Sanjiv Saigal, Dr. Subhash Gupta, Dr. Salin Agrawal, and everyone at CLVS Max Saket for such a wonderful job. And my special thanks to our organizing team from MAMS, especially Mr. Parag, Ms. Silpa, and all the background members of the team for their hard work and excellent job. Well done, team. And all the delegates can get their participant certificate from the event website, and also you can revisit all the sessions at YouTube channel of MAMS. Again, a big thank you to all, and good night.
So thank you, Shekhar, for those words. And just to mention that this was absolutely a delight and a dream to host a 2 days meeting on a topic which was, really initially thought that how can this can go on for such a long time. So this is really exciting, and I would share
that we are likely to actually bring out the proceedings, especially the talks, in an invited issue of the JCH as a guest issue. And I hope that works out well. And I would surely promise to you that we will continue to have more such interactions, more such meetings in future, and with the full support of everybody in the team. And I think it's really nice to see everybody sitting here, Dr. Gupta, with an excellent talk at the end, which was really nice. And I once again, thank each and every participant, the delegates, the faculty, the international faculty who stayed online for their answers during the question answer session, and the entire organizing team, which Dr. Shekhar has just mentioned. So, and also we will be having snippets of all these presentations in various formats in YouTube and otherwise, so that anybody who wishes to like go through and maybe go through some interesting talks can go through that and maybe share with others. Especially, it's really meant for the junior colleagues, the trainee and fellows and all, whom probably it will be more useful than anybody else. And it's a learning thing for me, and I have learned a lot during the entire meeting. I'm sure you would have also enjoyed the entire meeting. So thank you very much. Good night, and stay happy and healthy. Thank you very much. Bye-bye.
Bye.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir. Are you log out?